Started, and I want to welcome everybody this morning. I would say it was a lovely day out there, but it's cold and there's no sun, so that doesn't make me happy. But welcome everyone. As we, you'll notice that we're going to cram a lot in today, so trying to get things down to one day instead of 2-day meetings, so we'll get a lot in here. We're going to have a behavioral health funding update. Matthew Moore. Welcome, Matthew.
Thank you, Madam Chair, members of the committee. Matthew Moore, fiscal analyst with Legislative Research. I just wanted to provide you an update in regards to the mental health funding chart. Included in your material should be a legal-sized sheet of paper of what KDADS has provided me in their efforts to continue to update me on that breakdown of each line item by funding source. What they've included since last meeting is fiscal year 19. They've indicated that as they continue to look into and break out these line items, they'll continue to send me year by year as they receive it. So.
Committee, are there questions on the chart, or Senator Hawk? I'm glad you can read it because I'm like.
I'm just pretending that I can read it.
Oh, okay. Thank you. You make me feel better.
Thank you, Madam Chair. I should, again, one of these questions I should know. On the community crisis services, those are, I assume, are the crisis stabilization centers under mental health grants and contracts. It's my recollection that that's funded with lottery funds. How does that show? Is that show as a fee fund, or is it shown as state general fund as the money is transferred out of the lottery? How is that calculated?
So that line item, you're correct in that it is the crisis stabilization centers, and I think there's 4, and I think there's 5 or 2 more on the way. But they are funded in 2 ways: a direct SGF appropriation for Rainbow Services, and then Salina, Topeka, and Wichita. So when you look, and you see it particularly in 2021 and 22, that item, there is the SGF, those are the direct appropriations for those 4 centers, and then the fee funds are what that we receive from the lottery. So those are the direct transfers from the lottery vending revenue into a separate fee fund account for that is used for those centers.
Now, I know we have the 4 you mentioned. We also have one in Manhattan that I think was to be funded strictly with the lottery, but because the machines didn't come in and get installed, there was some grant funding. Are there others besides the 4 plus Manhattan?
I believe my understanding is that there is one on the way in Douglas County, and then I believe there is one planned for Leavenworth as well.
And then I guess my final question, Madam Chair, is we don't know how those lottery funds may come out, so I'm assuming that we would still fund those crisis stabilization centers, the one in Manhattan and the new one, if the fee funds were not available.
Actually, Senator, that would be a decision that Senate Ways and Means and Appropriations then would have to make. It's just like when the machines were delayed getting up and running, and the legislature made the decision to come in and supplant with SGF until the funds came in, then that would be a decision that would have to be made at that time. It wouldn't be an automatic.
So I need to be on my toes then.
Yeah.
Okay.
And I think also, if I recall correctly in those lottery, you'd think I would remember that. I think I should, Representative Ballard should recall it, because she's supposed to know everything. But we also, the clubhouse models are funded through the lottery. I think that's the 2, the crisis and the clubhouse.
Isn't it 75-25%?
That goes to the,
To those, they take the lottery funds and 75% goes to Am I right? 75% goes to the crisis and.
Madam Chair, yeah, that is correct. It is, it's 75 goes to the crisis, and then 25 goes to Clubhouse.
Yeah, and I think, and at some point, if we want to ask KDADs that, but right now, the lottery funds are doing well. The machines are actually exceeding what the projections were.
Just an opinion on my part, and I suspect one of the subcommittees, I just hope in our recommendations that we remain committed to the crisis stabilization centers. And I was just at a KHA meeting talking about one of the priorities they talked about last night was mental health. And again, looking at some kind of regionalization, and I think certainly the crisis stabilization centers move us in that direction. So I just sometimes get nervous that people's gambling habits may not always stay where they ought to be, but maybe it's a good time for gambling, and we'll keep our funds there. So thank you, Madam Chair.
Well, and I think you've got some very strong advocates in this room to see that happens, so. Representative Ballard and I took a lot of heat when we did that lottery vending machine money. Yeah, we didn't mind the heat. It was worthwhile, so. Any further questions, committee? Representative Arnberger.
Thank you, Madam Chair. Is it capped, though, the money coming in? Isn't it capped at, is it 4 million?
I'll have to double check. I think the total is 8 million, and it's 6 million for crisis and 2 million for Clubhouse.
And then does it sunset or no?
I don't believe so.
Okay, I just want to double check on that. Thank you.
Committee, are there further questions? Is there anyone online? All right, thank you. Nope.
I have a
Representative
last
Ballard.
I'm looking under the same thing for grants. Pardon me, I'm chewing, I'll stop. Housing programs. Would you explain that further?
There are several sort of housing programs that KDADS has that are related to assisting individuals with severe and persistent mental illness who are at risk at homelessness. For example, this last session, there was a Housing First program that was included as a supplemental that was approved. That item would show up in this housing program section, and I can certainly see what I can provide, a breakout of what those programs are. I know that there are maybe 2 or 3 of them that are specifically addressed to fighting homelessness.
Thank you. I would appreciate that because I was looking at it because part of the crisis centers is taking the heat off of the services we provide in the state, but the housing programs would be interesting because like in Lawrence, we have the crisis center coming, but we also have set up like 4 different, well, it's apartments kind of thing that would assist them if they come out of Osawatomie or some other place and they have to be at a place before they can find a home. And I'm just wondering, does that fit in that category?
I think there'll probably be a lot of discussion on the financing as you guys proceed forward in this next session.
Thank you, Madam Chair.
Further questions? Senator Hawk.
Thank you, Madam Chair. My apology for not noticing or knowing this already. On the statewide mobile response and mobilization, how is that different than the 988?
So my understanding is the statewide mobilization is, so 988 individuals call 988, and then the statewide mobilization is that sort of extra funding in case they need additional services. Those are for the uninsured individuals that might call the 988 number, need additional services, and then that funding would provide for that. There's also a little bit of that in our caseloads for individuals who might have Medicaid and need additional services. And then there's also the option of, if they have private insurance, they might get some private insurance paid. But that mobile response is that money that's set aside to pay for additional services for the uninsured.
And that doesn't go to
Senator,
local CMHS.
Okay, I'm just going to interrupt here just a moment because Matthew, I don't know that is exactly right. Representative Ballard and I are not recalling that. The only money that appropriations did was 3 million for the startup with the 988. I don't remember 5 million to have anything to do with the crisis, mobile crisis for
So-
the 988.
So, Madam Chair, that funding was included in the agency request that was a supplemental, and then it was approved by the governor, and so it was part of the governor's recommendation. It wasn't something that the agency, that the legislature added.
Yeah, let's just dive into that, I think, a little bit further, because I think Representative Ballard and I are a little confused on that there, so.
So
And
what-
you may be right, because we can be wrong every once in a while.
And so what I would point, right under that line item for statewide mobilization and response is the 988 programming. So that would be the $3 million that the legislature added. And I can certainly provide you a copy of my budget analysis from last year that kind of provides the detail of that statewide mobilization. But
Yeah, yeah, let's get more information on that. I think that'd be good for this committee to understand it too. Further questions? I'm sorry, I didn't mean to interrupt you. I just didn't want to go down a rabbit hole when we could stop it. So if you want to finish, go ahead, Senator.
No, anytime that I can confuse the chair and the ranking member, I really jump on that, so thank you. But you both know that I'm always the one that's initially confused, so glad to share that. Thank you.
Well, and Representative Ballard and I are fine with payback, just so you know that, Senator. Any further questions? Senator, or Representative Arnberger.
Thank you, Madam Chair. I'm looking at basically underneath the 988, the regional beds. If you look in the actual for fiscal year 20 in the federal, it says 39, but the rest of them have no federal dollars. What's up with that?
I would have to double check with the agency as to what the $39. I know it is a majority state general fund funded. They have a separate account for that, those beds, but I'd have to double check with the agency what that 39 was.
Okay, I just popped out like a sore thumb. Thank you.
Any further questions, committee, for Matthew? All right. Thank you very much, Matthew. We appreciate it. Thing is the funding mechanisms and everything on, especially in the area of social services, can get really, confusing, and sometimes we remember the right pieces and other times we don't. So we always appreciate our staff. Okay, committee, we are going to have a presentation from the Autism Task Force, and I have Nanette Perrin, Senior Director of Pathways.
Yes. Hi. Thank you, Madam Chair and members of the committee for allowing us to share an update on the Autism Task Team. I'm Nan Perrin, and I am the Senior Director of Pathways and Social Determinants of Health for Sunflower Health Plan, and I am a member of the Autism Task Team and co-chair with Kathy Keck, who will be jumping in about halfway through my presentation. So we'll do a little bit of back and forth in the presentation. But to give some background, Kansas is at a critical juncture with its autism services, including Medicaid state plan amendment services, often referred to as SPA, and home and community-based services, 1915C waiver services for children with autism. The waiver is currently beginning the 5-year renewal process with the federal agency, CMS, with a deadline for submitting waiver language to CMS for review and approval before the end of the current calendar year. The Kansas Department of Aging and Disability Services convened the Autism Task Team to develop recommendations for the Secretary for Aging and Disability Services on autism services in Kansas by asking how might we. The team is comprised of various professionals and those with lived experience. The Autism Task Force began meeting on August 31st, 2021, and has met 7 times thus far. The team has focused recommendations around the following topic areas: workforce, services, funding, and special populations. And that's to include children in foster care as one example of those special populations. The key individuals in foster care. The Kansas Health Institute, a nonpartisan and neutral educational organization, is providing administrative support and process facilitation services. The Autism Task Team will submit their final recommendations no later than January 31st, 2022. But we wanted to give you guys a little bit of a highlight as far as where our recommendations are currently going. Just to add a little information to the professionals and those with lived experience, we do have both parents as well as individuals with autism participating. And we also have a lot of individuals that were on the group that originally wrote the autism waiver. So just quite a bit of historical knowledge within that group, as well as current advocates. So some of the draft recommendations that we are looking at are looking at a children's waiver and a community living support waiver. So the IDD Modernization Task Force should explore initiatives to fully fund services that include removing or raising the age limit to 21 years, eliminate the waiting list, and coordinating the continuum of services across the lifespan. And really trying to look at a way to have the waiver not necessarily be siloed. Currently, there is not a waiting list for the autism waiver. There is a proposed waiver recipient list, but the autism waiver age maximum for entering is 6. The second recommendation that we've been talking about is expanding access via telehealth and reciprocity, and really looking at hoping to continue some of the flexibilities that started during the COVID pandemic regarding telehealth access and making sure that we're supporting rural and underserved areas. So now I'm going to pass it over to Kathy.
Kathy?
Good morning. Sorry, I was trying to unmute. I'm usually in person at these sort of events, so it's kind of weird to be on the screen. Hello, everybody. I'm Kathy Keck. As Nan says, I'm a co-chair of the Autism Task Force, and I'm also a parent of 5 kids, 3 that have significant disabilities, 1 that includes autism. And so the other recommendations that the task force have, again, these are draft recommendations, is individualized budget authority. And so the state of Kansas, in collaboration with stakeholders, would further develop systems that would allow for individualized budget authority based upon systems like the work, opportunities, reward, and also the self-determination program as it's done now through TARC, with an administrative cap for providers who do that service. Then the other recommendation is about incentivizing providers. The state of Kansas shall create incentives to provide autism services in rural and underserved communities, such as partial tuition reimbursement, vouchers to cover training costs, travel reimbursements, targeted free trainings and locations with few or no providers, and relocation packages to practice in the state under the contract for 2 years to 5 years based on the length of the training program. So really trying to get some incentives to our rural communities for providers to do some work in those areas to help support families. And some other broad topics of draft recommendations, we have a list here. So they include things like provider enrollment, expand access via telehealth and reciprocity, which Nan already talked about, the system-wide competency-based clinical training, early intervention autism diagnostic model, removing barriers in ABA and other EBP services, autism spectrum disorder interagency work group, increasing rates, funding, cultural and linguistical diversity for families. And then I'll let Nan go through the rest.
No problem. So additionally, discussion around a centralized reference resource and a systems navigator, continuum of care. So talking about supports both from outpatient level, but also into crisis. Discussion regarding an autism registry, ensuring access to state plan services, expanded access with early intervention, employment support, foster care autism support positions, and innovation and technology. So as you can tell, we have a lot of recommendations that will likely come out, but did want to give you guys a few more details about those first 4. So now we're happy to stand for questions if there's time.
Committee, questions? Senator Fag, excuse me.
Hey, thank you, Madam Chairman. I was wondering, when I seen autism registry, do we know how many people in Kansas have autism?
So that is actually, we can give some information in regards to, or we could get some information in regards to the number of members who are accessing autism services, but that goes back to, we did have an original task force multiple years back, 2007, I think. And it's really hard to get an accurate number in regards to the prevalence of autism.
Why would that be hard to get? Is it people don't want that information out, or?
So I think it's a little bit of a mixture. So some of it is, we can definitely get information on current diagnostics in regards to the primary diagnostic clinics are KU Med and Children's Mercy. And we can get the information on that. But when you look across the ages, autism can be diagnosed in early childhood, which is what we all encourage and hope. But there are individuals that get diagnosed later in life and don't necessarily have that information. For example, even individuals with individualized education plans through the local school district, they may have a designation of autism, but they may receive those services under other health impairment and not necessarily have that autism diagnosis. So it's just kind of a little bit of a difficult figure to get, if that makes sense.
Okay.
And so that's why they have talked about that autism registry, and it would obviously be voluntary, whether or not a family wanted their child or an adult wanted to be included on that registry, but just that opportunity to get a little bit more information on the prevalence.
Representing Ballard and then Senator Hawk.
Thank you for your presentation. I was just talking with the chairman a little bit, and we remember one of our former legislators from Johnson County really championed that many years ago, so it was pretty close to what you were talking about. But a similar question was asked many years ago when we were trying to decide how many we could appropriate for, a year. And they were saying that when some of the individuals are on the spectrum, and they may be very high functioning, but they have somewhat that a lot of times that's never recorded because they can perform just like anyone else. They have the symptoms, but they're very high and normally will have a high IQ, so that it's very misleading. So therefore parents choose, or when they get older, they don't even identify with that as well because of a stigma attached to it. So I don't know if that's the answer, but I remember that was a response that we received, and it made sense to me in a way. Thank you.
Senator Hawk.
Thank you, Madam Chair. Could you explain what individualized budget authority is and how that's different to whatever our current budget authority process is?
Yes.
And would it require more funding, or is it just a different accounting? I don't understand what individualized budget authority is.
Yeah, sure. I can take a stab at that, Nan, and then so individualized budget authority is basically it's the same pot of money the person would receive for the services, but they have a little bit more say in what services they get. So, maybe the funding for day and residential services or whatever the funding is for, they can, maybe they can determine how many hours, or maybe they have less hours they get, but they pay their attendants more in order to attract a more qualified person to help them. Or maybe they need assistance with some therapies that would improve their life that aren't typically covered. it could be equine therapy, chiropractic, anything. So they still stay within the same budget, but they use the money that best supports their needs and what they need in their life to accomplish things that for their life, basically. And do you have other take on that?
No, I think you answered that very well. It is the same amount of money, but it allows that opportunity for the family to direct the services within that. The work program, as we mentioned, is an example right now where Kansas utilizes that.
Would that require CMS approval to allow that?
It would be necessary to be included in the waiver amendment.
Okay. Thank you. Thank you, Madam Chair.
Committee, further questions? All right, seeing none, thank you very much for being with us here this morning. We appreciate this, and I think it's important for us to keep all of our different groups that are working on different areas to be on the same page and helping each other. So thank you very much. Okay, we're actually a little bit ahead of time, which is kind of nice. So, Carrie, Bruffett, would you guys be ready to go ahead and tee up? Who's online? Okay, welcome to committee, Carrie. And Carrie's with the Kansas Health Institute, and then virtual, we will have Hina Shaw, also with the Kansas Health Institute. So we'll let you lead us through this next group. I know that Will's on there. I did see Will.
Yeah, I saw Dr. Warren's. I'm not sure if I saw Kyle or not, but you all can tell me. Is Kyle Kessler also on the line?
Yes.
Awesome. And then we'll have some folks from the Telehealth working group too to present. So I'll actually leave most of the presentation to the chairs, the co-chairs of the various working groups who have met since our last meeting and have been meeting both in virtual meetings and also participating in surveys that are helping us prepare between meetings and for our next meetings. Each of the working groups will have a meeting on December 2nd to finalize some of the work that they're going to describe in a few minutes they've been working on, and also react to some of the responses to the surveys, which these surveys are being used to help select between alternative proposals that have been submitted, to help wordsmith a little bit. We'll do a little bit more of that wordsmithing on December 2nd. But the overviews that you'll get from the co-chairs will talk about the issues that the working groups have been looking at. And they have been focused on reviewing previous recommendations. And in the last meeting, you heard that work had started. So in the most recent meetings, they've really focused on finalizing what those options could be for revised language, but then really diving into the new topics or the expanded topics that you all asked the working groups to look at. And so I think they'll walk you through both today. I wanted to take 1 second, though, if you wouldn't mind, since we have a few minutes, hopefully we can do this. I wanted to ask you about format for the report. This sounds very technical, but wanted to get an idea of what would be most useful for you all as a special committee at the next meeting in December, as you're looking at the final recommendations from the working groups. So the updates this time are very similar to what you saw, the written updates, but they have the appearance of kind of a track changes model. They're not really track changes. We just put things in red and underline them. But we're sort of intending for the report that will be brought to the special committee to have an introduction, to have a table that sort of describes all of the recommendations from 2020, any revisions, and any new recommendations all together. So the report, the strategic framework, continues to live as that living document that last year's special committee was interested in. And then also have basically taking last year's report, and doing something like track changes. Again, it'll be sort of a pretend track changes, but something to indicate in last year's report where changes have been made. We talked about that at a high level in the first meeting, but we wanted to make sure before we started doing all that work in the report that makes sense for you all. So again, there would be a shorter version of a report that sort of summarizes everything that's been done this year. But then the last year's report, the 2020 report, would also be modified, and it'll get a new cover, and it'll be called 2021 or whatever needs to happen. But it'll still have all of the rest of the content. So just with modifications, sort of those track changes, and then additional description in the narrative. Remember, each of those recommendations has a box that sort of describes the recommendations from before. There'd be updates to the report background too for any recommendations that had been revised. So it's a little complicated maybe to describe and think about, but hopefully this gives you a little preview of the kind of, maybe one way that those recommendations, the revised recommendations, could be presented. The new recommendations will look like new recommendations presented with all of the background and the discussion that went on last year as well. So those would be in the section of the report that the topic area intends, but you'd identify new ones and then revisions. Thoughts about that? Is that what you all were thinking about? And I know this is kind of technical question, but generally we want to get some guidance before we move ahead too far with that approach.
Committee comments, questions? Yeah, I'm kind of a real visual type of a person, so I guess I need to bring up last year's report and kind of do a comparison on that, but.
Okay. So I think the idea, it would look a lot like last year's report. It would be last year's report, but with the revisions built in and then a new introduction that sort of would wrap around it. But we'll have something we can send around to the group maybe in advance, just so you could look at the next meeting, of the next special committee meeting, format-wise, so you can see what we're talking about and make sure we're on the same page before we show up in December.
Yeah, if you just take a section out of that, and then maybe you'll get it to us whenever you get it done and get it sent out to us so we can start kind of looking at it. I know Representative Ballard just said that she kind of likes that. Representative Ballard, go ahead.
Thank you, Madam Chair. I agree, because sometimes if we only put what we did now, they forget that we had Task Force 1.
Right.
And now it's Task Force 2, and that way they can see what we did in 1, how well we accomplished that, and now they can see 2, so they know it's ongoing. And I think it gives people a very clear understanding of what the committee was doing. So I like that as well, Madam Chair.
Well, because I think one of the things as we started this process last year was to hopefully allow every committee that goes forward to not have to rehash everything that's already been done. And that way, I think things expedite a whole lot faster, and it gives us a better opportunity to kind of modify things as we move along and not have to completely rebuild every single year, irregardless of who the members are on the committee. So any other comments, questions? No one online? All right.
All right. Well, with that, I will introduce the first co-chair of the, I think for each of the working groups, or at least for the first two, just have one co-chair each instead of them tag teaming, who will be presenting, but others are available online as well as other members of the working group if there's questions that are applicable to them. But first, I'll turn it over to Dr. Will Warrens, and you'll look at the Services and Workforce Working Group update.
Welcome to committee, Dr. Warrens.
Thank you, Madam Chair and members of the committee. Can you hear me all right?
Yes.
Okay, good. All right, so the Services and Workforce Working Group met on November 3rd to discuss our previous work. And I'm just going through the document that I believe you may have access to. But, the first topic we discussed was recommendation 1.2, access to psychiatry services. And this one I feel like we've pretty much wrapped up. So this was a study to be conducted by KDHE, and it was felt by the group that we needed to get more details regarding this study. And so we, with the help of other members of the work group, we have requested a legislative post audit to review the Kansas Behavioral Health recipients of the National Health Service Corps and the State Loan Repayment Program. Two big programs that are up and running that are already trying to work on this issue of workforce. We wanted to have a look back for the past 10 years. We wanted to review the professions awarded, so we're expanding this beyond psychiatry. This goes to social workers and other therapists, psychologists that are participating in these programs. We want to know about the communities in which those providers were located, the number of years they participated in the program, and then also and this is really kind of getting to, are these programs truly effective? the number of years they continue to practice in their position after they've exited the program, to see if we really are getting people in, spread throughout the state and then staying and continue to practice in those locations. We wanted to, in addition to that, we wanted to have this study review best practices from other states, targeting urban, rural, and frontier communities if possible, to get ideas of whether there's any opportunities for implementation in Kansas to address this issue. Dr. Rachel Brown down in Wichita is very aware of medical school and where these psychiatrists are being trained, and she wanted also included, I think it's a worthwhile suggestion, to look at where psychiatrists are being trained and how does that relate to where they eventually practice. I think with the point being of whether that should be promoted down the road as well as more residency slots in Kansas. Thinking if they train here, then they'll stay here. And then there was one other University of Kansas program that we want to look into. That's a program where medical students, if they promise to work within the state of Kansas in certain areas, then they will have financial assistance. And we want that program included as well, along with the National Health Service Corps and the State Loan Repayment Program. And so if there's no questions on that recommendation, and so that recommendation is pretty much getting pretty close to the way it's going to look.
So Dr. Warrens, so you're not finalized yet on exactly what you would want in that post audit, or is this the list that you're looking for in the post audit?
I'm pretty sure this is the list. I'll have to ask Carrie as well there, but I think this one's getting pretty close to the list we're going to be asking for.
Okay. Carrie Bruffett?
Carrie Bruffett with KHI. I forgot to introduce myself the first time. I would add on top of that one of the things that was discussed, Dr. Warrens, was potentially in the next meeting we'd talk about if there were members of the working group who might be able to assist with the development of a LPA request. So there may be some refining. The recommendation may list all those things, but we know that it sounded like the group understood the actual request, the LPA might be modified after discussion.
Okay, thank you. Further questions? Seeing none, thank you, Doctor.
Yes, and then recommendation 1.3, provider MAT, medication-assisted treatment for individuals suffering from substance use disorder symptoms. This one is still pretty early on. I know that Charlie Bartlett and Shane Hudson, my fellow co-chairs, have taken this and they are trying to map out some initial recommendations. There was talk about this recommendation and people were I think there was a focus on where the methadone clinics, how many we have and where they are in Kansas. That's a very important component. And then also buprenorphine prescribing amongst, around the state of Kansas. But Charlie Bartlett and Shane Hudson are both have extensive substance use disorder treatment history. And so I think they were taking that and they were going to revise that further and get some recommendations to the working group.
So, Dr. Warrens, are we having issues with our MCOs on this at this time, or?
Well, I would say when it comes to the methadone clinics, there's just very few of them. There's very few of them in general, and then the ones that are working with Medicaid are much, much fewer yet. And so you're exactly right. I mean, I think the MCOs will need to be part of this recommendation and working with with the methadone clinics that haven't signed up with Medicaid to try to see, trying to increase network capacity.
I'm just thinking that we probably need to get with Chairman Hildebrand and perhaps make this a discussion at one of our CanCare Oversight Committee meetings. So if staff can help remind me to get with the senator, I'd appreciate it.
And
Any
would
further
that
comments? Pardon?
and sorry, Madam Chair, would that be appropriate for us to also put language in our recommendation regarding that? Because I know there's another recommendation coming up that we have that we're steering towards the Care Oversight Committee.
It might absolutely be so.
Okay, thank you.
Might absolutely, that didn't sound good, did it?
All right, so recommendation 3.4, community-based liaison, fund and improve resources for community-based liaison to facilitate a connection to treatment and support services upon reentry as a component of pre-release planning. So the working group discussed the following revision to this. There was some concerns that fee-for-service billing is not the most effective way to provide peer services due to low payment amounts. Now, the caveat to that is I do think that the CCBHC will improve that situation for CMHCs, or at least it should. But it was also brought up that peer support is provided outside of the CMHC system as well with SUD providers. And so there was talk about funding for grants to CMHCs and SUD providers to pay for FTEs for peer mentors and CPS positions. And I believe KDADS is reviewing this recommendation and identifying gaps not already addressed in the new CCBHC designation. So that's kind of a minor well, I don't know how minor it is, but that's one recommendation that on this previous recommendation. Recommendation 4.4, behavioral health prevention. There was some discussion on this topic that this recommendation was, it wasn't clear to me at least what the purpose of it was, but then it does turn out that KDADS is using this recommendation as purpose for some of its work that it is doing. And so we are probably going to leave this recommendation similar, but itemizing out some of the things that we want to call out that it is promoting for behavioral health prevention. There also was talk about increasing state funds for behavioral health prevention efforts to support additional evidence-based primary prevention and grant opportunities for community prevention activities.
Dr. Warrens, can you elaborate a little more detail? And if not today, that's fine, because everything's working as we go forward. Is what would the increase in funds actually go to and achieve? Number one. Number two, is workforce also an issue in this area?
Okay, absolutely. Absolutely, Madam Chair. We can take that back.
Okay.
So new expanded topics, proposed recommendation, fully fund a statewide psychiatric access program that includes linked specialty teams, psychiatrists, psychologists, therapists, resource specialists, patient and family advocates to provide multidisciplinary consultations to healthcare providers across the lifespan. And so I think some of this comes from what Medicare is working on to try to help increase the impact of the mental health professionals we do have in supporting primary care, in treating more mental health in the primary care clinic competently and with good support and consultation. Is what we were talking about there. Kids Map that we heard from Dr. Rachel Brown last time the full committee met, and she described their program down in Wichita is one program that we're holding out as a model for this, as well as Kansas Connecting Communities. It is noted that the funding for some of these programs for Kids Map in particular expires in 2023, and additional funding would be required for 2024 to either continue or expand the program. The working group did feel like since that program is up and running, established, it would be best to ensure continuation of those programs. And the discussion on this will continue at the next meeting. The next issue that was discussed, and here is what I was talking about, Madam Chair, about another issue to come to the Bethel Committee, was request the Bethel Committee review extending Medicaid postpartum coverage to 12 months postpartum. This supports access to behavioral health treatment and other preventive care. I think there is a consensus in the work group that this would be a positive impact. But obviously changes like this have more impacts than what we expect. And so the thought was to bring it to the King Care Oversight Committee for discussion.
Dr. Warren, we're currently at what, 6 months or 3 months? Do you know?
I'll have to ask Carrie for help on that.
Carrie, do you know the answer
If
to
she
that?
happens to know. I'm putting her on the spot a lot.
I think I turned it off. And I should defer also to the Medicaid agency, but I think it's 90 days postpartum right now. But please, if Sarah Furtick or someone else is on the line can correct me. There is a difference right now because of COVID-19 continuous enrollment. There's not disenrollment for folks, but that's regardless of eligibility, what eligibility category. So right now, there is continuous enrollment, but the typical policy, again, I think is 90 days.
Sarah Furtick, I believe you're with us online, our Medicaid director.
Yes, Madam Chair. And actually, we currently terminate coverage for women in the pregnant women eligibility group at 60 days postpartum.
I was either 60 or 90. Thank you,
Very
Sarah.
close, Carrie.
Okay, Sarah, let me ask you, does that actually end up being a hard 60? Because I know that when we talk about, cutting someone off, it doesn't exactly hit, if we say 60, 90, or 120, it doesn't actually do that. Would that be accurate to say that it could be longer than 60 days?
That's correct, Madam Chair. So because Kansas is in a managed care Medicaid environment, eligibility is month to month. So
Right.
if you somebody and their 60 days ends on the 15th of the month, we will go ahead and cover them through the end of the month. But pretty much the most it could ever be is maybe 90 days postpartum.
Okay, so then, in order to, if the legislature was to decide that they wanted to extend that, would we need an amendment to our plan?
Yes, we would, Madam Chair. And actually, the American Rescue Plan Act for the first time allows states to do that through a simple state plan amendment starting in April of 2022. So the state would need to submit a state plan amendment to make that change. And there would also be a fiscal impact as we discussed in the working group.
Okay, did you have a comment, Representative Ballard? All right, thank you very much, Sarah, appreciate that. Well, I guess another question, how does that deal with our budget neutrality issue?
Oh, I'm so glad you asked, Madam Chair. Thank you. It actually, according to our actuaries, it would actually slightly improve our budget neutrality situation, and that's because we are extending coverage for a longer period of time. So the average cost of coverage for that entire prenatal and postpartum period is stretched out over more months. So the actual per member per month cost would go down for that eligibility group.
Okay, and then do you have a fiscal yet for what this 12 months would be?
So the policy change would basically be to add 10 months additional coverage versus what we have now. And our actuaries have given us a range in all funds annual costs of between 9.9 million and 11.1. So 10.5 million is a midway point there. That's what we think the annual cost would be, all funds.
All funds. Do we know what that is in SGF?
Oh, boy. Well, it kind of depends on what the standard match is for. So if the public health emergency gets extended, 65% of that would be covered throughout the PHE by federal dollars. Typically, your standard match is about 60% federal.
Right. Okay. Thank you, Sarah.
You're welcome.
Back to you, Dr. Warren.
Okay, thank you, Madam Chair. Our next topic we talked about is trauma-informed care. I think the work group does feel like trauma-informed care is something that should be spread amongst all of our behavioral health providers in Kansas. And so the talk turned toward trauma-informed practices pilot, trauma-informed care training, and the development of trauma-informed communities. And that topic is currently out in surveys for prioritization and also to elaborate on these recommendations as we speak. And the co-chairs are going to be meeting to talk about that here in the next few days. So I think the purpose of it is trauma-informed care is not an evidence-based intervention, but it does have evidence supporting it as, for lack of a better word, maybe therapeutic stance of a center. The hope would be is that we get to a point where if someone has experienced trauma and they interact with any behavioral health provider around Kansas or walk into a behavioral health facility, that facility has been prepped in such a way that their trauma is not triggered in that interaction, which is, would make sense as far as helping increase the therapeutic benefit of that interaction.
Okay, so when you're talking about the pilots with select behavioral health providers, would that be with our CMHCs or also private individual providers out there? What was the thinking?
I don't think we've gotten to that level of detail.
Okay.
I mean, CMHCs, I think, will always be, a main portion of what we're talking about. But there are other, you're right, there are other providers out there. And so it could be with either, I guess, is what I would expect will come out of the group.
Well, and I would hope, and I'm almost sure that, some of this will get addressed as our CMHCs become CCBHCs. But it's definitely something to highlight, so I appreciate that. Are there other questions or comments? Seeing none, proceed.
Okay, so here's another recommendation that's getting very close to the finish line, supporting the Kansas State Suicide Prevention Plan. So we had a topic of suicide prevention, and fortunately, there's been a lot of work that's been done on this in the state of Kansas with the development of the State Suicide Prevention Plan and the creation of the Suicide Prevention Coalition. After reviewing the State Suicide Prevention Plan, we felt two recommendations could be made to help boost the plan forward. And the first one is in support of recommendation 4.1.1 of the State Suicide Plan. And that is working on improving the data that the lead agency and the coalition will be able to work with in Kansas. And that is standardizing definitions, ensuring consistent data across the state in regards to suicide, making suicide a reportable condition, and also looking to try to collect enough demographics on those incidents that we could analyze to see if there are special populations within our state that might not be adequately treated at this time or might be disproportionately affected by suicide within the state of Kansas. And we've talked about that before as far as last committee meeting, as far as that can be things we've talked about before as far as race, sex, age, things like that. But it also can be things like occupation and geography and where someone lives. And so that was one recommendation we thought, getting better data. And then in support of recommendation 4.2.3 is to designate KDADS as the lead agency for the implementation of the state suicide prevention plan, and then using funds to help support the scaffolding of the infrastructure of this plan, including a full-time suicide prevention coordinator, grant opportunities for local communities, and implementing a statewide media campaign. And we did have some input from our friends at the state in our work group to help get some details on this recommendation. We also wanted to require, since we're going to be working on it now, formalizing it, to have a requirement that KDAD submit an annual report on the progress to the State Suicide Prevention Plan, to the Governor's Behavioral Health Services Planning Council and its Prevention Subcommittee. So this isn't all inclusive of what can be done as far as suicide prevention, obviously broad topic, but we thought that this would dial it down to what could give a boost at this time to get things rolling.
Well, and I think that one of the things that, there's a lot of decisions to make, and then just in that one recommendation, that's pretty extensive. So I guess my recommendation to the working group going forward is a better explanation as to why KDADS as the lead agency, and I'm not saying it's the wrong one, but just for all of us to have a better understanding of that. Exactly what the 1.5 million would be spent on. And I think that any time that we do, data collection is having a consistency. So if the committee members have recommendations, what would that data look like? What is important data in that? Because you can collect a lot of data, but if it's not usable or actually targeting what we're trying to get, then we lose in the outcome. And, that's just been a very important piece of what we did with the mental health K-12 program was, keeping that data consistent and narrowing it down to, I think we're at 10 or 11 items so that we have a history as we move forward. And then on a full-time state suicide prevention coordinator, you may want to also look at maybe having someone from the Attorney General's office visit with you all, because I know that they've got a department over there now, and one of the things I'd like to see us do as we move forward as a state is to try to unduplicate services so that we have one person doing, all of that, irregardless of where they're set at. I don't care about that, but try to reduce the duplication, and then we may free up someone that could be doing something that would be more important down another path. So that would be my recommendation. And on the annual report is the simpler that we can make these reports, the more often that they're going to get read. Sometimes if you're sitting there and you're just looking paragraph after paragraph, I like the ideas when I'm looking at what we've got right here, having points. And then if you want more details, you can have a link to go into that. But this here kind of hits the highlights. So, committee, are there other comments, questions? Representative Lynn.
Thank you, Madam Chair. I think I would like to also see more private partnerships, because I know we already have like the Seize the Awkward campaign, and I know there are others out there that we can maybe work with and probably hopefully get some of this data already.
And hope to get what?
Well, the data that they're looking for, that maybe we can see how that money is spent, what kind of data they're getting from this campaign that they're already doing.
Okay.
Thank you.
Other comments? Senator Hawk.
Thank you, Madam Chair. I wanted to add a ditto to your comments about the AG office. I think it's great we have the social media program and the KDADS, but I totally agree that in a way that really seems to me to be duplication, and we either need to recommend something that really coordinates it well or figure out a way to put it either in KDADS or the AG office. And so I don't want that to go unnoticed. And if we can get this working group to figure out how to solve that problem, that'd be great.
Well, I would suggest you be thinking of that when we put this big report together.
Gotcha. Thank you, Madam Chair.
Because it takes a lot of teamwork to make all this happen. Are there any further comments or questions?
Representative Landwehr, I have a comment. This is Jane Adams.
Yes, Jane.
We worked yesterday on the Suicide Prevention Coalition met, and we talked at length about how to make a concerted effort to involve in several layers of ways the people who, I'm going to say the word consumers, but people who have either attempted suicide or who have are survivors or their family members. And so we are meeting, and we talked about working more in depth with the consumer organizations, like the adult consumer organization, like the NAMI, Kansas, and Keys for Networking, so that we're in touch with, are the people we're designing this for, is this what they see is what they need? Is it helpful to them? And so we're looking at front-end input, increasing the membership of active people on our meetings, and also looking at feedback after we design something. And so we spent a long time talking about how to make sure what we're designing fits with what people in Kansas are saying they really need, the people who have direct experience, lived experience with this. So I just wanted to share that.
Well, and I think that's an excellent point. Representative Ballard.
Thank you, Madam Chair. Ms. Adams, I agree wholeheartedly. So, so often we put together programs that we think will be helpful for people without directly consulting the people that are needing those services, because often they know what's not being covered, but what they need. So, boy, kudos to you for that. And I hope we can incorporate all of that into our plan. And that makes it even more effective, and people have ownership for it because they were part of that decision-making process. So thank you.
Well, thank you.
Well,
It wasn't me. It was a lot of people really had this in-depth conversation about how to do this differently.
Man.
Representative Ballard.
Well, I understand it wasn't just you, but you're sharing that information, and you can go back and say that that was a very wise conversation to be having, especially if we want this program to be effective. So thank you, Madam Chair.
Well, and I think that needs to be an integral part of the report that we talk about, is making sure that any groups that we have that can be an asset on the consumer side needs to be involved in these. And, maybe we need to start gathering a list of the different groups that we do have out there so that we make sure that those are the experts that we're also talking with. Representative Arnberger.
Thank you, Madam Chair. My question is for the revisers. Underneath the Attorney General for the Youth Suicide Prevention, isn't that written in statute that they must provide, is it an app, the service? I know that when we talked about funding a couple of years ago in the budget, they brought it up, but I wasn't sure on if it's actually written in statute or they were just wanting to utilize that service. Okay, thank you. And I'm also kind of curious too with KDADs, is it also written in statute that they provide the same service? I'm just curious if if we can combine, if we need to change some legislation for that.
Okay, so Revisor Abbott will check into that and then be able to get back to us on it. May not be today, but he's usually pretty fast. But if not, it's something that can be sent out to us, and then I would make sure also that the working group has that information as well. Scott. Okay. You want to proceed, Doctor?
Yes, I guess just one follow-up comment with Representative Ballard and Lynn and Dr. Adams is, I think one reason why we haven't focused on more language about the private partnerships, it kind of goes in the same category as, talking about reducing access to lethal means and a whole bunch of other topics. But I think we found a lot of that language already in the Kansas State suicide prevention plan. And so we didn't want to get too prescriptive in our recommendations. And we felt like we were seeing that language already present in the suicide prevention plan. So I think that's why we haven't called out. I mean, great ideas, great topics, all of them, but we wanted to let the coalition and the agency, have freedom to move forward in the way they best saw fit, if that makes sense.
Well, it does, and so maybe rather than, taking that out into the details, is that you definitely make reference to where that can be found and why you didn't take it into that. I think that'd be a good point to do.
Okay, absolutely.
Yeah, the more that we can bring together, and this is what I've just been so thrilled with the work that our working groups have done the last couple of years. The more that we can bring into this report, whether it's details of something or provides a hyperlink, and that's why reviewing this report online is so important. A hyperlink to, we don't have the details here basically, but here's where it's at. We recognized it, we saw it, but we're just not going to duplicate it in this report when you can read it over here. And then that also makes people aware of what else is out there to look at besides just one place. So we're trying to be that one-stop shop report on everything mental health in Kansas. So thank you for that. So
Okay,
are there further? Go ahead.
Sorry.
No, you're
The next
fine. Go
topic
ahead.
was the autism waiver, and so we were listening very attentively to the autism task team report today. We may have to have more interactions with the autism task team to get some even more detailed previews of what they're looking at, because their report won't be finalized till January, but we're working on a little different timeline. So that'll be a recommendation yet to come.
Okay, questions, comments, committee? Representative Lynn.
Thank you, Madam Chair. I have a question regarding a previous topic, if I may. And I think it's meant more for Sarah Fertig. I have a question about the 12 months postpartum care. Women who have miscarriages or stillborn, how are they included in this?
They would be included in that, Representative Lynn. And Madam Chair, the way it currently works in our eligibility system, when we have somebody who qualifies for eligibility because they are a pregnant woman, we have an anticipated delivery date that's entered into the system. And so if we discover that the individual has miscarried, then the same 60-day termination rule applies.
Okay, thank you. So they're part of the 60 days, and then they would also be included if we were to extend it to 12 months.
That's right, Representative Lynn.
Okay, thank you, Madam Chair.
Okay, and I just had staff remind me that at our last meeting that we did have a memo from the AG that we'll make sure that the working group members have a copy of that. Are there further questions or comments on this section? All right, proceed, Doctor.
Okay, thank you, Madam Chair. So then we have our last two topics, social isolation and stigma. So conversation, and these are in their early stages of formulation. So as far as social isolation, treating social isolation similar to other public health issues. So disseminating or creating strategies to disseminate with the importance of social isolation through public service announcements, education with providers, development of screening tools that providers can use to try to detect when social isolation is becoming a problem with one of their patients. And then for each group, identifying primary places that are frequented and target strategies for each. And then also a public campaign to address social isolation. And then with stigma, promoting helplines and success stories. And then also there was some discussion about trying to eliminate the word stigma from the subject of stigma. Basically trying to move forward, creating a culture in which mention of depression, anxiety, post-trauma is as mentionable as diabetes, hypertension, and migraine. Some of the work group members felt like in their own work in mental health that when they bring up the word stigma, it feels like it's bringing down the conversation and regarding mental health, and then so trying to eliminate that from the conversation. So very early on those subjects. And those subjects are also out there in surveys and for interaction with the work group in between meetings. And the results of those are coming in as we speak.
All right, thank you. Questions or comments? All right, seeing none. You got this. This is a pretty impressive report, and we're getting more now into what I refer to as the weeds, because we did a lot of big lifting last year, and this year it's now coming in and kind of fine tuning and coming into detail. So I'm really impressed with this. Carrie, did you have any further on this or?
Oh, no, I was just going to hand it over to Kyle, but you can do that.
All right. Thank you very much, doctors, and we appreciate the work of this working group. So, all right. Next, we have Kyle Kessler, System Capacity and Transformation Working Group.
Good morning, Madam Chair, members of the committee. I'm Kyle Kessler with the Association of Community Mental Health Centers of Kansas. Can you hear me all right?
We've got you.
Great. And it's been a privilege to co-chair the System Capacity and Transformation Working Group. We had meetings on November 1st and November 11th, and I will be pretty quick with my updates, but part of it is the merger of 2.2 and 2.2 addressing inpatient capacity, and 9.1 the regional model. We reported that last time, and we had some additional discussion on that at our most recent meeting. And it has been historically, and going back to several the legislative mental health task force from, I think, 2018 and 19, or 2019 and 20, talking about South Central Kansas specifically. And certainly there are still gaps there, like there are in other parts of the state, but there now are more resources in Wichita than there have been probably in about my 20 years around this issue. And so there are the additional conversation we had was to do ongoing analysis that should be conducted to identify geographic areas of need and gaps in levels of care. So that may be a little more generalized of a recommendation going forward, but it certainly doesn't mean that a potential regional facility in Wichita wouldn't be well worth pursuing. On recommendation 2.3, reimbursement rate increases in review, the only change to that was to add it for all providers, the 10 to 15% reimbursement rate, all providers of behavioral health services rather. And then as we go into recommendation 4.1, the 988 suicide prevention lifeline funding, the working group had a lot of discussion about funding streams and decided to return to the issue for further discussion in one of our upcoming meetings. I know you all talked some about 988 and the 3 million versus the 5 million, and KDADs and others can certainly dive into that more. But just as a side note, I believe that the $5 million number as it related to crisis intervention was part of the pre-settlement with the Disability Rights Center by KDADs to try and do more adult mobile crisis response work. So that is separate from 988, and the 3 million was what helped get that up and running, and the sustained funding is what we're hoping to see down the road for additional 988 work, if that makes sense.
But it does.
Okay, very good. And
Okay. Kyle, I think what we'll do is let's see if we've got any questions on what you've covered so far, if that's
Okay.
all right.
Sure.
As we go through, are there questions? Representative Arnberger?
Thank you, Madam Chair. Kyle, did your guys' working group discuss the bill that we discussed in health this year on the House side on the 50-cent tax? Did you guys discuss that and the revenue source coming in, so forth, and how that 25 million or whatever was discussed would be utilized?
Yeah, so several different crisis service arrays, and Senator Hawk may have some thoughts on this as well. And we talked about whether or not it would be worth looking at lowering a recommendation or keeping it the same. So that's what we're going to go back to in subsequent meeting.
Senator Hawk.
Thank you, Madam Chair. I did have a chance to talk with one of the telecom providers, and I surmise there's some difference of opinions from those who would be collecting that 50 cents. And I had a lower number thrown at me, wondering if Ways and Means might consider something that might be more agreeable to the telecom companies. And so I suggested that our group talk about maybe there ought to be a range of recommendations that might be a lower amount plus what the state general fund could be to fill that, and then we could hash that out like we usually do on in the committees, or heaven forbid on the floor with amendments.
Well, hopefully we can do it in the committee process. I can tell you, Senator, that I did have 2 of the 3 major telecoms reach out to me after the session, and we have had discussions. We've got one that is just not wanting to budge. which is very discouraging to me. And it's not a hard 50 cents. That was kind of our starting point. So we do have some flexibility. And I believe that staff has been gathering where we're at across the country, what some of the other states have done, because last year when we brought up the bill, I think we'd only had 2 states that had even taken action on them. And that was one of the comments from the telecoms, is that they wanted to know what other states were doing. And my comment back to them was, are you saying Kansas can't lead? I didn't like that response of, let's see what the other guys are doing, because I think that we can lead. And so it's not saying that it has to be at that 50 cents. We just need to know what that amount's going to be, and we will have detailed information on how that money will be spent. And that has been all along, almost a line item sheet that we've been working with. And Andy Brown with KDADS has been excellent with providing that information. Go ahead.
No, the only other thing I wanted to add to that is, but I suspect with some of the federal dollars we have coming, wanting to expand broadband and looking at KUSF, those are always interesting discussions in our utilities committee. And I think all of that has to fit together, because we need broadband expansion. I think the suicide prevention is an important thing. And then we have to look at what's the mix of funding that we want to have, from KUSF to State General Fund to ARPA dollars and our discretionary funds that we're looking at now, and now the new federal infrastructure money. So it's a complex but exciting time with some great opportunities, I think.
Well, and it's important for people to understand that the expectations from the federal government with the 988 legislation is that anyone that calls 988, we have to provide services for. It's not up for discussion. It's not that we will find them, we will look for them. We have to be able to provide services. Another part of that 988 funding is follow-up has to be done on each individual that has contacted the 988 to find out, did they get services? Was there a problem? If there was a problem, then part of their job is to get it to the right people to fix it. So it's kind of a expansion, and Kyle can correct me if I'm wrong, because he's been involved in these discussions for a long time, is to enhance what we're doing in the area of mental health along with our CCBHCs. Representing Neighbor.
Thank you, Madam Chair. I do remember in our conversation, too, when we were looking at rates, and Kyle, or Senator, you can correct me, that there was some discussion on should we be setting that rate, because nobody had an idea at that point, and that's why we, I don't want to say kicked it down to the next meeting, but there was some discussion on, are we the proper people to set that amount?
You mean the 50 cents?
Yeah.
Well, the reason that we felt that we were is we have to be able to pay for these services somehow. And we know that right now, the current services that we have would not be able to handle that 988. So that's why we decided it was something for us to set. And I know that there was there was a lot of heartburn, and unfortunately in this process here, there were people from the Utilities Committee that were upset because they felt like it should have gone through Utilities. It actually went through the Health Committee on the House side of things. And so we had to work through that part of it. We had to work through people having misconceptions, especially with our telecoms, on what was the language from the feds. And we have looked at that every which way from Sunday, and it's pretty explicit that we have to take them and be able to provide those services. I found it interesting, some of the people that were really opposing this were also members of the utilities committees that had no problem in 2019 passing a 41-cent increase on everyone's phones for nothing to do with services, but infrastructure stuff for 911. Passed that 41 cents, no big deal. Everybody was all tickled with it. And the comment that came back to me, Representative, was, well, it was higher before we got down to 41 cents. And I said, then I guess I should have started at $1 so I can get to 50 cents. But that's not what we did.
And
Andy, Andy Brown has, I mean, like I said, he has just been a rock star on this stuff, and we're trying to be as flexible as we can to be able to get the services, but we do have to put that amount in there so that we have a steady funding stream. The one thing that the Health Committee added to that was it would also include prepaids, which prepaid cell phones are also included in 911, whatever that charge that goes on our phone bill.
Well, I'm not saying we don't need an amount. I think our question was, should it be 50 cents? Should it be 45 cents? Should it be 40 cents? That kind of thing. So there wasn't a negativity about there had to be a charge. It's what the amount was. And so I think that's something I'm sure that will come. People will have points of view on that one. And I appreciate it, Madam Chair. Thank you.
It might be helpful is if the committee, Kyle, and I don't know if this has been handed out to those committee members, but there was a sheet that Andy Brown had worked up that showed this is how much money that 50 cents raises, and this is what we're going to fund with it. So for me, if I'm working that, then I'm going to say, okay, so what can we cut back on this line item, and then how do we bring that down below the 50-cent level? But I think that would be a good starting point. So Kyle, if the committee members don't have that, then that's the sheet that they need to get from Andy.
Okay.
Any further questions or comments on this section? All right, proceed.
Okay, recommendation 8.1 relating to correctional employees has to do with training staff on mental health to better recognize those with substance use disorders and use trauma-informed approach to identify other mental health needs and connect them with available services. One of the things that I've heard recently the Department of Corrections is looking at is providing mental health first aid to all correctional employees. I think this would be a great idea. And this is something that I know several of you in the room have championed that appropriation that for mental health first aid. And so to see it potentially used this way and for corrections to do some investment in this area, I think is very encouraging. So that's an additional piece of that recommendation. Recommendation 8.3 on law enforcement referrals. And this just adds a little bit of wording to the current recommendation, which is to increase utilization and development of evidence-based SUD referral, as well as treatment and recovery services among persons with law enforcement contact, which could include securing funding to increase access to inpatient, residential, and outpatient services for the population. So again, pretty straightforward.
Okay, Kyle,
Yes.
we'll just take questions as we go along with this. Do you feel that on this 8.3 that we can ease some of that if we are able to do the mobile crisis with our 988 and then also the enhancements that will come with our CCBHC designations?
I think that those would certainly be a good crosswalk or a good cross recommendation, potentially even combining those. So that would be something that we could also take back to the working group at the next meeting.
Well, because I think when we're talking about mobile crisis units, I think some of our communities have already done a little bit of this where we have a social worker move with our law enforcement at the same time. And that's kind of the same concept we're looking at on these mobile crisis units, correct?
Yes and no. I mean, I think that some of the larger communities have co-responder type programs, certainly Sedgwick County, I think Shawnee County, Johnson County, maybe Wyandotte County, but crisis intervention might mean something very different in a more rural or frontier county and be handled very differently. So even though we would like to have the conformity of a mobile crisis intervention, it may mean something different in different communities, at least so for a little while.
Right. But that would be the direction that we'd be trying to head. Because I think that, we can maybe we could maybe reduce some of our inpatient stuff if we can get help with our CCBHCs on for some of these folks. Not all of them. Some of them are going to have more intensive. So, all right. Any other questions or comments with Kyle? All right. Thank you. Go ahead.
Okay. And then recommendation 8.4 on defining crossover youth population. The addition there is just to coordinate with juvenile corrections advisory boards, or JCABs as they're known as, to ensure local implementation aligns with statewide policy team recommendations. Any questions there?
Committee questions, comments? Seeing none, proceed.
Okay, recommendation 9.5 on family psychotherapy, which would allow billing code 90846 in Medicaid as a tool to support youth in foster care and other youth without the patient or caregiver present. That is, we talked about well, first it would allow therapists and practitioners to have discussions without the child present. Again, that's what that is. And the discussion, working group members acknowledged some concerns with the discussion phrasing from last year, and working group members instead proposed the following language: there should be discussion about the extent to which Medicaid expansion. I moved on. I'm sorry. I completely fouled up there. So I combined two things. My apologies. So really, the 9.5 recommendation just stays the same, and I believe Medicaid Director Fertig may have some additional comments on this, or otherwise, it's just basically the same recommendation as it was last year. And people,
Sarah, do you have anything to add?
No, I concur with Kyle on that.
All right, thank you. Proceed.
okay, and then there was added in a high priority discussion, is what it was labeled by the group as, and talking about Medicaid expansion. But the addition there is that there should be discussion about the extent to which Medicaid expansion could help address recommendations in the report, including access to care and the financial impact of federal incentives in the American Rescue Plan Act. So that's essentially where that landed. I don't know that there was any additional information provided on expansion of services outside of wondering what the impact on the FMAP and financial piece would be if ARPA and the provisions in there were discussed further.
Okay, comments, questions? Seeing none, proceed.
Okay, and then this gets into the recommendations for new or expanded topics. And the first one being the K-12 Mental Health Intervention Team Program. I believe you all are familiar with that program, as it's been discussed by the committee, and several of you are champions of the program. The revised recommendation reads, expand the Mental Health Intervention Team Grant Program to additional districts, support continuity, and provide a way for students to access services when schools are not open by extending the times of services at schools, utilizing community mental health centers or other mental health resources. So that is where that recommendation sits. Are there any questions? Would you like me to continue?
Committee questions, comments? Kyle, we don't on that working group, we don't have anyone from the education community on there, do we?
No, I don't believe so. And to that, in fact, one of the things, it's a pretty good segue now, Madam Chair, that one example, I did receive a request just yesterday or the day before that I haven't even shared with Carrie or our co-chair, Laura Brake from KTAD yet, from schools asking for some to provide some feedback or some work by the working group and the committee on how schools could receive more information upon a student's discharge from a PRTF. So it's, I think, very promising, encouraging that schools know that this committee and the working groups exist and have some interest in what we're doing. So I think that's something that we'll take back as a new. I recognize it's late in our process, but I think it's worth having that conversation. And I know PRTFs has certainly been an issue, as well as the school mental health intervention team program. But we do not have school or KSD representation on that working group.
No, I think that shows that we're, that our work is actually being, some attention is being paid to the work that everyone's doing out there. So that's great news. Carrie Bruffett?
Just to add, Kyle, Jean Clifford, who's on the State Board of Education, is on that working group. And so that, and actually had proposed the recommendation.
Okay.
My apologies.
Just, no worries, just point of clarification.
Well, I think that we would find also in the K-12, we still have the issue of the records for foster care children getting to where they need to be at the school as we transfer a child from one place to another place, and perhaps put a child into a mainstream situation when that's not where they need to be. So we end up actually harming the child in the long run. Further questions or comments? Okay. All right, go ahead, Kyle.
Okay, and the next topic, new topic, it was specialty courts, and with proposed recommendations and the revised recommendations, we had a really good conversation, I thought, and discussion over specialty courts, and there are others, I believe, on this call who are more well versed on this than I am. But the revised recommendations include potential for regional specialty courts or venue transfer, to explore creation of regional specialty courts across Kansas and consider the implications related to venue transfer for access to regional specialty courts, and then specialty court coordinators to and providing funding for districts that meet qualifying criteria to hire specialty court coordinators. So some of this again goes back to the availability of these in some larger urban or semi-urban areas. And then some of the folks thought, this might be something that could work regionally. But I believe Spencer Kane from OJA is on, and he may want to add to this, or Carrie or others.
Carrie Bruffett.
I'm very glad that Spence is on, so he could help answer this question. But the group did, as Kyle said, talked about combining the discussion about venue transfer and regional specialty courts into a recommendation, thinking of strategic importance, but then referring it to a committee whose name I still do not know, but Spence may not know, that is actually looking at venue transfer venue transfer issues. So this was an example of a recommendation where this group would say weigh in, but then send it to another venue, I suppose, for discussion. But Spence, I'll defer to you if you recall the name of the committee.
This is Spence Cohen with Office of Judicial Administration. I believe it is just titled the Specialty Courts Committee. It is by I believe Judge Brown. And Amy Raymond, our trial court our director of trial courts is the head of the OJA portion of that. But they are looking at a change of venue, and I believe they're going to discuss that in their January meeting.
That's great news. Committee comments? You're thinking? All right. Seeing none, it looks like that pretty much covers everything, doesn't it, Kyle?
We did have one more new item as well, Madam Chair.
The competency evaluations?
Yeah, and
okay.
That there will be some additional conversation about that. But the proposed recommendation is that to provide funding for community mental health centers to conduct mobile competency evaluation and competency restoration. There ended up being quite a bit of communication or conversation, I should say, in the working group about, and from at least one, maybe a couple of the judges, about the number of people who are awaiting competency to stand trial, or competency, or having competency restored to stand trial. And if that is something that could be done, it could free up a handful of state mental health hospital beds and probably remove what could be over 100 people from jails around the state. So we're going to try and get some additional information on that as well.
All right, committee questions, comments? All right, seeing none, thank you very much, Kyle. We appreciate the update.
Thank you, Madam Chair.
All right, Carrie Bruffett, we're going to have, do we have Sunny and Shauna with us?
Madam Chair, I am on the line. This is Sunny Mickle.
All right, welcome, Sunny.
Madam Chair, I'm here as well. I think Sunny's going to cover our testimony, but I'll be here for questions.
Okay, great. All right, welcome to committee, both of you. And Sunny, I guess you've got the report.
Yes, I do. So I am Sunny Mickle. I'm the Vice President of Government Community Relations for Blue Cross Blue Shield of Kansas. And I also serve as a co-chair for the Telehealth Working Group, along with Dr. Shauna Wright from the University of Kansas Center for Telemedicine and Telehealth. The Telehealth Working Group met on November 15th, and we focused our discussions on telehealth utilization and payment parity. During the meeting, working group members reviewed telehealth utilization rates for all medical and behavioral health services. Then we also looked at specific behavioral health service codes and the frequency of the types of behavioral health services that people were receiving across the state. This data came from the state's all payer claims database and also several private insurance companies. The group also heard from supplemental experts on the local and national landscape around telehealth payment parity. One of our subject matter experts was Dr. Dorothy Hughes from the University of Kansas Medical Center. Dr. Hughes presented data from survey research that she conducted with 14 providers and administrators on their telehealth usage in Kansas. We also had Kyle Zebley from the American Telehealth Association come speak to us as a subject matter expert on telehealth payment parity in other states and the federal government. So he dived into a little bit about federal legislation that may affect telehealth reimbursement for Medicare beneficiaries and the fact that this legislation is moving pretty quickly at the federal level. After those presentations, working group members agreed to continue responding to surveys before our next meeting, and this is going to help us refine our recommendations on telehealth coverage and reimbursement. Our next working group meeting is scheduled for December 2nd, and at that time, we're going to finalize our recommendations for the special committee. With that, Madam Chair, that's the end of my testimony, and I know Dr. Wright and I are happy to answer any questions from you or the committee.
All right, committee, do we have questions of Sunny or Dr. Wright? Senator Hawk.
Excuse me, can you tell me what the status of emergency orders that we had during the early part of the pandemic and what's in effect right now relative to that issue of telehealth rates and parity?
Sunny, do you have an answer to that? I think basically what it was is through the emergency and the rates were increased? Or is there someone else that can better handle that?
I can handle part of this. I know we also have some other folks in our working group that may have more specific information. The public health emergency is still in effect, and because of that, this is the federal public health emergency. Because of that, telehealth reimbursement for Medicare is happening for patients regardless of where their originating site is. Before the pandemic, Medicare was very specific about the originating site and did not always pay for patients when they were at home or outside of a clinical setting. So or if they were also from a urban area of the country. And in this situation, telehealth for Medicare is looking very similar to the way it works today for a private pay here in the state of Kansas. So it doesn't matter if a patient is at home or in an urban area, their telehealth services are being covered. Does anyone else have anything else to add about, I believe the facility fee is another matter that's occurring with Medicare. Shauna, do you want to add to that?
Yes, and I might ask you, this is Shauna Wright, I might ask you a clarifying question as well, Sunny. My understanding is that with the pandemic, what we saw mostly was an opening of codes to telehealth that hadn't been open to telehealth before, but not necessarily a rate increase in terms of our physician fees. And then you did mention the facility fees, which during the pandemic have been covered because our providers still have to maintain their facilities, even if they're doing a telehealth model or a hybrid in-person and telehealth model together. They still have those bottom line facility costs. But my understanding is that the rate didn't increase in terms of what our physician fees were, but during the pandemic, there was an agreement to cover all fees to help sustain healthcare through the pandemic. Is that your understanding as well, Sunny?
My understanding that it's paying at parity plus, so paying more today because of it's adding that facility fee regardless of where the patient is located. And that facility fee was intended when the patient was at an originating site that was a clinical setting. So it was paying for them to have that provider working with them using a room in that facility, et cetera, in addition to also connecting with a provider at a remote location. That is how I understand it, that it's parity plus under the public health emergency.
And an opening of codes that hadn't previously been open, procedural codes or events that had not previously been open to telehealth in some instances.
That is correct. In our state, our Kansas Telemedicine Act is actually much broader in allowing coverage for telehealth in situations that providers are able to practice under their scope of licensure, whereas in Medicare, it was more restricted to certain codes before the pandemic. And now those codes, as you were speaking to, many of them have opened up and they're allowing reimbursement for those as well.
Thank you.
And what's the expiration date of today for that emergency order?
The public health emergency at the federal level is expected to extend through April of 2022, but there also has been an indication that it will likely be continued throughout all of 2022. It has to be renewed every 90 days, but they wait until they get closer to the end of the expiration before they extend it for additional time. But the federal government has indicated it will likely be continued throughout all of 2022.
This is Shauna again, and I believe, Sunny, that CMS has made that same expression that maybe even if the pandemic is determined to have ended, that they will see the codes through the end of 2022. I mean, that's aspirational, but I think that there's maybe some goodwill intent to keep those services available, or am I speaking out of turn?
I believe that's what Kyle Zebley from the American Telehealth Association was speaking about, that there's actual legislation they're looking at to codify some of those codes and allow that originating site. But there's also a discussion back and forth what that reimbursement will look like. It may not necessarily be parity plus. It may go back to paying for the professional component at parity and the facility fee when that does apply.
Senator Hawk has a question or comment, one or the other.
Just to clarify what I think I heard, you mentioned Medicare, but I'm assuming this also applied to private insurance in terms of reimbursements for telehealth services. Did I hear that right?
Well, if our state law was not as broad as it is today, it would have applied to or been a consideration for private payers. In Kansas, we already were paying more codes than Medicare was, so it did not impact the way we handle telehealth reimbursement in Kansas. And Shauna or anyone else from the committee, please chime in if you think it may have had an impact on how you handled your business.
So does that mean that my private insurance, if I had mental health services, would get the facility fee and the parity plus that you mentioned?
It
Or
may
would that only?
I'm so sorry. It may depend on the provider or the patient insurance. So some insurance companies were paying parity plus. Other insurance companies may only have been paying parity and not paying for that facility fee. It depends on the private payer and what they communicated out to their providers in their network.
Do we have any sense of the percentage of providers that were getting that full reimbursement versus those that weren't? Is it 50%, 70%, 90%? Just curious if we have a sense of that.
I do not have that information either.
Just curious.
Well, and I think one of the things that sometimes people forget is that if it's self-funded plans, that operates different than the other plans. So anytime we do make changes in insurance, it's only impacting one group of insurance companies. It's not impacting all of the self-insured, like a lot of our school districts are self-insured plans as well.
Thank you.
Mm-hmm. Other questions or comments?
Madam Chair, this is Hina Shah from KHI.
Yes.
The committee also perhaps want to hear from Sarah Fertig on Medicaid rates and any changes there.
So Madam Chair, during the pandemic, the Medicaid program expanded the number of codes that we will reimburse via telehealth. And our current approach is to, we pay the same rate if it's a telehealth service or if it's paid in person, but we currently do not pay facility fees for services delivered via telehealth.
Thank you, Hina. And there was, and I'm, if we're not going to get this in our report, I know in the discussions yesterday on the telehealth working group, there were some charts that were presented to members looking at, where the visits were prior years, where the visits are at today. And they're not a complete picture of things, because one of the things that we needed to understand is what were our in-persons prior to this, and how many of our in-person, say in 19, then became into the telehealth, so we don't duplicate those numbers. So there's some more details coming. But I thought that was very good information that was provided. So I think when those numbers get finalized by the committee, it would be good for this committee to have access to those numbers. Any further comments, questions, discussion? All right. Seeing none, thank you very much, Sonny Nickel and Dr. Shauna Wright. We appreciate your report on this. Okay, next committee, we have a presentation on the Governor's Commission on Racial Equity and Justice Behavioral Health Related Recommendations. We have David Jordan, President and CEO of United Methodist Health Ministries Fund. Welcome to committee, David.
Is it okay if I take off my mask?
Yes.
Thank you.
Yes.
Thank you for having me today, Madam Chair. As mentioned, my name is David Jordan. I'm the President and CEO of the United Methodist Health Ministry Fund. We're a $70 million health philanthropy located in Hutchinson. Today, I'm speaking on behalf of, in the capacity as one of the members of the Governor's Commission on Racial Equity and Justice. As background, Governor Kelly signed Executive Order 20-48 on June 24th, 2020, forming the Governor's Commission on Racial Equity and Justice. She asked that the first topic that the Commission study is the issues of law enforcement and policing in Kansas. The Commission includes perspectives from the criminal justice system, the education system, the healthcare system, and advocacy organizations. The initial report that the Commission issued came last December. It included over 60 recommendations regarding law enforcement, the criminal justice system, and how local governments could improve racial equity in Kansas around policing. Despite that report being primarily focused on criminal justice and policing, it did include several recommendations regarding behavioral health that really mirrored what was in last year's Mental Health Modernization Committee's recommendations, particularly around crisis response, providing better funding for crisis response, as well as supporting evidence-based training programs like mental health first aid. So we're identifying mental health problems early. For 2021, the Commission has focused on social determinants of health. In studying this topic initially, the Commission heard repeatedly about the overlapping and connecting interest in issues around social determinants of health that are occurring in the state and communities of color. The issues span education, healthcare, housing, early childhood, economics, and as a result, the Commission decided to focus on social determinants of health, forming 3 working groups: an education working group chaired by Topeka Superintendent Dr. Tiffany Anderson, an economics work group chaired by Dr. Shannon Portillo at KU, and a healthcare working group chaired by myself. As part of the work this year, we have 2 reports. The first report was issued on July 1st. It included recommendations around early childhood and childcare, federal legislation and funding, tax policy, teacher diversity, post-secondary education, school resource officers, school mascots, maternal and child health, and vaccine equity. We are meeting actually tomorrow to finalize recommendations for our December report, which I'll get to in a little bit. So here are 3 examples from the July report, and I'm happy to go in more depth. Excuse me, I'm going to get some water if that's okay. I apologize, Madam Chair. The first recommendation, just to highlight from the July report, just mirrors some of the discussion that I heard earlier around the use of federal dollars and making sure that the state prioritize the disbursement of ARPA dollars in a way that's equitable, and that we should consider the definition of health more broadly than just healthcare that occurs in a hospital or doctor's office, factoring things like behavioral health, safety net services, and education, early childhood. Health equity should be a primary focus of the disbursement of funds per our recommendation. Another recommendation that we had revolved around health coverage for children. Children of color are disproportionately uninsured, and there's evidence that insurance coverage for kids 0 through 5 can reduce the interaction with the criminal justice system. So our recommendation was to follow the lead of several other states and to pursue continuous coverage for kids 0 through 5 that are enrolled in Medicaid, both to reduce churn off of Medicaid, but also to reduce the administrative burden the state has with re-enrolling and verification for kids that go just in and out of the system around the edges of the eligibility levels. And then another recommendation included in the July report is relative to the childcare tax assessment credit, basically recommending that the Department of Revenue, which administers the tax credit, look at ways to expand the tax credit, expand the type of eligible qualifications, eliminate the reduction of benefits after the first year, and expand the types of businesses eligible for the tax credit. There are a number other, as I mentioned, a number of other recommendations relative to the social determinants of health in that report. What I'm going to take the rest of my time to highlight now is really the reports that the recommendations we're going to approve at tomorrow's meeting for the final report of the commission. Relative to behavioral health, we looked at cost, coverage, and services. The first recommendation is that the state should expand Medicaid eligibility to 138% of the federal poverty level. As we look at Kansas's lack of Medicaid expansion, we recognize we're missing out on a number of financing options for behavioral health services, which was highlighted earlier, as well as providing coverage to 150,000 Kansans that are in a coverage gap. We also recommend the extension of postpartum coverage from 60 days to 12 months. I know that was highlighted in today's conversation earlier. 9,000 women in Kansas who are enrolled in Medicaid lose coverage after 60 days. Disproportionately, those women have behavioral health needs. Those untreated needs are the greatest cause, particularly around substance use disorder, of interaction with the child welfare system. So there's an opportunity not just to improve access to care, but to reduce state costs and other services. We also recommend the use of state dollars to provide mental health coverage for youth regardless of their immigration status. We recommend continued investment in proven models to help prevent and identify behavioral health issues early, particularly evidence-based programs like mental health first aid, the attachment biobehavioral catch-up program, and other evidence-based programs used in the state and through different programs within KDHE, DCF, and KDADS. We recommend continued investment in use of state and federal resources to promote the use of suicide prevention services, the 988 hotline, and programs like Zero Reasons Why. Again, many of these recommendations are focused on the legislature. We also have administrative recommendations as well as local recommendations. We did lean heavily on past reports and the work that this committee has done in the past as well, so you'll see some overlap. We recommend conducting a statewide needs assessment to identify gaps in funding and services. Per the conversation that just happened, we recommend the expansion of telehealth access and to codify regulations that expanded telehealth for mental health services as part of the response to COVID-19. The changes could include requiring payment parity, the use of personal devices, and the ability to access and initiate services at distant sites, to make it easier for patients to access services for providers and to provide services to patients. I know you'll hear a little bit more about telehealth after this presentation, but we conducted a statewide poll last year, and we saw that over 90% of Kansans and over 92% of non-white Kansans wanted to expand and maintain access to telehealth services post-pandemic. They saw it as a way for them to get access to services at home without or at work without having to take time off from work in a way that worked for them. And I think that part of our job as a commission was to reflect that. Another focus of the commission's work was on adverse childhood experiences. So those experiences that happen that may be a result of domestic violence, substance use disorder, mental health, or children observing violence. ACEs are common in the United States and in Kansas. 40% of Kansas children have experienced one ACE. 20% of Kansas children have experienced 2 adverse childhood experiences. Experiencing these adverse childhood experiences early in life has lifelong consequences on school readiness, student success, earnings, lifelong health. The key to mitigating the impacts of adverse childhood experiences is helping children and caregivers form safe, strong, and secure relationships. So a number of recommendations, both in this section and the early childhood mental health section, revolve around use of evidence-based programs to support the development of these nurturing, safe, strong, and secure relationships, not just to improve health outcomes, but also to save the state money. Among those recommendations is invest in primary prevention efforts focused on healthy and equitable relationships, such as home visiting services, education services, safety net services, and behavioral health services. Invest in training and education about the use of trauma-informed practices that support dyadic relationships between children and youth and their non-abusive protective parents. Expand access to health care, housing supports, safety net services for survivors and victims and their children, and develop payment policies and fund care coordination services such as pediatric care coordinators, community health workers, and other culturally competent professionals to coordinate services for youth and children and their caretakers. In terms of recommendations related to early childhood mental health, the Commission made recommendations around behavioral health parity, allowing preventive behavioral health care for infants and toddlers, implementing the DC 0 through 5 crosswalk, which is a set of diagnostically appropriate codes that 10 other states use so that basically a severe emotional diagnosis doesn't follow the child from early in life to later in life because they needed access to services. So it allows you to crosswalk the diagnosis so that it benefits the child throughout their lifespan. To increase the availability and funding of infant and early childhood mental health consultation services across the state. In recent years, the Children's Cabinet has redeployed or refunded several mental health consultant programs in schools. We think this is a great evidence-based approach. There's a number of challenges that exist with preschool settings when kids are expelled from preschools and that are just disproportionately children of color because there's not behavioral health services that can help address those challenging situations. A number of states, including Ohio, just recently made significant investments in behavioral health consultations, and this really is consistent with the later investments that this committee and legislature has made in school-based mental health services. It's just recognizing the need for those services in preschool settings. And then just utilize Medicaid as a way to promote and pay for universal screening, so we're identifying challenges early in a child's life. Again, sort of providing resources to support the use of therapeutic preschool, so building on that more comprehensive mental health approach to preschool that also includes behavioral health consultants. One challenge that we heard from folks both within the healthcare system and the mental health system is making sure that there's support and funding for culturally appropriate and multilingual services. So support for multilingual services would help address challenges and reduce disparities. Continue to the use of evidence-based home visiting strategies that support and prevent family interaction with the child welfare system. There's a number of interactions that the state could look to fund home visiting, whether or not it's through Medicaid dollars or state general funds, that could help prevent kids from entering the child welfare system at a much lower cost, and increase investments in the early Head Start program. From a youth mental health standpoint, again, reflecting this committee's past work, fund and support policies that establish, maintain, and expand school-based mental health services, support funding and policies that ensure services are offered in multiple languages, and develop confidentiality policy and procedures to ensure children experiencing behavioral health issues can confidentially access services to ensure they get the care they need. The next topic that we looked at was workforce, and some of this is also tied to financing, but develop payment policies and managed care contract language that pays for social determinants of health services to improve health, and utilize patient-centered care teams and delivery models that utilize a team-based population health approach. And collaborate with CMS on this effort to look at other states and models. As part of that, explore how we can leverage payment models to pay for social determinants of health services provided by culturally competent providers that are utilized in CMHCs, SUD settings, and in community-based services such as community health workers, how peers might be used in an SUD system like they are in the CMHC system, just looking at how we can take a team-based approach to care and utilize different payment sources to do that. Another piece is just recognizing the role that state scope of practice laws play and administrative policy play in the credentialing and payment of a culturally competent workforce, and explores ways the legislature can support making it easier to provide culturally competent care. In that statewide survey that we had done last year, 71% of respondents of color, which we oversampled, highlighted the desire to have a doctor or healthcare provider that was culturally competent and of the same race or came from the same community of theirs, and I think this was one way to do that. And then I think the other piece is develop payment and credentialing policies to recognize and sustain culturally competent workforce like community health workers. And again, we also recognize that a lot of work has been done on this topic by this committee and others, and we drew on some of those lessons, but also will encourage the examination and support of the previous work on mental health and youth mental health done by the legislature and other groups. So thank you, and I'm here for questions.
All right, thank you very much. Committee questions, Representative Lynn and then Representative Arnberger.
Thank you, Madam Chair. I had the opportunity this week to visit one of our safety net clinics in Olathe, and one of the issues that they brought up was about they're not really receiving the Medicaid reimbursement for their translation services. Is that something you're looking into?
Yes, and we in our administrative recommendations, I didn't go through all of the different administrative recommendations. There's actually there'll be a whole section on reimbursement for language services for language access. I can share that language with you after the presentation.
Great, thank you, Madam Chair.
Representative Arnberger.
Thank you, Madam Chair. I'm looking on page 7, the reports, and I have questions about the July 1 report.
Sure.
First question is, what did you guys, over the topic of teacher diversity, what was your finding, or what exactly were you looking at on teacher diversity?
I'm sorry, Representative Arnberger. I'm not sort of steeped in the expertise of the teacher diversity work. That was chaired by the Topeka superintendent, so I can pass along questions to her. I apologize.
Okay, and then same on school mascots. Are you guys just going through all the schools in the state of Kansas and figuring out which ones are not appropriate, or what exactly did you guys do with that?
Again, I'm probably not the best person to speak to that recommendation.
Okay, and then the last one is the vaccine equity. What does that mean exactly?
The recommendations around vaccine equity was just to make a series of recommendations based off of science to make sure that vaccine was being equitably being dispersed throughout the state, as well as to educate folks about the efficacy of vaccines. There was no discussion of requirements or anything of that nature.
I just wasn't sure what exactly it was getting at, so thank you.
Okay, on the vaccine equity, was that dealing with COVID or all vaccines?
It's really geared towards all vaccines and immunizations.
Okay, I guess I'd just be kind of curious to find out what kind of equities that we would have, because we know that when our kids enter school, that's when we definitely get to start tracking if all the vaccines are current.
No, absolutely, Madam Chair. I think there's a number of recommendations in terms of making sure that information about vaccines are provided in multiple languages, and that health departments have the resources to provide education and outreach around vaccines. I actually don't believe there were many legislative recommendations around vaccine equity, but I can look.
All right. Committee, are there further questions? Senator Hawk and then Senator Fagg.
Thank you. I appreciate your testimony. You mentioned the early childhood and child care, and maybe there's another group that I should direct my question at, but I'm trying to figure out how many child care centers went out of business or closed down, and what's really available for families now. And of course, I hear certainly personal stories about not being able to access child care. And did you talk about that? And do we have a sense of what the gap is now compared to what it was pre-pandemic?
Great question, Senator Hawk. Outside of the purview of this report, I've recently been part of conversations with Child Care Aware, and they've indicated that their data shows that over the last 2 years, Kansas has lost 1/4 of all of its child care providers, which is a significant challenge. One follow-up is the Health Fund is looking to partner with Child Care Aware to understand why we've lost the providers, both home-based providers and centers. I think there's a lot of assumptions being made, but I think we need to do some real research to understand what the root causes are, whether or not it was age, whether or not it was its cost, whether or not it's related to the pandemic. So I think there's a number of questions, and we hope to be able to find some answers, because we know that we need a child care workforce and child care providers to support our economic growth as a state.
I certainly agree we need to know why, but I think we also post-haste need to try and close that gap. And not usually my position, but I tried to help one of my Manhattan groups that was trying to start up, and having adequate staff to go through the regulatory process and do it in time to make it available when parents needed it with school starting was a very difficult process. And usually I shouldn't say I'm always in favor of regulations. I want good regulations because I want the people protected, especially our children. But I also want to make sure services are available. So I would hope if you deal with that, if there are ways to streamline or speed up the ability of people to offer this, particularly if we're short 25% of what we had. And I'm guessing we need more than what we had pre-pandemic. So appreciate your work in that.
Absolutely.
And I think, Senator, that'd fall in line with what we've been looking at in other areas because of workforce issues, is how can we, without sacrificing safety and quality of care, et cetera, can we ease up some of the things? And you're well aware of what the BSRB has been very helpful on their end of things. And so there may be some things that we could, look at in that.
I just know when my kids were little and needed childcare, me finding that for them was a critical part of my mental health and certainly of my marriage.
I would agree. Senator Fagg and then Representative Ballard.
Under cost coverage and services, you say use state dollars to provide mental health coverage for youth regardless of their immigration status. We're talking about taking state dollars to fund illegal youth, is that what we're saying?
I think we're talking about funding services for all Kansas kids.
Okay. So how many illegal youth do we have like that, and what kind of dollars are we talking about?
I don't have that figure in front of me, Senator.
Okay. Is there some way we can get that? I mean, we're saying use dollars, but we don't know how much and exactly what for.
I'm sure we could work with KDHE and the Department of Administration to look at any cost analysis.
Okay. There was another item in here that talked about early childhood. It said early Head Start. Now this, I'm new to the committee, so I know Head Start is a federal program. Early Head Start, is that a state program, or can you explain that a little bit?
Early Head Start is also a federal program, but there's braided funding for both Head Start and Early Head Start with federal, state, and local dollars. So recognizing the role that Early Head Start plays, particularly serving the low-income population, we thought it was a prudent recommendation to, and sort of to the point of the chair and Senator Hawk, just the more we can do to invest in the early childhood system is also investing in the workforce.
Okay, so I'd be interested in how much we're talking about increasing state investments, exactly how that'd be spent too. So that was my question.
Thank you, Madam Chair. You addressed part of it a few minutes ago when you talked about the workforce and maybe easing some of the regulations. But I've been looking into that in Lawrence. I think actually we have lost more than 25% in that area. And part of it, when I was calling around and then also talking with childcare providers who were no longer providing it, is some things have changed. You have to have more space than you had before. So because you can't have so many toddlers all on top of each other. The other thing is the infant care. The ratio was 1 to 4, so you needed 4 direct care workers for 4 infants, and they're having trouble finding direct care workers that can do that. So therefore, you're going to have trouble being licensed if you don't have that 1 to 4 ratio. And so there's all little things that happen. And if your house is not big enough, you can't always keep them out in the yard, which would give you the open air. So that's been a real problem. And when you say 25%, I think I would almost say, my goodness, we would welcome 25% because I believe it's not just Douglas County that's having that problem. My other question is about the maternal and the child health. We have the CHIP program, and here we're talking about we have 9,000 fewer Kansas children who have health coverage. And yet, I'm looking at Representative Rambo because we have really talked about if you have free health care for your children, and yet they're not being covered. That's a real problem. And at one point, I would say, if I would go back 10 years, we were making progress in that area. Now I see that we're going back again. And I don't know, you can't force people to do it, but did you discuss maybe other ways that we could encourage parents to register their kids?
Well, the experience and evidence shows that if parents are enrolled in coverage, then the kids are more likely to be enrolled in coverage. So, you know, the coverage extension for the postpartum coverage, I think, is a benefit there to making sure the children are enrolled in coverage. So, as I mentioned, 29% more likely for a kid to be enrolled in coverage if their parent is. So there's a strategy right there. If the parent is able to get a coverage extension because of their postpartum, 6 months, 6 weeks to 60 days to 12 months, or should the the state expand Medicaid, you're going to be covering more of those parents that are in the coverage gap. And as a result, you're going to see more kids enrolled in coverage because their parents are covered. I do think there's more that the state can do, both from and philanthropy, because we support a lot of this from an outreach and enrollment standpoint, how we can, make sure that you're enrolling more folks in coverage, especially kids. And I think then there is this administrative challenge, just as there's been challenges with the Medicaid program in the past in terms of churn or redetermination programs or how you're enrolled. Those challenges exist across all populations, including kids. And that's what that recommendation about continuous coverage would get at the largest and biggest blanket way. But there's probably other administrative changes that could be made to make it easier to enroll or more apt for this re-enroll in coverage. I do think the state took a positive step recently. We're providing continuous coverage for all kids up till 12 months. And that happened after this report came out. So I think that that's a positive step in the right direction.
Okay, I'll end with, when I look at this, as Black, Indigenous, and children of color are nearly twice as likely to be uninsured. I know at one point we were working with faith-based organizations, talking with pastors in churches, and looking at other organizations as a way that they would be the go-between, making people more comfortable about stepping forward. There are some people, kind of scared of the government, and they shy away from it. But do you know, are we still making those efforts to reach out in the community as part of a partnership?
That's a great question, Representative. I'm not certain of the partnerships that the state Medicaid office has with faith-based organizations to do outreach and enrollment.
Okay, I just wondered, had y'all discussed it? I can follow up on that. I just wondered, was that a part of the conversation?
A good chunk of the conversation was focused on how we can meet people where they are. Okay. And then from a policy standpoint, I think there's great recognition in the workforce, of the use of community health workers and other patient navigators, people that have lived experience, that are from those communities, that speak the same languages, to help patients navigate both enrolling in coverage, but also better accessing care. And just the need for us to figure out how to pay for these services from a reimbursement standpoint so that they can be sustained. A lot of these services are being provided through grant dollars, and they're going to continue to need grant funding, but so that there's some recognition that there's a role for this team-based, culturally competent approach.
Thank you so much. I appreciate it. Thank you, Madam Chair.
Thank you.
Representative Neighbor.
Thank you. Thank you, Madam Chair. Going back to page 7, where there was discussion on the vaccine equity. Several years ago, I did work for KDHE, and it was Be Wise, Immunize. And the reason for that is we have a lot of young children who didn't have access to immunizations necessarily, cost, parents having problems getting them to the doctor when they were working. And so there was a large effort made across the state, because we traveled and did reports and looked at medical records on how many children were not vaccinated, certainly a parental choice, but then FQHCs made things available at no cost for these children, safety net clinics, and then there were clinics that were in malls, and they would have 2 days worth of, if you wanted to bring in your child because you didn't have access or insurance, and it was free. So I think when they're looking at vaccine equity, it was a matter of availability, cost, location, and time, and they were trying to bring those opportunities to all kids, not just those that saw a pediatrician on a regular basis. So there's been a big effort even in years past, because they continually look at the rate of vaccines. The other thing is, working in the medical field, oftentimes you have language barriers. big time with Hispanic if you don't have an interpreter or whatever. And I know doctors trying to give instructions to patients, what I say to a person who only speaks Spanish, they nod yes that they know, but then they don't take their medication correctly. And that is a serious problem when they're a diabetic or, you know, if they came in with pneumonia, whatever it might be. So having interpreters there is a huge advantage and helpful just to answer questions, not to have anybody have to do something, but to give the education and then to have that information printed in something that they can read and understand has a huge impact. And I think when you look at the equity problem on that, it has nothing to do with COVID. This has been a big push in Kansas for several years because of access. So I just wanted to throw that in. Thank you.
Committee, are there further questions or comments? I guess, and I'll look forward to seeing the report, and I believe, Carrie, correct me if I'm wrong, but this is also one of the reports that has a hyperlink in our report, correct? Yes. Well, because we're trying to bring everything together, so, that I would hope that any of our groups, and especially with this one here, is that we're seeing what you're recommending, but I hope you're also working on what are the solutions for the workforce, because we know that's a problem countrywide, not just statewide, in the whole healthcare realm and behavioral health. And then also with your recommendations is to put what the cost is that's associated with that. Because I know that's one thing that's been very helpful for us as we've gone through this process in this committee, is to knowing what the costs are so we can decide, is that a feasible cost that we might be able to overcome? And if not, how can we get there? So that would just be my recommendation. But I appreciate you being here today and the information you provided.
Excellent. Thank you so much, Madam Chair. I appreciate the opportunity and happy to be helpful in any way.
All right. Thank you very much. All right. Next committee, we have Telehealth Research Update. We have Dorothy Hughes, Assistant Dean for Student Affairs, University of Kansas School of Medicine. Welcome to committee.
Good morning. Are we on? All right, thank you. Okay.
Put on your gloves.
I'm not the only one with freezing hands, is that okay?
Hey, I bought her gloves to wear. She's not even wearing them. Welcome. Thank you for being here today.
Thank you. Good morning, Madam Chair, committee members. Thank you for having me. I'm Dorothy Hughes. I'm an assistant professor in population health at the University of Kansas School of Medicine. But my disclaimer here is that this is the results of my own team's research and should not be construed as the official position of the university. The study results here were funded by United Methodist Health Ministry Fund. I do have ongoing work funded by the Health Fund and Reach Healthcare Foundation. So just in full disclosure there. So today I'm going to talk just very briefly about the survey that was conducted about a year ago now. That had about 230 respondents about telehealth experiences that was answered by providers and administrators. And to do that, the Health Fund brought together a number of groups that are listed here to try and reach out to a wide variety of professionals. In follow-up to that survey, we conducted in-depth interviews with providers and administrators. There were 14 of them, 2 from each of the first 7 groups that are listed. Since physicians are also usually members of KMS, we did not particularly seek out members from KMS because they were represented in the other groups. I do want to point out that this very deliberately was not what we would call a representative sample. We purposely sought out these providers and administrators with the goal of getting maximum variation in their perspectives. We really wanted the widest variety we could find about different things going on in the state around telehealth. So I will describe our sample a little bit later. The survey takeaways, just to reprise those, these were also presented to the CanCare Oversight Committee last December. And I can also make sure you have links to my full report on the survey, the full report on the interviews, and the poll that David Jordan also referenced earlier. So there's a lot more out there on this topic than just what we're talking about right now. But respondents to our survey indicated that physicians, NPs, PAs, and behavioral health professionals are the ones providing telehealth most commonly. Video conferencing is the most common modality, and the most common services were primary care, patient education, chronic care management, and counseling and therapy. Their top policy priority was payment parity. They did perceive an improvement of insurance coverage of telehealth services, and the policy changes that had been put in place due to the pandemic were perceived as largely positive. This was the geographic spread of our survey respondents. So again, this was fielded about a year ago, and we've got pretty good spread across the state, but of course, as you might expect, more response in Sedgwick, Johnson, Wyandotte counties, and some of the other northeastern Kansas counties. I will not be detailing the geographic locations of our interviewees, though, because since there are so few, that could make them identifiable. All right, so to get into the in-depth interviews, which each of these ranged from about 45 minutes to an hour apiece, and some of them went longer. So 50-50 split between women and men participants, a 50-50 split between administrators and providers or clinicians. And geographically, we had a pretty good variation here too. Almost half were from urban counties, over a third from rural, and 21% were located in clinics or facilities that were providing services to both rural and urban patients. So there are 6 themes that emerged from the interviews, and I will go through these one by one. So first, telehealth and access to healthcare. Our participants talked about access during the pandemic specifically, and they talked about how telehealth increases access, the importance of patients being able to access from home, and the fact that some locations, one of our participants talked about low uptake of telehealth services due to their locations' technical difficulties getting it up and running. So again, we were looking for maximum variation, so this is not only people who've had a large volume of telehealth, these are also people who had some stumbles and low volumes. So really the takeaway here is that while COVID forced telehealth to advance, providers and administrators saw a lot of benefit and increase to access, especially being home. One of the trade-offs to not being able to see the patient wholly, head to toe in person, the trade-off was being able to see their home environment. And so there was some benefit added there. Going on, just a few example quotes from this theme. So one urban outpatient pediatrician said definitely during COVID, it made it easier earlier on because a lot of people really didn't want to come to a hospital setting. A rural SUD administrator said, a real plus with telehealth stuff is it allows us to engage people who can't get here. I mean, you can imagine in a rural 7-county area, a lot of people we serve don't have a driver's license or cars. A lot of times no income, so it's hard for them to get here, but almost all of them have a smartphone. And lastly, one of our urban CHC administrators said, I think it just provides a greater level of access, especially to vulnerable members of the community. Some, maybe with higher incomes or higher resources, might have already had access to things like a teledoc, but the expansion through community health centers really helps people of lower access in general be able to utilize our services. So under the theme barriers to implement telehealth vary, I actually have 2 slides on barriers because, as you might imagine, it's complicated to get up and running and keep going. But patients' tech savviness really varies, and so some struggle more than others, and this is not necessarily due to age. Connectivity and device availability really varies, so not just whether you have Wi-Fi, but what kind of device and, can you purchase it, can you pay the data plan, that kind of thing. And the effects of living situation were important to think about too. Is the patient in their home? Is the patient in a long-term care facility? Where might they be trying to access these kinds of services? Communicating with patients about telehealth was discussed, and this was mostly about just educating them about how to get on the visit, just taking time in addition to the clinical time to make sure they understood how to interact with the technology. And then the cost to patients, this is again about device-related costs, separate from sort of connectivity. To continue on, some providers had difficulty with the telehealth platforms, trying to find a platform that had all the functionality that they wanted and that integrated well into their electronic health record. The cost to providers is not only startup costs in relation to purchasing the technology, but also continuing to pay for the platform that they are using, and annual service or subscription costs. And lastly, telehealth-related policies are sometimes cumbersome or unclear, and I'm sure we've all experienced this to some degree in the pandemic, that kind of the rules are shifting from time to time, and so our providers and administrators found that as well, and they would certainly appreciate more certainty going forward about what they can expect. So a few example quotes here: connectivity and device availability. I think the negative is just the internet. Those always comments about, well, I tried telehealth, but the internet wasn't any good, and struggles with getting some of our patients on. They don't necessarily have the newest, latest, greatest iPhone on the market, and so that makes sometimes for a difficult phone call. We did have to invest in the hardware, software, cost-wise equipment, more IT time, staff training time, that kind of thing, system maintenance. Some of that we were able to get some COVID grant money to support. And just, I think, 3 more here. So we're doing fine right now because of the waiver. They can declare an emergency, I guess, and so we're able to do it with, quote, non-secure devices. And you know how secure the medical record systems are now and how we have to ensure the security, and of course, that's expensive. The standards for SUD providers have not been updated since 2006, and in 2006, they never dreamed of telehealth. I am not an expert in those requirements, by the way, so that's just a direct quote. I can't speak to accuracy. I'm sure others here could. Cost to patients. If you're paying per text or per minute on your phone, if you're paying every minute on a card, well, first of all, it'd be frustrating then. We've experienced concerns where a patient who has like a pay-per-use plan and the provider's ready or the patient's not there and there's some back and forth and it doesn't work well. So if you're paying money to go back and forth and to try and figure this out, or even just, I think would rather just come in person where they don't have to pay. So that is the case for some people, and our participants were very clear that telehealth is not a panacea, and that it's really, it's not always going to be appropriate for everything in everyone's situation. Regarding scheduling and no-show rates, there were no secondary themes to identify here, but I wanted to point out the benefit of being able to fill these potential no-show slots with telehealth. So it allows for greater efficiency in a clinic setting. So if someone no-showed, the provider can go back in their office, try to call them, try to reach them, and if they answer, we just say, do you want to do this over the phone? If it's an appropriate situation to deliver care that way. So now they can catch them easier and fill that spot. So things that can and cannot be done via telehealth. So again, our participants were very clear about there are some things that are better suited for telehealth than others. This is just an example list, not an exhaustive list of things that potentially are well done via telehealth. Things like basic triage, quick follow-ups, patient education, reviewing lab or radiology results, transitions of care, and chronic care management. And then what it's not very good for, I'm sure many of these you would expect, anything that requires a physical exam, procedures, residential services, injectables. Some of our mental or behavioral health providers said that group therapy just wasn't working quite as well, on telehealth platforms, and they were preferring to go back to doing those in person. Okay, so a couple quotes here. Refilling medications, that would not be any different whether it's a pandemic or not. There's a percentage of patient visits that could be done by way of telehealth very expeditiously and safely. I always think of every visit as sort of patient education. I'm really telling people stuff that maybe they don't know, or maybe they've got some sort of a cursory knowledge of, or maybe they've got the wrong knowledge of. So I mean, most of my visits are spent talking to people. And I really think that shouldn't be underestimated, that really what we're paying for in any kind of medical specialty interchange, we're paying for expertise. And so if that's conveyed via telehealth or whether that's conveyed in person, that's really the critical, core bit there. So things that cannot be provided well, I can't do joints over the phone because I can't manipulate those to see what's going on with them. And we've had some stop smoking groups, some pain clinic groups. That's pretty tough electronically. So I think it's a tool that people may want to use even when they don't have to, but we're going to have to strike a balance. So again, they're very reasonable about kind of the approach and recognizing the good and the bad. In terms of parity, they talked about a wide variety of experiences there. The payer mix is different depending on type of provider and the kinds of services they usually provide. So that's important to remember that, any kind of like what was being talked about before is that if you're changing policy pertinent to one kind of payer, Medicare or Medicaid or private insurance, that's going to affect different kinds of providers differently because they experience a different mix of those payers. So they talked about some similarities with in-person visits, and I think those are better represented via the quotes that I'll have. There's a range of actual knowledge about billing and reimbursement, because keep in mind that between providers and administrators, some of them are positioned differently in their organization. They may be more intimately familiar with the billing operations or not. And lastly, they did talk about some differences from in-person visits. So we'll get into the quotes here. So as far as I know, I believe the rates are, at least right now, are the same. And I think of all insurance companies are reimbursing for telehealth right now as well. We have a lot of Blue Cross Blue Shield out here, and I don't feel like we have felt the pinch at all as far as reimbursement. I think they've done pretty good. I haven't paid attention to a lot of the miscellaneous commercial ones to see, so honestly, I can't say because I haven't paid much attention. So again, that's that bit about payer mix, that for that particular person, one payer really stands out. Even with that, you still have a medical assistant to set up the visit. You still have to have the person answering the phone, the person who checks their insurance to make sure how much they're going to pay, and someone to collect the payment. So you really don't eliminate anybody in the office, you just eliminate the patient being present in the office. Looking ahead post-COVID, our participants talked about wanting to continue supportive and enabling policies for telehealth. They think it's here to stay. And they talked about ways that telehealth could be expanded, potentially with remote patient monitoring, school-based telehealth, or mental health services in nursing homes for those with very limited mobility, potentially. And the need for regulatory clarity and simplification was also brought up, in addition to support for audio-only visits. So again, this is the idea that the medical advice and expertise is work deserving of compensation. And for some patient populations, especially our mental and behavioral health participants brought this up, that actually exposure to the internet can be risky because they may be more vulnerable than others to things like scams. And so even, having that, having audio only for them is actually protective. So a couple example quotes here. So it costs big money to have a platform that is somewhat capable of doing what you want it to do. I don't know what the exact policy implications of that are, but I do know that if there is a draconian reduction in the reimbursement, then those two things together could be really devastating to any small group of physicians, no matter their subspecialty. And it is worth highlighting here that, the larger health systems have some more cushion, so to speak. But when we're talking about especially access in rural areas and helping rural practices, smaller practices, and physician groups, it's really critical to think about these kinds of things like overhead costs. Medicaid is like 75% of our fee revenue, so any little wiggle up or down, we feast or famine. The degree of our electronic interventions and treatment will be dependent upon public policy. So again, this idea that one payer is really important to certain types of providers. Now, this quote, I think, is really exemplary of not only the sentiments broadly across the 14 interviewees, but really across the majority of our 230 survey respondents also. This really rings true. So I think it's another arrow in the quiver, if you will. It isn't like, hey, I'd like to do this full time every day. But it is like, if we could get Mrs. Jones's medications filled with the telehealth visit, it's going to give me more time to get my charts done or see another patient, and it saves her the hassle of driving. And so in that way, it's very helpful. All right, so key takeaways here. Providers have experienced a variety of telehealth volumes. It's very dependent on patient population. The upfront investment was significant, and the technology is still evolving and needs to do so. Reimbursement policies affect providers differently because of their different payer mix, which is also tied back to patient population. And public policies are not going to affect them uniformly. And while telehealth is an important option, it will never replace in-person care. So what's up next for us is that we are conducting patient focus groups. And so that's the work I referenced at the beginning that's dually funded by the Health Fund and Reach Healthcare Foundation. We're seeking a wide variety of perspectives across ages, genders, races and ethnicities, and types of care received. The criteria are pretty simple for participation. So over 18, live in Kansas, have had at least one telehealth visit. Our first one is actually scheduled for this Friday. So I'm really excited to meet those participants and see what they have to say. So with that, I would be happy to answer any questions.
Thank you very much. When will you have your report, do you think, then on the patient focus group?
We're hoping by the time session starts.
All right, awesome. Questions, Representative Arnberger?
Thank you, Madam Chair. This is more of a telehealth 101 question. So I have participated in a telehealth visit. It was via phone call, and then I sent in pictures and that way. Is that typical, or video is more typical, or is it 75-25?
Sure, great question. So I can't give you a percentage per se, but the survey certainly reflected that video conferencing is the most common. So while I shared that our interviewees were supportive of audio only, that was not the most common experience. So most of them were talking about video conferencing, Zoom, or some other kind of proprietary platform that meshed with their EHR.
Okay, and the second question I have, and I'm just kind of thinking, I don't know if this is even a thing. I'm from rural Kansas and western Kansas, and do they already do this where there could be a hospital, or not hospital, a doctor's office where there is a nurse there, but they teledoc in, or they telehealth a doctor in, and it's a video, so it's more of a hybrid?
Yep, absolutely. Yeah, I think that brings up another really key thing about telehealth is that it's not a monolith. Like, it doesn't all look the same. There are a lot of different models out there. So I'm on another project with the University of Kansas Health System called the Telebehavioral Health Network. And so patients in that have the option to either dial in to a specialist in Kansas City from home, or they can go to one of the participating primary care clinics in rural communities and actually sit in a room that's dedicated to telehealth. And so that way they don't have to provide their own device. They don't have to worry about connectivity. They have a staff person right there to make sure that nothing goes wrong with the technology, and that has proven to be really successful. Their volumes have gone up over time and sort of reached a nice steady state, and I think has really expanded access to mental health services. We have I think 11 participating communities across rural Kansas right now, so that's one example. But yes, there's sometimes you also call it like provider to provider connection, where there is a provider on both ends. So that certainly happens when we're talking about access to specialty care. But for things like primary care and mental health, usually that is the patient at home or in a location of their choosing. Sometimes they're able to go into the office. So.
Gotcha. Thank you. I am glad that's going on, but I was hoping I came up with a really good idea. So,
well, if you have more ideas, we'll take them. I mean, yeah.
Thank you. Committee, are there further questions? Senator Hawk?
Representative Arnberger made me think of a follow-up question to that. Are there regulations that prevent a provider, for example, a doctor, from being out of state? So maybe I'm getting my service from my Manhattan doctor's office, but there's a specialty piece of it. Does that doctor that may be in Denver not qualify for reimbursement because they're not in Kansas? Are there regulations in terms of how far that connection can be?
Yeah, that's a great question. So my understanding is that during the pandemic, some of the licensure restrictions have been more flexible. But I'm not an expert in this area, so I can't tell you for certain. But my understanding is it would be in the purview of the Board of Healing Arts and BSRB and the licensing agencies in Kansas to say whether or not that's the case. So whether to say a person residing in Kansas could dial in across state lines and do that, or whether they would require that out-of-state provider to be licensed in Kansas. So I believe that ball is in the court of the regulatory agencies here, but like I said, I'm not well-versed in that.
I'm curious, maybe staff could research that and see if there are licensure restrictions that permit that or prohibit it. I'm just curious. Thank you, Madam Chair.
Committee, are there further questions? I have one, and I think it's important if you make sure that when you're talking with folks in regards to their insurance and how it works, is what's the impact with high deductible plans?
Yeah.
Because I think that's kind of getting lost in the mix of things here. When the rate parity question gets raised up, that's one of the things is that it's fine to increase those rates, but at the same time, then who's it impacting? And people with high deductible plans are normally sitting on some fixed incomes and different things like that. So that would be good to see. And then and this was a comment that I actually made yesterday in the working group, was, when they're asking, when the legislature's being asked to come in and do this rate parity, then it's putting the government between the healthcare provider or mental health provider and the insurance company. And that's not really a good thing for, I don't think, for the government to be in, because those are contractual agreements. And, what one insurance company pays this provider, what another company pays, those are all designed through the contractual. It depends upon what their networks are, et cetera. And I'm not quite sure how we get individuals to understand it's not as simple as saying, okay, we're going to do rate parity so that whatever the rate is. Because if we set it, we giveth, we also taketh away.
I
And that's
understand.
just the way government works. So,
Yeah. I didn't jump in the other day when that came in, although I heard that remark. And I would offer that, at least in my experience, studying policy, it is a very different thing to set guidelines, around type of care and modality versus price setting. And I don't think anybody is asking you to set prices within a contractual arrangement. But I would say that, this to me harkens back to the idea of mental health parity, where, it's a broad sort of declaration that we would like mental health care and physical health care to be viewed the same way and to be viewed as equally important, and treated similarly. So in my mind, this is a question of, modality and making sure that we also use the existing mechanisms we have to hold providers accountable. We do want to make sure that the same quality of care is being delivered regardless of modality. And I think all the people I've talked to, both the survey and in the interviews, want that too. Nobody's getting rich off of telehealth, and nobody's, at least that I've talked to, is wanting to do anything nefarious. So I thank you for the opportunity. And any other questions?
no, that was just, I just wanted that to kind of be out there for people to kind of stop and think about that. Because if we were to get into that, is then perhaps everybody would be excited to have our Medicaid rates. And I don't think that they would be. And it's almost as if, we've got some providers then that are wanting to make up the difference in a Medicaid patient rate versus a private pay rate.
Okay. I can understand how that would be a concern that has not come up yet in our work. So.
Yeah, so there's just a lot of different ways to look at it. No one's got a hard, fast no, because it's a very complicated issue. Insurance itself is very complicated.
Absolutely.
And, yeah, we don't want to go down that path. So are there other further questions? But, we're looking for real solutions. So that's why we want to make sure everybody's looking at everything out there so that we can come back with a hopefully a consensus on something. So thank you very much for being here today. We appreciate it.
You're most welcome. Thank you.
All right, committee, that takes care of our morning work. We will break for lunch, and I will ask that you be back here at 1 o'clock, please. All right, we're going to go ahead and call things back to order here. And I believe that Matthew with KLRD has a update for us.
Thank you, Madam Chair, members of the committee. I just wanted to provide an update with regards to the $5 million for the statewide mobile response and mobilization on the chart. Before you should be a copy of the enhancement sections of this year's budget analysis for the Department of Children. For children and families, KDAD's, it was included in that because of the ERO. So if you look on the first page, you see a giant chart. Includes DCF enhancements and KDAD's enhancements. The third one from the bottom for KDAD's is the statewide mobile response, $5 million. You can see that that was requested by the agency and included in the governor's recommendation. On page 96 of that document, the second item from the top, the second bullet is kind of the description of it. And as I stated earlier, it is due to the 988 number. Individuals who call that number would receive who need additional services. These funds would provide that. And I had that clarified throughout session with the agency, helped to differentiate this pot of money from that $3 million that the legislature added. One thing that I would know is that because this is DCF's budget analysis as well, there is that enhancement for a very similar program with DCF for children in foster care. So there's sort of the word is escaping me, but they're sort of parallel enhancement requests, all related to those providing those services for someone who calls the 988 number and is found needing additional funds. And as I stated earlier, these are for those individuals who are uninsured. If they're on Medicaid, there's some funds that are thrown into caseloads for that. If they're on private insurance, they would be billed for private insurance. But these funds were envisioned as for uninsured individuals.
Thank you for that, Matthew. I guess that I would like for us to get more detail on exactly what that $5 million is being spent on. And I wasn't aware that the crisis hotline out of Lawrence, which is actually the state of Kansas national hotline, and then ComCare Wichita became one, and now actually there's one in Johnson County to help handle these 988 calls. But
And I will just note that this would have been created prior to sessions. So some of this, I mean, if there are developments afterwards in terms of those crisis centers, it wouldn't be reflected in this document. But this was the information that I had at the time that we drafted it last fall.
yeah, but I just didn't realize that Lawrence I thought that was just a call center, that they would be, sending one. I'm totally confused, Matthew. Representing Ballard, are you as well, or?
Well, I thought, yeah.
Yeah, so anything that the agency can bring back to us, Matthew, I think that would be good. It's like, what are they using this money for? What are they doing? Where are they doing it at? Is it just in Lawrence and Sedgwick County? Are we doing it in other areas? Because, see, when we talk about the 988 the suicide prevention hotline, and we talk about mobile services within that, we are talking about services statewide, not just where these call centers are at. And then people are like, well, how do you handle that in a rural area? And if I recall correctly, and it's not always good for me to try to remember things through the session, is they had to be within an hour. We would be able to respond within an hour in our rural communities. Yes, Representative Ballard.
Thank you. I'm trying to think. I think Lawrence is like the hub.
Yes, because they're the national.
Yeah, okay,
right.
so we would be like the hub, and part of that would be seeing that we answer from there and make sure it goes out all over. Now, that I know.
No. Mm-mm. No, actually, what'll happen now, because it does have a domino effect, is if Lawrence couldn't handle the call, then the call got routed to ComCare. If ComCare couldn't get, which is within so many rings, and if that doesn't happen, then it can roll actually to Colorado, Oklahoma,
Right, so it's a
Missouri,
roll-
Nebraska.
It's a rollover.
Yeah, total rollover.
Okay.
And we're expected to handle the calls and not have to deal with that rollover. Yes, Senator Hawk.
Just a question in terms of wanting some more information. It sounds like what is stated here is that $5 million goes to provide services that might be at a number of different places, whether it's community mental health or a private provider, from somebody who calls in needing services. And I don't know if I'm reading that correctly, so, but it sounds like that's not for the call center specifically as much as it is to provide service to the person who calls in needing help. But I don't know if I'm interpreting that right, so.
Well, and that's where this kind of becomes confusing, because if you go down there to, it says these services are currently grant-funded pilot programs that the agency seeks to sustain and expand. I'm just not aware of what those services or what we were funding, who those pilot programs were, et cetera, and I don't believe that you could recall that either, Representative Ballard, and that's a budget that you work on extensively. So I think we just need to understand what is that $5 million. Because there's no sense in us duplicating anything, you know, in what we work on with the 988. Because the only thing that held up the 988 last year was the fee on the phones. So, anyone else with questions? Senator Fagg.
Thank you, Madam Chairman. Matthew, you mentioned Medicaid in there when you was talking. Can you kind of talk just a little bit on that part?
Certainly. So as I indicated, my understanding is that this pot of money is for those uninsured individuals if they call and they don't have uninsured. So if there are individuals who are on Medicaid, that reimbursement would come from Medicaid and would be funded. It's through our caseload process. Every fall and April, we go through and do human services consensus caseloads. If you had your chart, the chart that we went over this morning, there's the under mental health services, the very first line item, Medicaid/CanCare. That would be where those sorts of payments would show up, because those would be reimbursements through Medicaid.
Further comments or questions?
Just one.
Representative Ballard.
Thank you, Madam Chair. You know, we did not in social services discuss in detail 988 because of the opening, you know, in the summer. But maybe we will this year, but I think we need a better understanding of how this really works. I mean, know what we talked about, but what is it that we don't know?
On the 988?
Mm-hmm.
Well, and that's where I would recommend that your chairman, Representative Carpenter, have Andy Brown, because Andy Brown's in charge of that whole.
Okay. Now, maybe we will. We just didn't go through it.
Well, you
this
probably
past
did it
year.
because Health and Human Services was dealing with it.
Okay.
You guys didn't have it.
Yeah, so we really didn't have it. And I was looking at Representative Lynn. We didn't really have it. I knew about it because we had talked about it. We also discussed it on CanCare and everything else. But I didn't quite know exactly how. But I know it didn't kick in until July of 22. Am I correct?
Yes, July 16.
Yeah, like that. So that, well, so this year I'm sure we will go through it and then I'll be able to answer.
Right. Okay. Have we made that as clear as mud, Matthew?
I believe I've got the request, and we'll.
If not, holler at us. We will try to make it even more clear, or muddier, whichever. Thank you. I appreciate this very much. All right, committee. We have a presentation on other states' approaches to telehealth from Jack Pitzor, Policy Associate, Health Program, National Conference of State Legislatures. Are you with us, Jack?
Hello, yes, thank you, Madam Chair and members of the committee. Checking to see that you all can hear me and I am sharing my screen now. So yes, thank you, Madam Chair, members of the committee. My name is Jack Pitzer. I am a policy associate with the National Conference of State Legislatures Health Program. And I am really appreciative of the opportunity to be talking to you all a little bit today about state telehealth policy and ways that states have been increasing access to telebehavioral health services both during and after the pandemic. And a quick personal note, I was actually born in Lenexa, Kansas, so not too far from where you all are gathered today, and lived in Kansas for 10 plus years. And my first NCSL trip was to Topeka to assist with a presentation to you all a little over 2 years ago now. So lots of Kansas pride, and all the more reason I'm excited to be talking to you all about this very timely topic.
So I guess the question is, it K-State, KU, or Wichita State?
That's a great
don't
question,
answer that.
Madam Chair.
I wouldn't answer that if I was you.
We'll address that in the Q&A if need be, but maybe maybe I'll try to avoid that question. But yes, so I'm sure many of you are well aware of NCSL and our role, but just in case a few of you are not familiar with our organization, the National Conference of State Legislatures is your bipartisan membership organization for all state legislators and legislative staff. And our purpose is to really strengthen the legislative institution. And we do this through a variety of different services for our members, and this includes conducting individualized policy research requests, creating connections with legislators and legislative staff in other states, and then providing technical assistance presentations like I am doing for you all today. So for today's presentation, I'll be talking about state telehealth policy broadly, and then also telebehavioral health specifically. And I'll start off with just a very brief overview of telehealth, and then really dive deep into some state telehealth policy actions that fall under the categories that you see listed here on this slide. And then I do not plan to talk your ear off for the entire 40 minutes I'm slated to present to you all today. So I'll definitely leave time for Q&A, potentially that K-State, KU, Wichita State question, but potentially not. So for the presentation, before we dive deep into some content, I thought it would be helpful just to define some key terms and do some level setting. So when we talk about telehealth, we're talking about using technology to deliver healthcare services or health-related services remotely to patients. And this includes communication and education between patients and providers, as well as opportunities for providers to connect and consult with other providers. And then we often discuss telehealth within the context of mitigating healthcare workforce shortages. But of course, telehealth doesn't extend the number of healthcare workers that we have, but instead looks at extending their capacity and their potential reach. And then telehealth itself is not a service, but rather a means for delivering healthcare services. So that's why you'll hear me sort of use the wordy phrase delivering healthcare services via telehealth rather than saying telehealth services. And then when we're talking about telehealth, we're often referring to 3 different modalities or methods for delivering services virtually. And these include real-time communication, which allows patients to connect with their providers often via video conferencing. Then there's store and forward telehealth, which is the transmission of data, images, sounds, or videos from one care site to another, which then a provider at that care site evaluates that information. And then there's remote patient monitoring, which involves collecting patients' vital signs or other healthcare data while that patient is in their home or at another healthcare facility. And then a provider looks at that health information and then can provide follow-up services as necessary. So states were increasingly enacting legislation related to telehealth before the pandemic, but COVID most definitely accelerated this trend. So all 50 states, DC, and Puerto Rico modified their telehealth policies in response to COVID in some capacity. And a lot of this happened legislatively, but a good number of state policy actions occurred in governor's offices, state Medicaid agencies, licensing boards, and other state entities. And then a lot of these actions were also tied to governor's state of emergency declarations and thus temporary for the duration of the public health emergency. But a lot of states have been doing a lot of forward thinking and looking at what changes they've made and trying to decide which of these they'd like to keep for the long haul. So NCSL released a toolkit on telehealth for state legislators back in July of 2021. And as part of this toolkit, we looked at enacted state legislation that takes some of these COVID modifications and permanently incorporates them into state law. And we found that at least 37 states enacted over 51 bills to make some sort of temporary change permanent. And these touch on a wide variety of different policy topics, such as private insurance, Medicaid, cross-state licensing, online prescribing, you name it. And then while legislation most definitely was looking at leveraging telehealth broadly, behavioral health was for sure a priority for many states and the legislation that they were enacting. So with this flurry of legislative action, the telehealth policy landscape looks quite different. And we'll take some time here now to kind of look through some current 50 state trends related to telehealth, and I'll pull some examples that touch on behavioral health. And we'll start with Medicaid. So a lot of states have focused efforts on Medicaid coverage for telehealth and telebehavioral health. And a big part of that is because Medicaid enrollees have a higher rate of behavioral health issues compared to the general population. And states also have a great deal of flexibility in determining Medicaid reimbursement for telehealth. And this often can occur through state legislation, but it's also a lot of policy actions taking place within Medicaid rules and regulations. And through these policy actions, states are determining whether to provide reimbursement for telehealth, which services are eligible for Medicaid reimbursement, who is eligible for providing those services via telehealth, where in the state it can take place, and a whole host of other considerations. And then another way to assess Medicaid coverage for telehealth is to look at which modalities state Medicaid programs reimburse for. So all 50 states and DC provide some level of reimbursement for live video visits, though what this exactly entails varies quite significantly across the states. And then there are at least 22 states that allow for the reimbursement of store and forward technology, and then 29 that reimburse for remote patient monitoring. Beyond different telehealth modalities, which is the how healthcare services are delivered via telehealth, a lot of states are looking at which and what healthcare services are eligible for Medicaid reimbursement via telehealth, and then which providers are authorized to deliver those services. For example, Arkansas enacted legislation that permanently authorized Medicaid reimbursement for certain telebehavioral health services that they allowed for the COVID-19 state of emergency. And this includes services like counseling, crisis intervention services, substance use assessment, group therapy, and others. And then the legislation also touches on which providers are able to deliver those services virtually and eligible for Medicaid reimbursement. And this includes certain providers like psychologists, counselors, marriage and family therapists, and then social workers. Colorado enacted legislation authorizing Medicaid reimbursement for peer support specialists. And these are individuals with their own history of behavioral health issues. And that legislation also indicated that peer support specialists can receive Medicaid reimbursement for services delivered via telehealth. Pivoting from Medicaid to private insurance, there are at least 43 states and DC that have state laws dictating private insurance coverage for telehealth in some capacity, though what exactly this entails, such as what private insurers need to cover, and in some cases what they need to reimburse for telehealth, varies quite a bit. So there are 41 states in DC that require coverage parity, and that means that coverage for telehealth must reflect what private insurers are covering for in-person services. And then there are 22 states that require private insurance reimbursement for telehealth to be on the same basis or at the same rate as in-person care. And this is referred to as payment parity. Now, there are various differences in how states write these payment parity laws, and it's my understanding that you all are looking into this issue separately with the Kansas Health Institute, so I don't want to get into too much detail on this, but I did want to pull a few state trends that do touch on telebehavioral health in particular. The first being that instead of requiring payment parity for all healthcare services that can be reasonably delivered via telehealth, a few states this year, Iowa, Nebraska, Massachusetts, and Rhode Island, they mandated payment parity for specific healthcare services. And all 4 of these state laws touched on telemental health and requiring payment parity for telemental health. Then outside of the payment equation, states have been updating private insurance coverage requirements for telehealth in other ways. So Maryland prohibited insurers from denying coverage for behavioral health services just because those services may be provided via telehealth. And then Utah required private insurers to cover telemental health if they cover in-person mental health treatment. Now I want to talk a little bit about one of the areas of telehealth policy we've seen the most action recently, and that is increasing access to audio-only telephone consultations. So before the pandemic, most states very much restricted or outright prohibited telephone consultations as a accepted version of telehealth delivery. But a lot changed with the pandemic, and many policymakers saw audio only as an effective way to overcome the technological divide, such as allowing older patients to increase access to telehealth, and then also looking at areas with poor broadband connectivity. And then also a lot of researchers have pointed to audio only as particularly conducive for delivering behavioral health services, though some researchers also contend that without the video component, a provider may miss certain cues during a telehealth visit. So with all of that, there have been at least 29 states that have enacted legislation that expands access to audio-only telephone coverage telephone visits in some capacity. And some state legislation simply lifts previous restrictions that may have been in place for audio-only, and then some state legislation requires or authorizes audio-only coverage through Medicaid, private insurance, or both of these payers. However, a lot of states are still maintaining certain restrictions on audio-only visits, and the way that states are going about authorizing, covering, and reimbursing for audio-only vary significantly. So, for example, Georgia updated their definition of telehealth to include audio-only visits, but under specific circumstances, such as live video not being available to the patient or there being poor broadband connectivity. And then it also limits payment parity requirements for audio only just to behavioral health services. And then Tennessee enacted legislation that authorizes audio only telephone visits for behavioral health services, and then also only when other telehealth technologies like store and forward and live video are unavailable. And then Washington enacted legislation requiring private insurers and Medicaid to reimburse for telehealth at parity, but it included the caveat that beginning in January 2023, there needs to be an in-person or an established provider-patient relationship before a telephone visit can occur, and that entails an in-person visit within the last year. Okay, so with the sort of coverage side of telehealth covered, I wanted to pivot to talk a little bit more now about certain requirements that affect providers looking to use telehealth. So telehealth providers often have to be licensed in the state where the patient is located, as well as where that provider is located. And because trying to get multiple licenses can be a very burdensome process. A lot of states have looked for ways to streamline licensing requirements and better facilitate telehealth across state lines. And one of the most common strategies to do this is to join a provider licensure compact. So states must enact conforming language with the conforming legislation that has the same language to join a compact, which then allows specific types of providers to deliver services to residents that are in other member states. And this can include both telehealth as well as some in-person services. There are currently 6 active compacts for providers that I have listed here on this slide. And one of the probably more pertinent compacts for our conversations today is the SIPAC, which is used to try to facilitate telepsychology across state lines, as well as some temporary in-person services. There are currently 23 states in DC that are participating members of the SIPAC, and then 4 states, including Kansas, that have enacted legislation to join the SIPAC, but their participation in the compact has yet to become fully active. One thing to note is that provider licensure compacts, in order for them to become effective, there typically needs to be a certain number of states to enact legislation to join the compact. And so there are a couple different licensure compacts that have yet to become effective because they haven't reached that state threshold. And one of those includes the counseling compact. So the counseling compact allows professional counselors to deliver healthcare services to patients in other member states. And it includes both some in-person services as well as counseling through telehealth. And Georgia and Maryland were the first 2 states to enact legislation in 2021 to join the counseling compact. But in order for it to become fully effective, there has to be 8 more states to meet that 10-state threshold. And then beyond licensure compacts, some states, specifically Arizona, Florida, and West Virginia, have taken a bit more of an expansive approach, and they're authorizing almost any type of licensed provider to deliver services to in-state residents via telehealth as long as they meet certain conditions. And these include that they must hold similar licensure in their own state and be in good standing with their licensing board in their state. They have to register with a state licensing board or Department of Health. They have to pay a registration fee, and then they also agree to not set up their own practice in that state. And while these interstate telehealth flexibilities touch on providers like physicians, nurse practitioners, physician assistants, who all do play an important role in meeting the behavioral health needs of patients, they also touch on a variety of different licensed behavioral health providers. And these include providers like psychologists, professional counselors, social workers, marriage and family therapists, and a host of others that I have listed here on this slide. And then there are a few examples of states streamlining or waiving licensing requirements and better facilitating telehealth across state lines, but in limited circumstances. So New York, for example, enacted legislation this year to establish an interstate licensure compact with neighboring states or other states in the Northeast region. And the state legislation requires the program to focus on areas with historic access issues, particularly for specialty care services. And then Utah must have had a sort of crystal ball situation going on and predicted that people were going to be moving around a lot because of the pandemic, because they enacted legislation in 2018 that allows a mental health therapist to continue seeing a resident that has recently moved to Utah, but it only allows this mental health therapist to continue seeing their client for 45 days, and then that patient must seek out another provider within the state of Utah. So moving from the cross-state licensing world, but sticking in the world of provider requirements, a lot of states have been looking at which types of providers are eligible to be delivering healthcare services, and then determining whether there are other types of behavioral health providers that they should add to this list of telehealth providers. California, for example, updated its definition of healthcare provider to include associate clinical social workers and associate professional clinical counselors for the purposes of delivering healthcare services via telehealth. And then Illinois authorized licensed certified substance use disorder treatment providers, which is a mouthful, to use telehealth. And then Tennessee authorized students that are in graduate programs for health professions, but that have yet to reach their full licensure to deliver services via telehealth. And the legislation specifically lists drug abuse counselors as one of these providers. And then a lot of states have taken action to expand the number and types of settings where patients can be located when receiving healthcare services via telehealth. Because before COVID, it was kind of common practice for a patient to have to go to a facility that had telehealth capabilities in order to receive virtual services. But that could be a barrier if the patient has to travel long distances to the nearest provider or the nearest facility, or if they lack access to transportation services. One of the more common flexibilities that states really looked at enacting was allowing for patients to receive services in the comfort of their own home. So states like Oklahoma and Tennessee updated their definition of originating site, so where the patient is located when receiving a telehealth visit, to include the patient's home. And then recognizing that the pandemic has had a pretty significant mental strain on our on young people and on students, a lot of states have been looking to try to increase access to telehealth within the school setting. So Georgia updated its definition of originating site to include a lot of different locations, including schools. And then Iowa enacted legislation in 2020 that authorized telebehavioral health services to occur for kids in school settings after there's been an established provider-patient relationship and the parent or guardian consents to telebehavioral health services being provided. There are some states like Kentucky and Mississippi that enacted legislation authorizing federally qualified health centers and rural health clinics to count as originating site for telehealth. And they also allowed these sites to count as distant sites, which is where the provider is located when delivering services via telehealth. And then both Kentucky's and Mississippi's legislation authorizes these facilities to receive reimbursement for telehealth via Medicaid programs. And then lastly, there are a few states that have taken a little bit of a broader approach to redefining the originating site. And they typically write out the definition of originating site to be something like where the patient is located when receiving services, and not limiting telehealth visits to a specific site. And two examples of states doing that this legislative session are Maryland and New York. And then I lastly wanted to touch on how federal and state policymakers have lifted restrictions on prescribing via telehealth, often for certain substance use disorders. So during the COVID-19 pandemic, federal agencies lifted certain requirements for initial prescriptions and follow-up prescriptions for medication-assisted treatment, or MAT. And this included lifting the requirement that an in-person consultation occur before prescribing buprenorphine, which is used to treat opioid dependency. And then additionally, federal policymakers kept in place a requirement that methadone still not be initially prescribed via telehealth, but it did allow for subsequent methadone appointments to occur via telehealth. And then states have pursued various flexibilities of their own to look at leveraging teleprescribing. And these include actions that are specific to the public health emergency and limited to that duration, and some that are permanent beyond the PHE. So Vermont, back in March of 2020, allowed providers that are already authorized to prescribe buprenorphine to renew a patient's prescription without there having to be an in-person office visit. And this is a flexibility that will last through the duration of the public health emergency. Virginia authorized providers with an established provider-patient relationship to prescribe Schedule 2 through 5 drugs, which includes all prescribed drugs, via telehealth in accordance with federal law. And the legislation also notes that this provider-patient relationship can be established through a telehealth visit as long as it is in line with federal law and requirements. And then some states still are maintaining certain restrictions on teleprescribing. So that legislation in West Virginia that allowed out-of-state providers to deliver services to in-state residents via telehealth prohibits these providers from prescribing Schedule 2 through 5 drugs via telehealth, even if they are authorized to do so in their own state. So that is all I have for you all today. I've left my contact information if you want to reach out to me directly. And then I also have some NCSL telehealth resources here. There's that telehealth toolkit for state legislators that I highly suggest you check out because it does touch on pretty much every single aspect of telehealth policy. And then also, I wanted to wish you all a happy early National Rural Health Day. This is in my slide because it is live today and not in the handout, I don't think. But tomorrow is National Rural Health Day, and we just had a magazine article that touches on rural health policy and also includes a little bit on telebehavioral health. And then there's also a few legislative databases where we track legislation related to telehealth. And with that, I'll pass it back over to you, Madam Chair, and I'm happy to take any questions.
All right, thank you very much, Jack. Are there questions or comments for Jack? Senator Hawk.
Thank you, Madam President. And
What?
Madam Chair, I just want to keep advancing you.
No, that's an insult, just so you know that.
Let me start over. You know, I was so focused on that K-State, Wichita State question, but I'm going to let that just lie now and get to the meat of it. Yeah.
Well, I figured there was 3 of us at least in here representing those communities, so we were going to let him, I wasn't going to let him bury himself.
Okay.
I appreciate that.
You were very
Madam
kind.
Chair.
So my question is about the Psych Pack and the Counselor Compact. Those compacts, do states have to have enabling legislation to allow those providers to provide service and get reimbursed, say through Medicare or through Medicaid, or once those compacts exist, does that automatically allow those providers to be reimbursed or paid when they're out of state?
Yeah, that's a great question. So, and thank you for that question, and thank you, Madam Chair. So the way that it works to join is that there is this conforming language that is uniform across all the states, and then a separate entity is the one that sort of kind of manages it, but states still do have a lot of authority over those providers that are delivering healthcare services via telehealth. The Medicaid reimbursement, I don't want to give you any wrong information, so I can follow up with you, but that is something that is addressed in licensure compacts for sure, because that can get a little bit tricky working with different state Medicaid programs across the board. But I'm happy to follow up with information and sort of way states and compacts have been looking at that Medicaid reimbursement question.
Okay. Are there further questions or comments? Were you able to see, Scott, when ours goes into effect, our Psych Pack? It is January 1. It's January 1 is when ours goes into effect. So that was legislation we passed this year. So that's why it said, when I seen it said inactive, I was like, oh, wait a minute. And then I remembered we had a delay on it.
Are we in the Counselor Compact?
This is the first I've heard of Counselor Compact. So I'm assuming, Jack, that that's a different category. Is that correct?
Yes,
Would that
Madam
be
Chair.
social workers?
So that's specifically licensed counselors. So it's, the SIPAC is for psychologists, and then licensed counselors is for the counseling compact. The counseling compact is a little bit, it's very much new to the scene, which is why there have only been 2 states that have enacted legislation to join it, and it was this most recent legislative session in 2021. There are a few other states that have looked at have looked and introduced legislation to join the counseling compact, but it's likely something that a handful of more states will be looking at for 2022 legislative sessions. But the reason it's kind of new, which is why there's only 2 states that have joined so far, and those are Georgia and Maryland.
Yeah, and yeah, I think we're going to see more compacts occur. Representative or Senator Hawk.
You were reading my mind again. No, it seems like we need, in terms of reciprocity, we need at least the clinical social worker, addiction counselors, marriage and family therapists to go along with the other ones that we have. Is there anything in the wind to get other compacts organized similar to the Psych Pack and the Counselor Compact?
Yes, thank you, Senator and Madam Chair. So it's, I believe there is another compact that's sort of in the works for marriage and family therapists. The Center for Connected Health Policy, they do a really great job tracking a lot of compact work, and they've cited that as another one that they're sort of looking at, but it's also a little bit newer, and I don't know if any states have actually joined. So that's another one that's sort of in the works, but other than the ones that are already active that I have on those slides, it's occupational therapists, counselors, and this marriage and family therapists are sort of the ones that are newer to the scene and in the process of seeing if there's enough states to join in order for it to become active.
So it kind of gets led by the groups and organizations themselves. So I believe the only 2 that we've got, I think, is the Nurses Compact and then the Psych. Does that sound about right? I always put Scott on the spot and and he sits there and looks so kind, but he's probably mouthing something behind that mask. I just know he is. Now he's turning red. I like that. No, but I think we're going to see more of that in the future, but it's not really been legislative driven because, like you said, you've got to get other states to decide that they want to join into, otherwise you don't have a compact. So, but I think it's a thing of the future because I can see, more and more of this happening as the telehealth continues to grow, that in order to help with some of the workforce issues, that maybe then you can pick up some people from, outside your own borders, whether it's in your community and within the state, or you go outside the state and reach across state lines. Senator Hawk.
What is the magic number of 10 states for a compact? Is that congressional law, or where did that come from?
Yeah, that's a good question, and another one that I don't know off the top of my head, Senator, but I'm happy to look into that one and send you all the provider contact information. But yeah, I think there's kind of 2 ways, from my understanding, the way that it can become active is that it's a certain number of states. So for the counseling compact, it's 10, and then or if it a certain date, whichever one comes first, but. Typically, there's a lot, especially this last legislative session, there's been a lot of states that have been looking at the counselor compacts and a lot of states enacting legislation on them. So it's sort of that magic number which is driving activation. But we'll definitely follow up with sort of how exactly that is determined.
I only ask that because I wonder if that number is only for counselors and if these other groups, could there be other numbers, and just wondered why 10. But thank you.
Committee, are there further questions or comments? Anyone online? All right, Jack, thank you very much for being with us here today. And I think that this is an area that we're definitely going to see some expansion on. So we'll look forward to what other information you are able to provide us. So appreciate you being with us today.
Of course. Thank you, Madam Chair. And yeah, feel free to reach out with any additional questions after the committee today. So
All right, thank you. Okay, committee, now we're going to have a presentation on workforce issues. That's probably our toughest topic in this whole realm that we're dealing with. So first I have Marley Doyle, MD, Director of Behavioral Health Education Center of Nebraska. Welcome to committee, Marley.
Much, Madam Chair and the rest of the members of the Senate committee. I'm honored to be here today. I am one of the neighbors from the north, from Nebraska. So I think I have 10 minutes, correct?
Yes.
All right, well, I don't have a PowerPoint provided, so if you need to cut me off, feel free. And I was just going to plan on talking a little bit today about what we have done in Nebraska to solve our workforce challenges. Well, I shouldn't say solve, I should say to try to make an impact on our workforce challenges. So we have a program at the University of Nebraska Medical Center called the Behavioral Health Education Center of Nebraska. We call it Beacon for short, BHECN. And it is the Behavioral Health Workforce Development Center for the state. So I wanted today to discuss how the foundation of Beacon came about, the programs and mission that we live by, as well as future directions and areas of growth for the future. So first is just the demonstration of need, and this isn't really anything new to anyone here, hopefully, but behavioral health services are in demand, and probably even more so as we go on in the future, especially in light of the pandemic, which has uncovered a lot of mental illness and substance use disorders that have previously not been acknowledged at such high rates. So about 1 in 5 Americans have a mental health disorder or a substance use disorder. And that seems to be true depending on the geographic area, but overall it's pretty consistent throughout all the states, throughout all parts of the country. And in rural areas in particular, urban underserved as well, access to behavioral health care services can be very limited, if not impossible. So what we look at is these areas called behavioral health shortage areas, and that's determined by HRSA. And they basically look at the number of providers per geographic area and compare that to the number of providers estimated to be needed for that area to meet the need for all mental health needs and diagnoses. So in Nebraska, we are definitely, most of our counties are designated as shortage areas, about 95% of our counties actually. And I was kind of looking in preparation for this for Kansas because our states are very geographically similar. And it's pretty similar. So you have adequate, or not adequate, but near adequate numbers in the more urban areas, but then it starts to drop off the farther you get from the cities, which is the same pattern we see in Nebraska. And HRSA estimates that currently Kansas, you have about 33% of the need met for behavioral health providers. So there's definitely room to improve. So how do you do it? And what's the importance? Well, we know the importance is just improving the quality of life for your citizens, but not only that, people with untreated mental health disorders have very high rates of disability, missing days of work, decreased productivity. It really affects not only just their personal lives, but it has a ripple effect and affects things on a big economic stage as well. So the Behavioral Health Education Center of Nebraska was founded in 2009, and it was a partnership between the University of Nebraska. There was a group of people there that really felt like this was an area that needed improvement and the needs weren't being met. So they came up with a plan to improve the pathway from student to behavioral health provider. And what took it down to the legislature and got state funding in 2009. And so it got approved. It was supported pretty unanimously by the state legislature at the time because there was a growing need and recognition that untreated mental health disorders were very detrimental. And at the time there was, going back in history, right around 2008, the recession, a lot of Nebraska's farmers were having a really difficult time. The farmer suicide rate was up. So it really was becoming apparent to everyone that this was a need that was being unmet. So after that got passed, we have been a line item on the budget since then. And so we are charged by the state to basically improve behavioral health access to rural and urban underserved areas by increasing the number of behavioral health providers. So how we have done that through the years is to focus on a few mission areas. So one is recruitment. We start in high school and work with students in mentorship programs and educational opportunities all the way up through graduate school and postgraduate training. And then the second part of our mission is retention. So not only do we need to get more students to go into the behavioral health workforce, but we need to keep the people that we have in the workforce continuing to work. So we provide free continuing education opportunities. We do a lot of work with burnout, compassion fatigue, preventing people from leaving the field, and also looking at licensure requirements because we want to be aware anyway of how we compare to other states, so we don't lose some of our students to other states that might have different licensure requirements that make it easier to practice. So those are kind of the recruitment and the retention are our two main mission areas. The other thing that we are very passionate about is continuing to study the number of behavioral health workforce providers in our state. So we have implemented a workforce data survey every 2 years. And what we do is send a survey to all behavioral health providers that are licensed in the state of Nebraska. We ask them where they're practicing, how they're practicing, if they're doing telehealth. We have a whole series of questions. And then from that data, we can tell who is practicing where, what license they have, and then we compare that to the state's licensure data. And we can get a pretty good snapshot of what our current workforce looks like. So since we started gathering that data in 2010, our behavioral health workforce has increased by 38%. And this is pretty unusual. It's pretty astounding because in most states, we're seeing behavioral health providers, the workforce is going down. And so the fact that we have gone up by quite a bit has been quite impressive. And of course, we do not take full credit for this increase. I think that the credit goes to the partnerships that we've developed, and as well as just awareness and our state prioritizing behavioral health and continuing to support us through the years. Since we have been founded, we have expanded a lot of our programming. So it's not just, capturing the data and then just reporting on it. It's allowed us to use the data to identify programs that will be successful in the long run. And so what we have done is we have kind of our main campus in Omaha out of the University of Nebraska, and then we've developed 2 satellite sites since we were founded. One in Kearney, which is in central Nebraska. There's the University of Nebraska Kearney that is there. So we work with a faculty member and have a small satellite center there. And then we also have a Beacon Panhandle, which is western Nebraska, and there's Chadron State College. And so the center there operates out of Chadron State. We're in the process of developing a Beacon Northeast, and our goal is eventually to have a regional presence in each area who can identify the specific training and education needs for that area. Because it's different. It's what we need in Omaha is very different than what they need in North Platte or very frontier Nebraska. So we have learned through the years that it's very important to work with the communities and hear from them directly, rather than us just trying to kind of come up with stuff that we think is going to work. We've also worked really hard on engaging our students, providing them with mentorship opportunities. We now have a student advisory board that helps us determine programs that will be successful with students, because again, we need to hear it from them. And that has been incredibly successful. We've developed all sorts of ideas from hearing from them and have had very successful mentorship dinners. And we developed a program called the Ambassador Program, which works with students starting from high school and up. To date, we have reached over 5,000 students as part of the Ambassador Program. And so I would say that, in summary, we are very active. We're very focused on what we can do to help solve the problem of access through the pathway, through the career pathways. And of course, this doesn't solve everything. There still is a lot of barriers to access that need to be addressed in conjunction with the workforce. But you can build all the services you want, but if you don't have the workforce to support them, it's not going to make any difference. So we believe that we are a very integral part of this puzzle, and we're passionate about working with stakeholders. I really believe if you want to go fast, go it alone, but if you want to go far, you have to go together. And that's the approach that we've taken. So thank you for the opportunity to speak today. I'm very excited and happy to work with anybody in the future, and hope that this is a model that motivates you. Thank you.
All right, thank you, and committee will hold questions until we get through all of our presenters. Next, I have Lisa Sutherland, Executive Director and Licensed Clinical Psychotherapist with Compass Behavioral Health. Welcome to committee, Lisa.
Thank you. Madam Chair and members of the committee, my name is Lisa Southern. I am the Executive Director of Compass Behavioral Health, which is a community mental health center in Southwest Kansas that serves 13 counties. We are mostly rural and frontier. As you are aware, we are the safety net for those facing mental health crises and are available 24/7, 365. We are unstoppable. I appreciate the opportunity to participate in this discussion on behavioral workforce issues. Compass has intermittently faced staff shortages in the 27 years that I have worked here. However, the last few years have become increasingly more difficult, and we have been doing thorough examination to determine the reasons. What I will be discussing is specific to Compass, however, can likely be applied to any of the community mental health centers. We suddenly got hit in our area with what I have been hearing Eastern Kansas has been experiencing for years. And that is therapists who come to work for the community mental health center, get their clinical licensure, and then go work for private practice. I have learned to view this as positive as possible, which is we did a great job training you. Go out and do good things to serve our community. If we have people to refer our clients to, then we're still taking care of our community. About 20 years ago, Compass had 4 psychiatrists. When I initially put together this presentation, I thought that's probably unheard of for Western Kansas. However, it's probably unheard of for many community mental health centers to have 4 actual psychiatrists who work for them. The reason that we had that number of psychiatrists is because at that time, J1 employment was limited to state hospitals or CMHCs. So we became their choice for employment. However, that went away. So we no longer have that as a way to recruit psychiatrists. APRNs then came into employment with CMHCs with their psychiatric specialties, and this opened a door for us since we were no longer able to actively recruit psychiatrists. However, this comes with a very frightening aspect because they have to have a collaborating physician. If you have no psychiatrist, you basically have no functional APRN, as they can no longer provide services or prescribe medication. 2 times in the past 18 months, Compass was faced with 90 days notice given from a collaborating physician in which we had to work very hard to find someone to take their place. We are now working to secure 2 physicians per APRN so that if one leaves, we're not left unable to prescribe medication or provide services. This is a cost that cannot be reimbursed. We just have to absorb it for peace of mind. Can you imagine the domino effect of our 4 APRNs not being able to prescribe to well over 1,000 clients? How would these kids function at school? How would these adults function at work or in their family life? Our crises would undoubtedly go up. Our hospitalizations would go up. And then the unimaginable thought, what if someone without medication were to engage in self-harm? APRNs will not readily come to Kansas to work. They want to work in an independent practice state. Kansas is not one. Delays in actually putting hired staff to work is another barrier. At times, it can be months with combined BSRB delays in getting licenses, and then MCO credentialing issues are another factor. It seemed easier and much quicker 27 years ago. When your staff are feeling the overload pressure, covering more nights of on-call than ever before, and then you have fresh, vibrant staff ready to get to work, these delays just add more gaps to care. COVID changed people. This is 100% true. Our exodus in staff over the last 18 months is a clear demonstration of this. The COVID mandate will cost us more good staff, which will result in less client care. Here are some ways that we try to mitigate the workforce challenges. Truly, every day, I wake up thankful for the universities who have outreach master's programs in Western Kansas. We work to grow our own and encourage our staff to get a master's degree and stay with us. We are also thankful to be eligible for student loan reimbursement through the National Health Service Corps. We have seen staff which is with as much as $100,000 in student loans written off over a period of about 5 years with us. This applies to both therapy and med staff. The con, of course, to this is that after the loans are paid off, about half of them leave us. And again, we have to deal with trying to replace those positions. Every day, I also wake up thankful for the emergence of telehealth agencies. We have utilized them for APRN and therapy staff. Without them, we would be even more understaffed. However, there is a con, and that is the expense. And believe me, I know they have overhead expenses. They are not trying to price gouge us. This is what it takes for them to provide us with staff. Let me just give you an example. It is $249,000 a year for us to employ a full-time APRN through a telehealth company. It is $400,000 a year to employ a full-time psychiatrist and $145,000 a year to employ a full-time therapist. This is way more than what we pay our staff, and yet it is the only option we have when we don't have enough staff to take care of our community. We are all working hard to retain our current workforce by not overworking them. Our management and team, including myself, all jump in and help with client services. I took an intake day last week to keep our same day, next day access services in place. I also took on call last weekend in order to give someone a break. Our staff have to see that from the top down, we are here to serve. As I said when I opened this, we are unstoppable, and yet these workforce issues do slow us down some days. Compass does believe the CCBHC initiative will help with the recruitment and retention of services, the workforce. We also believe that the change in reimbursement will help us with our model of care. The CCBHC model is designed to reimburse providers for the true cost of services. For example, the aforementioned cost of using telehealth. And this will provide us additional resources to more effectively recruit and retain what we hope will be our own life staff. Thank you for the opportunity to speak. I am happy now to take any questions.
All right, thank you very much, Lisa, and we're going to hold our questions till we have all of our presenters. The next one is Kyle Kessler with the Association of Community Mental Health Centers. Welcome to committee, Kyle.
Good afternoon, Madam Chair. I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. And again, our association represents all licensed 26 community mental health centers across the state. We appreciate the opportunity to provide some comments here this afternoon on the workforce issue, specifically the workforce shortage in Kansas. Our CMHCs around the state have over 5,000 employees, and with a approximately 12% vacancy rate, that is significant. We have 120 locations around the country. I'm sorry, around the state. I think that, and you have our written comments in front of you, and really I'll look more at the second page in terms of where I'm going with our comments, because you've heard last year and in previous years most of what we have in the opening of our testimony. But for purpose of today's comments, I would say really there's three buckets: the medical staff, clinical staff, as well as case management and attendant care staff. 5 or 6 years ago, we looked at or began really reviewing the status of medical staff across our system, knowing the number of psychiatrists approaching retirement far outpaced the number entering that specialty. And this is also a concern nationally. It's already been noted that the workforce issues in behavioral health are a national issue. And two issues really compounded the problem in Kansas. One was that we had lost the very reputable Menninger Clinic when they left Kansas to go to Texas. And this could probably be placed in the other two categories as well, because they trained an incredible number of doctors, clinicians, and nurses and other staff over the years. For those staff who did not follow Menninger to Texas 20 plus years ago, they are now either retired or rapidly approaching that age, and we have not been able to replenish that resource from an educational standpoint. And the second issue is that the limited number of psychiatry graduates in Kansas are not staying in Kansas after completion of their residency programs. So legislation was passed about 4 years ago, maybe 5, that added psychiatry to the list of specialties in the Kansas Medical Student Loan Repayment Act. However, it appears that the use of the program has been minimal by psychiatry residents, and we have been unable to access data about the number of residents who have participated or the amount of funding that has been used for this purpose. I think that the previous speaker certainly did a nice job in talking about how important data is. I mean, Dr. Doyle from Nebraska, and I believe the more things that we can measure, the more we can accomplish for sure. I'd say for our clinical workforce, a provision was included in Senate substitute for House Bill 2208. You've also already talked about that. That establishes the CCBHC model in Kansas that also reduced the hours for clinical licensure. And prior to this, Kansas had one of the highest requirements in the country. So reducing the number of hours required for supervision was seen as an effective and easy to implement solution. And we have seen quite a few clinicians become licensed faster as a result of that. Legislation also passed last year, as you all know, that allows professional, including medical and behavioral health licensees who are moving from other states to receive provisional licenses. This is a reference to House Bill 2066. And as it relates for military spouses or partners, and Kansas has a pretty substantial military presence with 3 large military installations. And so again, this is a nice asset for us. And lastly, the case management and other workforce is our newest initiative. Kansas has a large number of community colleges, and they were successful last year in obtaining legislation through the Promise Act and funding for essentially free tuition for any Kansas resident with a qualifying household income. We are working with them to develop a curriculum for either associate's degrees or 2-year certificates that would create, at minimum, an excellent career ladder, but potentially, and we think equally as exciting, a case management program. This would work by fulfilling a 2+2 standard in which a 2-year degree or certificate in addition to 2 years of relevant experience, such as being a para in a school or attendant care in the CMHC or child welfare systems, would meet qualifications to begin a career in the behavioral health field. And traditionally, our case management staff have held 4-year degrees, but other employers have really been able to pay higher wages, oftentimes give summer or other timelines or periods of time off that put us at a significant disadvantage in hiring them or retaining them, I should say. And I think we believe that these entities are less likely to hire 2-year degree staff. So this is something that we have quite a bit of optimism around. Probably we expect to be working with technical schools as well, technical colleges. So in general, we believe that the CCBHC initiative will help with the recruitment and retention process for all areas of the behavioral health workforce, especially the medical side, since those have historically been the lowest reimbursing Medicaid codes. And the CCBHC model is designed to reimburse providers for the true cost of services, and this will provide additional resources to the CCBHCs to more effectively recruit and retain staff. And so in closing, I would say that our goal should be to really recreate, as I mentioned earlier, the Menninger Clinic in the aggregate through the use of all these tools that you all have championed or worked on. I think that we really are putting ourselves in an enviable position, and it just takes time for all of these programs to get off the ground. But if we can accomplish this, and again, referring to recreating the Menninger Clinic in the aggregate, then this will achieve our ultimate goal of Kansas being the best behavioral health system in America. And that's my true belief. So I would stand for questions at the appropriate time, Madam Chair.
Thank you, Kyle. Next, we welcome Jennifer Marsh with the KDHE, Children and Family Section Director. Welcome to committee. Are you there, Jennifer?
I am. Can you hear me, Madam Chair?
Yes, I can. Thank you.
Wonderful. Thank you. Thank you so much for having us and for allowing us the time today to share additional information about programs that support the Kansas workforce in relation to behavioral health. Today, I'm joined by my colleagues, Lindsay Galindo, who will be speaking more about Kansas Connecting Communities, and Dr. Rachel Brown, who will share about the Kansas Kids MAP program. With rising behavioral health concerns that our previous presenters have spoke so eloquently about across all population groups and shortage of mental health professionals in Kansas, more individuals are seeking treatment in primary care, obstetric, and emergency department settings. One factor contributing to the gap between behavioral health disorder identification and service provision is the lack of growth in the workforce for psychiatrists, specifically child and adolescent and peripartum specialists. Often, primary care and obstetric practitioners are the first responders in behavioral health disorder identification and service provision. The training of pediatricians, family physicians, and OBGYNs includes some education on evaluating and treatment of behavioral health conditions. However, their expertise is limited, and many do not feel confident, particularly in the evaluation and management of more complex clinical presentations. Challenges faced by these providers include lack of training, appropriate workflows, guidelines, reimbursement, knowledge of appropriate referrals, and lack of access to psychiatric treatment within their communities. This is not a new issue. In 2004, Massachusetts was faced with similar conditions, and they launched a child psychiatry access program. The goal of the program was to improve access to treatment for children with behavioral health needs and their families by making child psychiatry services accessible to primary care providers across the state. The program provides quick access to psychiatric consultation and facilitates referrals for accessing ongoing behavioral health care. Based on the mental health professional shortage areas in Kansas, we saw the Massachusetts Consultation and Psychiatric Access Line program as an evidence-based model that was a feasible, high-impact, broad-scope solution which could address a number of these gaps. To address these workforce shortages, KDHE has built through strong partnerships, consultation, and support with local programs which provide behavioral health consultation, support, referrals, case management, provider education for children through the Kansas Kids MAP program and the perinatal population through Kansas Connecting Communities. And with that, I'm going to pass it to my colleague, Lindsay Galindo with KUCPPR to share more about Kansas Connecting Communities.
Thanks, Jen, and thank you for this opportunity to speak about the statewide perinatal behavioral health project, Kansas Connecting Communities. Next slide, please. So we know that behavioral health conditions, including depression, anxiety, and substance use, are the most common obstetric complication in the perinatal period. The Kansas Pregnancy Risk Assessment Monitoring System, known as PRAMS, is a survey of Kansas women with a recent live birth. Between 2017 and 2019, 13.5% of Kansas mothers responding to the survey indicated that they experienced symptoms of postpartum depression, and alcohol use, which is assessed prior to pregnancy, was common, with 63.3% of respondents indicating use during the 3 months before pregnancy. Many respondents indicated that they were asked by their provider about their mental health, and they were more likely to be asked about depression at postpartum visits compared to those prenatal care visits. In a sample of almost 2,000 new Kansas mothers who experienced symptoms of postpartum depression, 15.2% reported that they did not receive treatment, and participants who received WIC and Medicaid were less likely to indicate that they had received treatment. Next slide. So even when symptoms are identified, pregnant and postpartum women face many barriers to accessing behavioral health care, as we've been discussing, including limited access to treatment services and provider discomfort prescribing. This example of a new mother experiencing symptoms of depression while navigating long wait lists and other barriers to immediate care really highlights the significant negative impacts on both mother and baby that can occur as a result of delays in care. Next slide. Integrating behavioral health care into existing obstetric and postpartum care is critical to expanding access to treatment for perinatal women. KCC was really designed to fill this gap by building the capacity of frontline providers to identify perinatal mental health and substance use disorders and intervene effectively. Over the last 3 years, KCC has trained over 700 Kansas providers, including physicians, advanced practice providers, nurses, public health, and family support professionals to integrate mental health and substance use screenings and intervene during the perinatal period. In addition to ongoing training and technical assistance, providers have access to care coordination support and psychiatric consultations to support their work. Next slide. Consultation services are accessed through the provider consultation line for perinatal behavioral health, which is staffed by a licensed social worker and addictions counselor with perinatal expertise, as well as Dr. Erin Biter, a peripartum psychiatrist based at the University of Kansas Health System. The consultation line allows providers to receive the support and resources they need to respond immediately to their patients' behavioral health needs during this really critical period. I appreciate your time today, and we'll hand it over to Dr. Brown.
Is it just me or is Dr. Brown on mute?
There we go. So let me show you. Yeah. So I'm sorry to be on mute. I wanted to say I'm grateful for the opportunity to speak about Kansas Kids Map. And I'm grateful for our partnership with KDHE and for all the support I've had from the University of Kansas here in Wichita, both our Department of Psychiatry, which I chair, and our Department of Pediatrics. And we've worked very closely together to get this project up and running, and I think it's been extraordinarily successful. Just to give you a little bit of background, and can you move? There you go. This is no surprise to anybody. I know you've been hearing all about this information. There are over 700,000 children and adolescents under the age of 18 years in Kansas, and there are 9 child and adolescent psychiatrists per 100,000 children. This is a specialty that is in enormous shortage across the country and particularly across the state of Kansas. Estimates suggest that we should have about 400 child adolescent psychiatrists for our state, and currently we have about 60, of whom only 5 practice in the community outside of the corridor, the northwest corner of our state. So our state is essentially a mental health professional shortage area. That means that many of the children in our state who have significant psychiatric disorders that impair their functioning don't receive mental health services. Just as an estimate, about 50% of the kids with major depression don't receive services. About 60% of children with ADHD don't receive behavioral health services. And these are eminently treatable, manageable conditions that, if not managed, have negative long-term outcomes. And if well managed, the children and adolescents do way better. At the same time, many of these children and families are going to see their family doctors, their pediatricians, their primary care clinicians. 70% of all primary care visits involve a mental health concern. So our strategy has been, as you've heard described with the Kansas Connected Communities initiative as well, is to increase the capacity of primary health care to manage mental health concerns. And that has many benefits. Early detection, early intervention results almost certainly in better outcomes. Next slide. So I'm very passionate about access. I'm also very passionate about access to the highest level of expertise. And this model provides that. This is our mental health team, which includes board certified pediatricians, psychologists, and child and adolescent psychiatrists, and a wonderful social work care coordinator. Next slide. We hear about a lot of kiddos. This is an example of a child referred by his primary care pediatrician, an 11-year-old, where there were concerns about weight loss and poor eating, concerns from mother about autism, some psychosocial problems, divorced parents, fathers involved, but less concerns. And then a lot of concerns about eating-related behaviors that may or may not result because of a diagnosis of anorexia nervosa, which is the most lethal of all psychiatric disorders. Our primary mental health team made recommendations to the primary care physician, including further workup from a specialist, lab work, clinical interview, and we gave guidance as to how to do that, and then release of information for the physician to contact the school personnel. We felt that in this particular situation, as in many, there was not a simple, here's the problem, here's the answer, but that things are complicated. There's biological factors, psychological and social factors, and that's part of the reason why we've put the team together that we have to address the issues with primary care docs. Next slide. So this is the graphic that I hope helps give an idea of how the system works. In the middle is the primary care physician or other clinician working all across Kansas, and they can outreach to the consultation line, which gives case consultation with our pediatric mental health care team, and also allows the PCP to have access to toolkits, best practice guidelines. We provide clarification on medications, telehealth resources if need be, and resources will work actively with the primary care physician to help them access resources in their local area that may be available to them, of which they may not be aware. We also have a bi-weekly ongoing tele-echo clinic, which includes our primary mental health, psychiatric mental health care team, and about 25 or so primary care physicians and other clinicians who will call in. We provide mentorship through case-based learning. One of the ways that we know that clinicians learn is through cases and through authentic case discussion. And what that means is that you'll learn something around one case that you can then apply to multiple different cases that you see in your own practice. And then at the same time, because we're aware that doing this kind of work is stressful and sometimes difficult, that we have a deliberate outreach for physician and clinician wellness with a goal of creating a network of support and wellness for our colleagues as they take on work for which they may not have been as well prepared as those of us who have been in behavioral health all of our professional lives. Next slide. So this is just the reason why the wellness component has been so important. Burnout in mental health providers is as high as 67%, though most also report high levels of personal accomplishment. We know that physicians in particular commonly don't seek help for burnout, even when they're having suicidal thoughts, and that healthcare burnout has increased markedly during the pandemic, impacting all kinds of healthcare workers across the spectrum, with more than three quarters of them reporting exhaustion and burnout in September of 2020. So we've been very active in providing resources to support provider wellness. Next one. This is our Kansas Kids map enrollment. We are based in Sedgwick County, so in Wichita here, but our outreach is across the entire state, including to the part of the state that actually has the least levels of mental health care practitioner shortage in the Kansas City area. We nonetheless have a lot of enrollees from that part of the state, but we also outreach to almost all counties in all areas of the state, urban, rural, and frontier as well. Our enrollees are, for the most part, physicians and nurse practitioners practicing in primary care, but we also have a range of other clinicians including behavioral health clinicians, who are welcome to enroll in the program and to participate. Next one. And I'm thank you so much for the opportunity to talk about Kansas Kids Map. As I say, I'm very passionate about the work that we've been doing. I think it's been really rewarding for us, and I hope, and I really do believe has been very helpful for the practitioners that have called in, and therefore for their patients and the families that they work with all across our state. Thank you.
All right, thank you very much for being with us here today. Next, we've got Andrew Brown with KDADS. Andrew, is it possible for you to stick around for a little while? Because we've got a 3 o'clock we have to take, coming virtual, but some 988 stuff got brought up. Maybe you could help us with?
Yep.
All right, thank you.
Thank you, Madam Chair, for having me here today. And I wanted to, I'll kind of breeze through this. You've got written testimony in front of you that we submitted, but a couple of points that we wanted to add that some of the other presenters haven't made yet is just that this is in addition to this being a broad national issue, it also touches almost every level of provider type in the behavioral health field. At the entry level, we're in wage competition with lots of other entry level positions across many standard occupation classifications. That's an issue that we see both in our CMHC systems and also in our inpatient systems. This also is an issue, the workforce issue impacts our state hospitals, and specifically our efforts towards lifting the moratorium. And as we are working to build those programs that are going to assist people in the community and work on CCBHC, we're going to need additional workforce to support those efforts as well. And then one of the areas where this has really been highlighted is within the PRTF system. Currently, we have about 134 beds that are licensed, yet remain empty due to the lack of staff. And currently, the wait list for PRTF admissions have 133 children on them. So you can see that if we were able to adequately staff those facilities, we'd be able to eliminate that wait list and get kids served immediately. Additionally, in my testimony, there is a list of recommendations from the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association, who joined together in October to declare a national state of emergency for children's psychiatric care. Most of those bullet points that are listed on the second page of that testimony are topics and recommendations that have come up in our mental health modernization and reform work groups, and many of them were presented last session as we were working on mental health reform. But I think that it's important to review those and just continue to keep those in the forefront of your mind about how these workforce issues continue to impact the state of Kansas. And then lastly, I just wanted to let everyone know that we are working with the Recovery Office in order to try and bring these workforce issues forward to the Spark Committee as well, and see if we can't allocate some funding from the ARPA dollars to help with workforce issues here in Kansas. And with that, I'll let us switch to questions, and you can ask some of the experts in the room questions about what we can do to fix the problem.
All right, thank you, Andy. I'm going to hit you with one right off of the bat. You said that you're asking for the ARPA dollars to help with this problem. How will more money resolve this shortage?
Well, I think in part at our lower level, where we have entry-level workforce, when we talk about attendant care, when we talk about mental health technicians, those folks are oftentimes in a wage competition with other providers. And so TLC, which is Kids TLC, which is one of the PRTFs in Kansas City, they've recently increased their wages in order to recruit additional staff. They've seen some results with that, but we still have a retention issue. So opportunities to apply a retention bonus to staff to help maintain those folks in those positions longer would be helpful. And I think also it would be helpful for us to be able to have funds to go into communities and advertise for those positions.
Okay. Thank you. Committee, are there questions for all of our people? Cindy, representing neighbors, excuse me.
That's all right. Thank you, Madam Chair. And there's only one of me. I have to say that often. When you look at receiving funds like from ARPA, are those going to be, how are you going to sustain those funds over a long period of time? They may answer a question today and tomorrow, but you have to have the sustainability to keep those people around. How would you go about doing that?
Well, so for CCBHCs and for the PRTFs, as well as some of our other like nursing facilities for mental health, those programs are what we call cost-based reimbursed through Medicaid. So as we increase salaries for those facilities, that would increase the rate of reimbursement that they receive through Medicaid program. And that would also then give us a higher percentage of federal match, not a higher, sorry, I said that the wrong way. Our percentage of federal match that would increase the amount of funding that goes into those centers. So long-term, like if we invest now in the future, those rates would go up and be sustainable through that program. And our state portion of that would be reduced in the future.
Thank you, Madam Chair.
Senator Fagg.
Thank you, Madam Chairman. Andy, hearing you talk about the shortage and taking ARPA money to do this and more money, I'm sitting there thinking there's so many people in a community. And whenever you go out and take this government money to get them to come to you, they're coming from somewhere. So whoever their employer was that we took them from, they're going to be looking for people. So it's kind of a real catch-22 that I'm wondering where that goes.
Yeah, well, I think that that's true, right? Like we're all in this economy together, right? And we are all competing both as an employer within the state, but also with employers on the outside of the state. And right now, one of the challenges that our CMHCs face, and I feel like we also face at some of the state hospitals, is losing workforce across the state line to Missouri and to Oklahoma because of their ability to pay higher rates for staff. So if we're able to offer more competitive salaries or retention bonuses or other things, I feel like that will help alleviate some of that loss. We might even be able to gain some people back.
And I hear what you're saying, but then Missouri's going to be looking for employees too then.
Yeah.
They should have stole ours in the first place.
Yeah.
Yeah, there's a national shortage for behavioral health workforce. So if we want to look out for Kansas first, we got to put our money where our mouth is.
Well, and if you were to look at a map, and we've had that in the Health Committee of the CCBHCs in Missouri, just go right down that eastern border of Kansas. And it's not that hard to drive across that state line to go to work. Yeah. And then I think you heard earlier from Kyle, of staff leaving and going to places that have perhaps better hours, et cetera. And we've noticed in the K-12 mental health program that we end up losing a lot of our great workers to the school districts hiring them because they can give them better hours, more money, and they get the summer off. That's a big deal. Further questions? Representative Ballard.
Thank you, Madam Chair.
And everything doesn't have to go to Andy. Just remember that, everybody.
Yeah.
Okay. Well, I do have one for you, though. When you say the money, often I was just looking, Senator Fagg was asking that question about all the other states are in need. That's true, but our concern is really Kansas. But I think we have a greater concern, or at least I have a greater concern. If other states are paying direct care workers and everything else more money, and we're paying them less, we are actually creating this problem for ourselves by not. So give me a comparison. What would Missouri be paying for a direct care worker versus what we are paying?
Yeah, and I might toss that question to Kyle, but I will say that I think the last sort of anecdotal evidence I had was there was about a $10,000 gap for a licensed clinical social worker between what was being offered in Missouri versus what was being offered in Kansas.
I was going to follow up with Kyle on that, with Kyle, but that is a tremendous difference for someone who could maybe just drive 20 additional minutes and get there. But again, it's not so much that they're doing it, but why are we not raising our salaries? Which means it does create more revenue for us because of what's taken out of their salaries to come back. And while we're always on the low end of it, so that says that the citizens in Kansas are being shortchanged somewhat because other people will get them. Or it's the second part that bothers me. We get them initially, we train them, and when they're in good shape to help us, they can move over to another state that's paying more. So it's like, it's a double-edged sword. We're just not doing what we should be doing by the citizens.
Yeah.
And I will ask Kyle as well. Thank you.
Okay. Kyle, I believe that Representative Ballard's got a question for you.
Yes.
Did you hear it?
I did. Thank you, Madam Chair. Thank you, Representative Ballard. A couple quick comments. One, yeah, I think that Commissioner Brown's in the ballpark. The lower paying or more entry level positions would be probably $7,000 to $10,000 more. I also think that what you see a lot of that's particularly exciting in Missouri is they have a much more robust medical workforce. The number of psychiatrists, I think, in one of the CCBHCs may actually, they may have more psychiatrists than our whole system in Kansas combined. I mean, keep in mind, it's a large CCBHC, but being able to pay cost-based reimbursement is a big thing. And also, it's not just the eastern border, but the southern border as well. And I believe Greg Hinnon, the CEO at 4 County, is on, and he can tell you a story or two about folks he's lost across the state line into Oklahoma and Grand Lake mental health, which again, good providers, but they know good talent when they see it, and they find it. They have found some of it in Kansas. But Greg, I don't know if you want to comment to that. And you're on mute.
Greg, are you there?
I think his sound may not be cooperating.
Well, yeah. May I follow up on that? The thing is, Burt Nash Community Center in Lawrence. You know, I look at that, and it took us 3 years to find a psychiatrist. You know, and they were coming in from Kansas City to deliver services because we couldn't get one. And we, you know, raised the salary, but again, it was so low that it was still lower than what could happen. And that created a problem because you have to have at least a psychiatrist on staff. So it was like part-time, they would come in and out. So it really is a big problem.
And there, you know, other folks can comment, and this is Kyle Kessler again with the Association of Community Mental Health Centers, and maybe some of the other practitioners on the phone can speak to this, but they don't have some of the same managed care restrictions in the Missouri and Oklahoma systems that we do. And there are some folks who would rather not work within what we have with CanCare. And I use the PRTF as example. And for example, AmeriGroup is no longer an MCO in Kansas. And I think that one of the reasons, you know, they were pretty rough on the PRTF system. And it would take months to get paid. I don't know if that's improved or not, but once you lose employees, it's not that easy to get them back. So in a lot of ways, we are trying to rebuild a system.
You know, Kyle, maybe if you explain, for people that don't know, the CMHCs, the Community Mental Health Centers, was established by the state of Kansas. It's not like you're independent. We established those community mental health centers because we knew we were underserved throughout the state. And we have to take everyone who comes to our door, regardless of ability to pay, you know, because it is a state. You know, we do that. So therefore, most community mental health hospitals, Kyle, if I'm correct, run a bad debt. So much of it because we have to take them where privates do not. So how do we address delivery of services when we're short on direct care workers, yet we have to take everyone who presents themselves to our door? And how does community mental health hospitals or clinics continue to prosper?
Sure. And the community mental health centers, there are really three things we're talking about. So one is the uninsured or underinsured population, which again, since 2017, the legislature has really taken a leadership role on trying to restore those dollars back to, for the first time since 2006. Last year, we went above our 2006 levels. So we had dropped substantially from around $50 million for uninsured individuals down to around 35. So restoring that was significant for our system. So I believe now you have that spreadsheet in front of you, but I think it's around 53 million. And then another part is Medicaid, especially as it relates to the medical side with docs and nurse practitioners and nurses. Most of our CEOs or executives will refer to that as their loss leader, because those are Medicaid rates that had been stagnant for probably 2 decades in most cases. And then the last part being the shortage, or, if folks are not reimbursed adequately, or if you can't get them to come to your community in a rural area to take advantage of the loan repayment programs, then if they choose to leave, then they're not likely leaving Great Bend or Independence for Kansas City or Wichita. They may very well be leaving for Chicago or Denver or Dallas.
Okay. Thank you very much.
Thank you, Representative.
Senator Fagg.
Thank you, Madam Chairman. I've got a couple questions here. One, the Menninger Clinic that we lost, that went to Texas, I'd be interested in why that happened. So that, we know where to go in the future, so.
Yeah, I think that again, Dr. Brown or others may have some opinions on this, or Dr. Warren's, but I think a lot of it had to do with them simply being recruited away to a state that appreciated what they did. They went to Baylor University in Houston, and this would have been, I believe, early 2000s or maybe late. It may have started late 90s, but it really was something. And Senator, I think the question is a great one, because recently I posed it to our full board of directors from around the state and said, okay, if we think of the Menninger Clinic, what do we think of? Kind of just trying to develop a word cloud, so to speak. And the very quick responses I received were state-of-the-art, innovative, compassionate, cutting edge, and quality mental health, and the best. Those were the kinds of words that were brought up. And so it really created a pipeline for us. So I think that there was just some arguments among maybe higher education and the Menninger Clinic for how to go forward. And what hurt even more specifically was that as residencies are appropriated by the federal Health and Human Services system, they are appropriated by hospital, not by state or by community. So those residencies, and there were a number of them, went right out of state to Texas with Menninger Clinic.
Another question I had, Madam Chairman, was to the first presenter. When we was talking about our 30% that we had here, the real shortage we had in Kansas, I was wondering how Nebraska's numbers were. I don't think I ever heard on that part, if she's still
Yes.
online.
Yep. So
Marley, would you have an answer to that, Marley? Go ahead.
Yes. So, can you hear me?
Yes.
Yes.
In Nebraska, we are at about 50%. So we have about 50% of the providers that we need. So like I said, we haven't solved the problem, but at least I feel like we've been making steps to improve it. But we still have a really tough time with our rural areas. We will see. We're really working on ways for telehealth to be innovative. We're also looking at different models, like we've heard about here, that use our current providers more effectively. But there will always be a shortage. We know that. So we need to figure out how we can kind of work with what we have.
Thank you, Madam Chairman. One more question. Andy, I think this one might be towards you. What kind of retention rate does Missouri have with their students going through their programs over there? You know, we're talking about raising ours and ours leaving the state. I just wondered, are we just taking higher education and spending the money for their businesses in Missouri? If you understand what I'm saying there.
I do think I understand what you're saying, but I'm not sure I'm qualified to answer. So, but I
Outside of his bailiwick, I think.
yeah, I would say that, you know, I feel like our numbers have gone down in Kansas around the number of, you know, social workers that we're graduating. I think our class sizes have gotten smaller. But I do feel like there's a lot of new programs that have been started. And I know, you know, we might even have somebody on the call that can speak to this, but in Western Kansas, there's been some outreach programs to develop additional licensed social work classes so that we can get master's level social workers sort of brought up through the system. I think through Fort Hays State is where that program's at. So there's definitely some outreach going on to try and find ways to increase those numbers. And I think one of the things that I admire about what Beacon has done in Nebraska is they've really looked at that career ladder and figured out ways that they can partner with universities around their state or campuses around their state in order to be able to recruit people locally so that they stay in those rural areas once they graduate. And I think that's an important component of this is, you know, if we do all of our training in Kansas City, crossing the state line is not that big of a deal once you graduate, right? But if we're able to do that in places like Fort Hays or, you know, Salina, that opens up opportunities for us to really kind of create a workforce that stays in Kansas.
I would just add to that our data absolutely supports that. If a student trains in a rural area, they are much more likely to stay in that area. So we have really focused on increasing the amount of rural training opportunities because that does seem to be the key to success. And I would also say with in regards to what can one-time funds do in regards to kind of a long-term solution, one successful thing that we have kind of done is turning pilot programs and into successful programs by getting matching support from the universities and the communities. And that will really add some longevity even to one-time funds. But yeah, the key is to keep people, to train them where you want them to be.
Committee, are there any further questions for the group we just heard from? All right, seeing none, thank you very much. You know, actually, Andy, if you'd stay up there, because we're about 10 minutes ahead of schedule for our 3 o'clock,
right.
is, because the one thing I don't have on the 988 is the chart you and I worked off of this is where the money's dispersed. So that's something we need to get out to the members here.
Mm-hmm.
But if you guys, whatever questions you have on the 988, he knows it inside, outside, forwards and backwards better than I do. And I'm looking at Senator Hawk and then maybe Representative Ballard, I don't know.
Yeah, and I can take a stab at what I heard on the way down here,
Okay.
right? Which was, I think there was some confusion about the $5 million that was set aside in the budget for mobile crisis versus the $3 million that was set aside for 988.
The $3 million's fine, but the $5 million got associated to the 988, and that would be a mobile crisis. And I'm thinking, Representative Ballard and I looked at each other, it's like, yeah, we don't recall appropriating $5 million, so help us.
Yeah, so the $5 million that we requested in our budget enhancement last year for mobile crisis is for us to be able to provide mobile crisis services to the uninsured through the CMHC system. And so we started this year with funding from DCF through the Family First Services Act to start a program for youth So that program is a mobile crisis program that we've started just in October. In April of '22, we'll have the opportunity to work with KDHE to add adult services to the Medicaid plan. When we do that, we'll qualify for an enhanced FMAP of 85%. So we're going to be in a situation where we'll have the ability to cover our Medicaid insured folks through a billing process for mobile crisis services, but we'll still need funding for our uninsured folks. And so that's what that $5 million is set aside for. And so we've got about $1.2 million of that that'll be going to the Wheat State IPA to help build the network of mobile crisis providers and support them with training and technical assistance. And then the remaining 3.8 will be RFP'd out in order for us to contract with an ASO to provide those services on a fee-for-service basis.
So these aren't, so how is this group of mobile crisis units different than the ones we talk about when we talk about 988?
So 988 will start July 16th of '22. So these services will hopefully be in place before that, so that when that program starts, we'll be able to have a referral from the 988 folks to the mobile crisis teams that have been established. The funding that we've asked for in the 988 bill is to specifically support the individuals that have called 988 and need those mobile crisis services. But we also want to have those mobile crisis services available to people that contact other emergency lines or other services that may reach out directly and need access to that. So including this $5 million in our budget allows us to make sure that the CMHCs are able to cover mobile crisis programming for the uninsured. And then our Medicaid program will help us make sure that we can cover the folks that are have Medicaid coverage, right? So that allows us to cover two populations going forward.
So does that mean that we have double the mobile crisis units?
No. So mobile crisis is an expensive program. It requires us to braid multiple sources of funding together in order to be able to staff the program adequately and to make sure that those services are going to be available statewide. So the $5 million that's in there for the uninsured is just a portion of the money that's needed. I believe that there was also I think about $8 million out of that $17 million that was in the 50-cent 988 fee that was intended for mobile crisis. And we may have pared that down while we were talking with telecom companies about how we could look at maybe a different rate. But ultimately, we anticipate that the total cost of a statewide mobile crisis program is probably close to about 25 to 30 million.
Okay, so does the $5 million on this mobile crisis, is that in response to a lawsuit that was settled?
No. So, so I don't know how to word this, but we have included it in the settlement agreement for the foster care settlement. We've also included mobile crisis as a portion of the pre-litigation agreement with DRC, the Disability Rights Center. And in both cases, mobile crisis is a program that we've been working on since I became commissioner, and even the year before that, we put out an RFP when Susan Felt was the commissioner. And so it's an ongoing project that we've been working to try to develop, but we haven't been successful implementing it because we've had funding issues.
Okay. And will you still be including, because I think we had it in the 988 legislation, is mobile crisis responders for the IDD population as well?
Yes.
Okay. God, I just thought of something. When I think of the mobile crisis units, because this was a question that was asked a lot during the session, is that, well, you're going to build bricks and mortars, you're going to be housing people. Why can't we use our EMTs? Why can't we use EMS? Why can't we? And it's because these individuals are all have day jobs. So it's kind of like having a volunteer fire department, that they've got jobs, but when a call goes out to move on a crisis, they gather and go. Would that be a correct assessment?
Yeah, so for example, only about 10% of the calls that we anticipate being answered by the 988 Lifeline call centers are probably going to result in a dispatch for mobile crisis services. And so what we are looking at, what's the volume of that? So for about 1 million people, the Crisis Now model calculator indicates that we can anticipate somewhere in Kansas between about 12 to maybe 15 mobile crisis dispatches statewide in a given day. So obviously that doesn't mean that every mobile crisis team in the state of Kansas is going to get dispatched every day. And it also means that there might be some communities where they're dispatched 3 or 4 times in a given day. And so we want to make sure that we're flexible in how we build the model so that we're not requiring everybody to just have a mobile crisis team that's sitting there waiting for a call to come in that might not come in that day, right? And that's why that sort of volunteer fire department reference comes up, is you want people to be able to hire staff, you want them to be able to build out training for these staff, but we also want them to be able to work at the times when they're not on a call.
Committee, are there further questions? You're sitting very quiet, Senator. Okay. Well, I just know, I mean, Andy's kind of the expert with it, and I know that Senator Hawk is, looking kind of down the same path that we've all been talking about. How do we come off of that 50 cents? Where could we go? What's our best path to do that? So it's not a, no, we're not willing to budge. It's just make sure that we're looking at the numbers and that we can provide the services, because if we don't for that 988, that could end up being a big problem.
Yeah. And I think last session we put together a number of different packages at different price points that we thought we might be able to use to move forward.
Well, there's also the possibility, Andy, I think, one of them was is that, okay, you lower it to a certain level, and then maybe in 2 years you graduate it up, up to a certain level, and then it would have to be revisited beyond that as to whether it needed to go higher or not. I knew you'd have something. Senator Hawk.
I liked hearing that you had some different packages. Is there a chance we could look at what some of those options are?
Well, I think that's already going to happen in one of the committees during the session. So
Perfect.
We might be getting ahead of ourselves if we do that now.
I don't think we got this at the Senate. We really like it when the House does all the really tough stuff, and then we get to go yay or nay when it gets to the Senate. So we thank you for that.
Well, I'm glad that you appreciate that. There's more of us to do the heavy lifting, and we're just kind of up to the challenge, Senator. It's kind of what we do. But
Just so glad you realize it.
no, it did move out of the Health and Human Services Committee, and then everybody went crazy and got excited and nervous, and then it went back to approps, and right now that's where it's sitting. So it's still alive for us to do something, but you did not see it. We introduced it in one chamber. Any other questions on 988?
No, but thank
Senator
you very
Fagg.
much. Thank you. That explains.
Thank you, Madam Chairman. Andy, what caught my ear was 20 or 30 million. Is that money that hasn't been spent, but you see the potential that's going to be needed? Can you may talk around that number a little bit for me?
Yeah, so when you're looking at, we've got 26 CMHCs across the state. 2 of those share the same territory, so really we've got 25 territories, right? And so to put a team in place for an entire year and provide these services at the community level, we anticipate that that's going to be about $25 million, give or take, right? And so 30 is a little bit rounder number, But I do think that there's going to be maybe some need in communities like Wichita or Johnson County to maybe have more than one team. So we want to make sure that we're being realistic about the number we're asking for. But we're asking in smaller amounts because we're trying to use all the available federal funding that we can attach to this to cover the costs that we can cover with federal dollars. And we're also wanting to make sure that we're keeping the impact on people here in Kansas as low as we can.
And Andy, and one more question, and we'll get to our 3 o'clock. And I wanted to make sure that I didn't speak out of turn earlier today. The goal is in our rural areas where the CMHCs are more sparse, that they'd be within an hour. Is that correct?
Well, we haven't got everything figured out yet, but I think an hour response time is kind of the gold standard. Yep.
Okay. All right. Thank you very much, Andy. And I want to thank everyone else that was in here on the presentation on the workforce issues. It's a big one for all of us. And I think as we keep putting our heads together and thinking creatively, that perhaps we'll be able to do something. So thank you.
Thank you, Madam Chair.
Okay, now I believe that we should have online an update on the Sedgwick County Mobile Crisis Response Unit with Sheriff Easter from Sedgwick County. Are you with us, Jeff?
I am. Thank you, ma'am.
All right, welcome to committee.
Well, thank you for asking me to speak today in reference to what we call ICT-1 here in Wichita, Sedgwick County, which is a mobile crisis team that responds to mental health crises. To start off with, this was an idea that was looked at by the medical director here in Sedgwick County back in 2018 based off of a model that they had researched. What it consists of is a law enforcement officer, it's ComCare here, but a healthcare, mental health care person, and then a EMT, either from the fire department or EMS. And the reason that all three of those are important is, of course, the mental health care worker is going to be doing most of the dialogue with the individual in crisis, assessing them to see what other needs they have. If they need to be taken to, here it would be St. Joe Hospital or via Christie, the EMT would diagnose or would do a medical check on them to see if there's any medical needs. And then, of course, the law enforcement officers there to ensure that of everybody's safety. There is one vehicle for this. All three are together, and they work different shifts. And so what's most important, to be honest with you, about this model is the EMT portion. Because if, in general sense, what happens is law enforcement goes out, they assess that someone's in mental health crisis, they have to take them to the hospital. There's a good 2 to 3 hour wait before the officer can leave the hospital because they're doing the medical screening at that point. And then once they're cleared medically, then they start in on the mental health aspect. With having the EMT there doing the medical screening, it bypasses that in the hospital. So it's a direct admit into the mental health portion, and so they're back on the streets fairly quickly. This was started in 2019 as a pilot. We at the Sheriff's Office were involved as well. We had 3 different teams, and it was made up of Wichita Fire, Sedgwick County Fire, EMS, Wichita Police Department, Sedgwick County Sheriff's Office, and ComCare. And so we split the duties on it for about a 6-month test period. It was found to be very successful. We also found that about 95% of the people being served live within the city of Wichita. So at that point, the team was formed, comprising of EMS personnel from Sedgwick County, a ComCare worker from Sedgwick County, and a law enforcement officer from Wichita. So I have here in front of me statistics from July 1st to September 30th. They do it in thirds, and so for 2021. As far as activity, this group had 207 encounters during this time frame, which 172 of those were field response, where they actually went out on the call instead of having EMS arrive and law enforcement arrive. They had 20 others. ICT has become a little bit more known. So there's been 20 of the other encounters they had were simply phone calls that was transferred to this particular unit. One of the biggest successes is the overall dispositions of these cases. So what is being tracked is handoff to another agency. 32 of those 207 encounters, or 18%. No client found was 22. Refusal of engagement was only 7, which was 3%. Transport by ICT1, meaning transport to the hospital, was 23. And the biggest one was treat in place. And so treat in place, 92 of their 207 encounters were treated in place by the CommCare worker, put on a plan, and then follow-up was done the next day, and then moved forward from there. That's 52% of the time that occurred. I can tell you in the past, a lot of these situations, what they created was bookings into the jail instead. And so we are seeing success in this particular unit. Now, again, there's only one, and they are, sometimes they're not staffed fully, to be honest with you. So the shift that they're supposed to be working, they couldn't work because either we didn't have an EMT or we didn't have a CommCare worker. CommCare here is down 145 therapists, and EMS is down quite a few people as well. So first and foremost, they got to cover the streets. So we're starting to see problems trying to staff this particular unit, but it is still operating very well when they are out there. Emergency resources that were freed up during that time frame is projected that 50 EMS units were freed up due to this unit. 33 fire units were freed up. 96 LEO units or law enforcement units were freed up, and they decreased ED visits with this group by 51 during this time frame. If we're looking at age ranges, it has ranged between 10 and 99 years old, folks that they have serviced. The biggest percentage is between 20 and 29 at 30%. The next highest percentage is 30 to 39 at 13%. We also asked the questions of, is the client already engaged in mental health care? Of those 207 people, 111 said no. So these were new people in new crises, which was about 60% of the population that we serve. Yes was 72 at 39%. So overall, very supportive of the ICT unit. To say it's expensive, it's already personnel that are assigned. The problem is, just like in most public safety areas, we're all short on personnel. And so we've had discussions here locally how we can expand this to like 3 units so that you have units that they're covering, 7 days a week, at least during the priority time calls. Because what we did is we broke out what are the priority times that we're seeing people in mental health crisis. And that's when this unit is particularly working. But that doesn't mean that we don't need more units during that same time frame, because when this unit is tied up, there's still other mental health calls coming in that the traditional response is taking on. So with that, I would be happy to answer any questions or discuss further the model that we have here.
Thank you, Sheriff Easter. Committee, are there questions? Representing Neighbor.
Thank you, Madam Chair, and thank you for your presentation today. I know in Shawnee and Johnson County, we have a CIT program, which you have a mental health worker go with the officer, and you might have an ENT, but at least 2 of them are there on each call. In our situation, we take names. Families can call into the police station and say that they have a relative in their home that has a mental illness. And so if a call comes from that home, they know automatically to send a team out there to de-escalate the situation. Do you have that in your area?
So what we call that is flagging. And so, yes, we can flag a residence if they have an individual that has mental health issues. When you talk about CIT, CIT training for officers, all officers here are trained in CIT. An actual team that goes out is only this team. So when we get other mental health calls, we don't have other, it's mainly the CommCare workers that respond with us. It's not a co-responder situation that we have here. And, you know, we have either EMS and fire will arrive with us to handle the mental health call if the ICT team is not available.
One more question, Madam Chair. Thank you. So since you had 111 of your 207 calls that were not mental health issues, would it be better to have, not to have to send all three on a call?
Okay, I might have, well, so the 111 is
Right.
if they had previous, they were mental health calls, but it was if they had previous contact with any type of mental health services. So the 111 were brand new people having mental health crises that needed this team's assistance. It
That
was
made more
not
sense.
a mental health call. The only calls these folks make is mental health.
Okay, that made more sense. I just either wrote it down wrong or didn't understand, but anyway, I appreciate that. But thank you, Madam Chair.
Senator Hawk.
Thank you, Madam Chair, and thanks for starting this program. On your ICT teams, have you found that there's a particular time of the day that you make more calls than other times? And
yes,
would that affect how you might be able to increase the number of teams that you have available?
Yeah, we studied that, and especially during the pilot project. And the peak times are traditionally second shift hours till about 1 or 2 in the morning. And it usually is between like a Tuesday and a Friday. And then we get some peak times on Saturday itself. And so, yes, we studied that, and that's where this team, that's what their hours are set at, is also during those peak time call loads.
So they're not functioning 24/7 then?
No, they're only functioning 5 days a week during those peak times, and it's mainly second, partly into third shift hours.
Gotcha. Thank you. Thank you, Madam Chair.
Well, and the majority of that problem with that, Sheriff Easter, is not having the finances to have 7 days a week, 24/7, right? I guess
Correct.
24/7 would
You
be.
know, all three of the entities that are involved, those were not new positions that they were given to do this. They had to take existing resources. And so that's how it's funded currently. You know, we're looking at different models on how we could add personnel. But again, the problem is we can designate personnel, more personnel, additional personnel, I should say, new personnel to our chart, our employee chart. However, EMS is very short and CommCare is very short. So even if you added to the personnel chart, they would still have a hard time filling those positions until they can fill some of the other 145 openings that they have.
Right, and I think what we're going to face is when 988 comes online July 16 next year, we're not going to have a choice. We're required for anyone that calls that 988 number to have services readily available, period. No ands, ifs, or buts about it. So hopefully we can, sit down with you folks and figure out how the ICT team that we currently have works in conjunction, because I know there's been concern with some community members that we would come in and replace, and that would not be the intent. It's how do we all work together with this, because we know that there's other areas around the state that have similar programs.
Yes, and you know, talking with other areas of the state, and I see on your next item at 3:30 is discussion on workforce issues. that needs to be a very extensive, serious discussion. Because you can mandate all this stuff, but if there's not the personnel, it can take place, but it might be 2 hours, 3 hours after the incident, if there's no personnel to respond to it.
Right, Representative Ballard.
Thank you. I would just comment on when we got the notice that 785, anyone within 785 or 620 would have to call all 10 numbers. And we started that October the 24th, so we just couldn't call. So now if you just do 7, your call will not go through. So it affects 785, 620, that you have to dial all of them. And that is getting them in the habit of freeing so that you have more room or space or whatever for 988, and so we've started going through now, preparing to make sure we're ready. So that is really interesting.
It's going to be a learning curve. We've had several discussions prior to this. The roundtable discussion is on the workforce issues. We just had presentations, and I don't know how much of that you got to listen to from several people, some of them from different states, on how to address it, because we're not unique in what's happening. Everywhere in healthcare, we're short. And are you short on officers? Is that an issue also that's out there or not?
Yes, Wichita Police Department is short on officers. I'm a little bit short on deputies out in the field, but we're 90 detention deputies down, which is more than an entire shift. So all of us are facing kind of the same issues in public safety, where we just don't have the amount of people applying anymore, and we have folks that are leaving the profession.
That's kind of what we're seeing on our side. Representative Arnberger and then Representative Neighbor.
Thank you, Madam Chair. Sheriff Easter, could you provide how much it costs a year for you guys to provide this service?
Yes, who would I need to send that? Because it would basically be salaries of the 3 individuals, and then just the vehicle expense. So who would you like for me to send that to?
I believe you would send that to Rida Orr, who's the person that's been contacting your office, Sheriff.
Rida, yeah.
I'm just curious on, if we're going to have this model be utilized throughout the state, and this is a heavily utilized county, how much we're looking at cost-wise. So,
Representative Neighbor.
Thank you, Madam Chair. There are certain requirements or guidelines for response times for EMTs and things. I used to work for the fire department, so it was within a certain amount of minutes, because if they had a heart attack after a certain amount of time, you're not really doing much for the patient at that point. Are there going to be guidelines set federally or anywhere that says how much time it has to be? Because if we're talking about an hour getting to someone in a rural district, that's something we might have to look at. But I know usually response times are, 4 to 7 minutes in that time frame. So I don't know if that would be something that we would have to consider.
I don't know that we would have to, because it's kind of, if we just operated the way we had for many, many years, it would have just been an officer going out to that call and then trying to decide how to deal with that individual. So what Andy and his department has lined up to make up these mobile crisis units, I don't know that has been defined yet, but something to bring up.
Thank you, Madam Chair, and thank you, sir.
Any further
The only thing I would
questions?
mention above and beyond that is in your larger jurisdictions, you can have more than one mental health crisis call taking place at that exact time. We have that a lot here. And this one team is only responding to one. And so I don't know how that fits into what you all have been discussing with 988 and mandatory that folks come out and those type of things. I can tell you in Sedgwick County, we've had mobile crisis units in the 90s, and same thing happened. They might be out on one call, and then they're out of commission for the next 3 or 4 hours. And so unless you have 24-hour service in the larger jurisdictions when it comes to mental health care, I don't know exactly how that would work, other than yeah, you'll have somebody show up, but that's going to be law enforcement like traditionally is done now.
Senator Fagg?
Thank you, Madam Chairman. Last night on the 10 o'clock news, Sheriff Easter, they was talking about mental health and looking for more funding. Was this what they were talking about? And if so, how much more are we looking for, are you looking for, and how will the funds be used?
Well, that's completely separate, sir. That has to do with the Mental Health and Substance Abuse Coalition that's here.
Okay.
And I'd be more than happy
I
to
just
talk
want-
to you on that offline.
No.
Yeah.
I just wondered if it related to it. I just got the ending, so, okay.
Well, and I think anytime we're, in any of these issues that we're dealing with here, funding's going to always be an issue, and your largest expense is having the personnel. If you remember the numbers that Kyle gave of how many PRTF beds that we have set and vacant, and the only reason they're vacant, they're open. There's no one to man those. Yeah. Are there any further questions? Do we have anyone online? Sheriff Easter, I want to thank you very much for taking time out of your day. I know that all of our law enforcement people are very busy across the state, and it's hard to grab your attention, but we do appreciate this and the efforts that you've put in to raise mental health issues in Wichita as well as across the state. So thank you very much.
Thank you, ma'am, and thank you, committee.
All right. Roundtable discussion on workforce issues. Are we good? Computer, well, you can't have a computer down. Do we need another power supply or just a plug? You know, Carrie, while we're waiting on them, I thought maybe, I love the way that you handle and facilitate things. If you want to help us through this roundtable discussion, I think the things that are going to be important for us to hear about and talk about is, how creative do the experts that are out here in the field, the experts that understand the education that's required to be licensed to do the jobs that they do, how do we change this to get it into, how do we get our entry level to a point to where we can start maybe attracting some younger people and get them interested in it, but they would maybe be able to relieve a little bit of the load from those that are already licensed or certified, whatever their credentialing might be. So why don't we do this for them to get, so everybody online, if you hold up, we're gonna break for about 5 minutes so we can deal with this issue. So if anybody needs to step somewhere, get up and stretch, go ahead and do so. And then we'll go into our roundtable discussion.
The minutes first.
Okay, real quick, committee, we're going to go ahead and reconvene before I forget it, and because I've got a pushy person over here that thinks she's now my vice chair. Is there a motion to? I was headed for you in a minute. Is there a motion to approve the September 28th minutes? Representative Arnberger, seconded by Representative Ballard. All in favor, aye. Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Done. Okay, now we're going to get into a roundtable discussion on workforce issues. So, Carrie, if you want to start things off, and let's see where we go from there.
You bet. Carrie Ruffett with KHI. Thank you, Madam Chair. And thank you to all those who presented and those who asked really good questions in the presentation about the workforce issues. And one thing we've discovered in the facilitation this year and last year with the working groups for this special committee is that workforce, while it was a specific topic area, it's an issue that actually cuts across almost every topic that each of the working groups is looking at. So thank you for providing an opportunity for the whole special committee and all of the members of the roundtable to be able to participate in that, because that will really help the working group that does have the workforce recommendations develop those for this year's report. As Madam Chair said before the short break, I think the idea here is to talk about ideas, right? So what particularly did you hear in the presentations today, or just in your other work with constituents and others, that you would want the working group to potentially consider adding to the recommendations, or if you just want to throw out there on the table for people to be thinking about? And then if there are key themes that you would encourage the working group to incorporate into the report, even if it may not be specifically a recommendation, is there important context that you would want? To help you think about that, I want to read real quickly the recommendation from the 2020 report that was on the workforce investment plan. And there's several workforce recommendations, 5 that were high priority recommendations, I believe, 5 or 6. This is 1.4, so I apologize for reading it if you have it in front of you, but probably not everyone does. And that was: the state of Kansas should make a long-term investment plan for the behavioral health system workforce by increasing funding for training, recruitment, retention, and support to effectively attract and retain high-quality staff. And then it also said specific steps include develop a career ladder for clinicians, such as through the development of an associate's level practitioner role, and take action to increase workforce diversity, including diversity related to race, ethnicity, LGBTQ, and the ability to work with those with limited English proficiency. And then the rationale for the recommendation last year was that Kansas is struggling to maintain an adequate behavioral health workforce across the state, particularly as surrounding states recruit Kansas clinicians. Does this sound familiar from what you heard today? Working group members discussed the importance of utilizing a grow your own approach, increasing reimbursement and salaries, financing provider education and training, and promoting entry into the behavioral health workforce in young students. Also what we heard about today, including from the folks from Nebraska. Additionally, a modernized workforce should include a diverse group of practitioners to better serve an increasingly diverse Kansas population. An adequate workforce is key to ensuring access to services in the behavioral health system. So that was the context last year, very similar to what you heard about today, but I like what the chair said earlier in one of the working group updates. It's last year we had really great recommendations, but now there's some opportunity to get in the weeds. And so this is a chance for you all to get in the weeds and help point the working group, the Services and Workforce Working Group, in the direction of which particular weeds you want them to be thinking about between now and December 2nd. So I'll stop talking and just get thoughts from the group. Is there something you heard about today in the presentations that you really think we could build on that recommendation we just read, or potentially a new idea that you'd like to see the working group at least consider?
And this would include anyone that's out there online. This isn't just to legislators, anyone that wants to participate. And for those of you that can, because I know that there's some limitations sometimes on mobile devices, to raise your hand for WebEx, then you may have to interrupt us. But Representative Arnberger is going to watch for the raising of the hand. So don't everybody speak at once, and don't be bashful, because this isn't the time to do that. Representative Neighbor, and then Representative Arnberger.
Thank you, Madam Chair. I thought it was interesting, the presenter from Nebraska on some of the ways that they've looked to bring more people on board and the success that they've had. Let me look at my notes here. Doing the high school internships, maybe paying for CEs for people as they make their advancement, because social workers really have to have a master's degree to be able to do more of the things that are needed. And, you know, retention and could be worked with more mentorships so that people have people to bounce things off. I know new teachers usually have a mentor for at least 3 years, and we hope they stay those 3 years, because usually after that they will stay if they're going to stay in education. So that mentorship program sounds extremely good and helpful, especially the first year or two when they're out in the community. So I was pleased with that.
Representative Arnberger.
Thank you, Madam Chair. And to kind of piggyback off of what Representative Neighbor said, so the Department of Commerce has a director of internships and apprenticeships. And so I am curious, could we partner with them to fulfill those needs and get interns and apprenticeships, everything going on that standpoint? But the other thing I'm curious on, and it's not necessarily just a Kyle question, because I typically go to Kyle for everything on mental health, but to kind of broaden to all of the industries involved, are some of these educational requirements too high? Do you have to have a master's to do this? Do you have to have, can we create certificate programs, so forth? So I'm just kind of curious on education. I know we want the best of the best, but just because you have a piece of paper doesn't mean that you are the best of the best. There's people that work just as hard, or maybe know things from working in the industry in different areas. So,
Kyle?
Thank you, Madam Chair and Representative. I certainly won't be shy about volunteering a different work group for more work. I'm sure that Dr. Warrens and Charlie and Shane would appreciate that. But I think that one of the things that, to answer Representative Arnberger's question, I think that we're right sizing a lot of our requirements, and certainly this would be a good question for maybe some of the BSRB members, or for David Fye specifically, about where we rank there, because I think that we had higher than normal requirements, or were extremely high in some of the things we looked at doing last year. So I think that's absolutely worth looking at again. One of the things that I heard, and I have actually talked to my counterpart in Nebraska about that part of the Beacon initiative relating to some of the high school interaction and outreach. And just thinking about this recently, I know that things like public speaking, English comp, and government, American history, calc, all of those things are offered for course credit, college course credit in most high schools. And I went to a smaller rural high school, and psychology was a class. So what would have prevented me from taking psychology or a social work class or sociology for a dual credit? So those dual credit courses are a big deal going forward. I think not just because it expedites the college entry, but it also gives you that initial exposure to a career that you might not have otherwise thought about. You hear a lot of kids talking about being bankers or farmers or in finance or lawyers or so on and so forth. But you don't hear an awful lot of them right out of the gate talking about wanting to be social workers or psychologists. So I think that is something that would be interesting.
Representative Lynn?
Thank you, Madam Chair. I was really fascinated with her testimony as well, so I'd love to see more, since we didn't get any paperwork from her. I would love to see more of a plan of how they did that. And I thought it was really fascinating that they said the way to get those rural providers is to train them in the rural areas to begin with. So however we can facilitate doing that, I think would be a good thing to try.
Well, we know something like that works, as we see it a lot with, because a lot of the physicians out of the KU Medical School in Wichita go to rural areas, and then a lot of them stay there. I think it's like, the last time I checked, and it's been just a few years, is a little over 50% of them stay. I'm going to do Representative Ballard, and then I'll come to Representative Shue.
Thank you, Mr. Chairman. Yes, and I would comment on that because of the, I can't even think of it, but the internship, after they finish, that was one of the conditions, you know, that we pay all of their medical expenses for them to go to a rural area and spend their time giving back. And what we have found is that they go out there and they don't leave, they stay. So, you know, that program works. Has two other things. But the other thing I want to talk about that I want to look at is this paternal and health care. Improve the health of children by reducing the number of uninsured children. And if we talk about that issue, and I think it's in this report that we got, I think we have to look in terms of what else are we doing? We started off really big, and I think it's sort of like sizzle out a little bit of why do we have 9,000 fewer Kansas children that have health coverage? And we know if they're not covered early, they're going to have more difficult problems as they go along, and we're not catching it. So that's one I'd like for us to highlight and think in terms of what other networks can we work with in the state in order to get more children to have health coverage. And there was something else I thought, but I forgot. If I remember, I'll bring it up.
Okay, we'll bring it back. Representative Shue, and then we have Kyle Kessler has his hand raised online.
Thank you, Madam Chair. Been quiet today. My overall question, especially for the subject matter experts, is the trend of not being able to find enough employees and behavioral health professionals separate than the larger trend that we see in Kansas of not being able to attract young talent to come here while the young talent that is here continues to move away?
Is there anyone online that would like to answer that, or we just let Carrie take that question back to the work group?
I could speak to Compass's issues. They are not leaving our community. They are simply taking other positions.
Wow, that's a big switch, I think, from what we've heard on some things. Okay. Kyle Kessler, and then I'll come to Senator Hawk.
Thank you, Madam Chair. I was just going to piggyback on what was mentioned by Representative Armberger and Representative Neighbor about the rural residency piece. Potentially, I believe KU and Dr. Gabriele, who's the director out of the Kansas City side of psychiatry, they were looking at a potential rural residency program for psychiatry. And so that would be something potentially to ask them to visit with the committee about, to see if there are any resources or statutory changes that they would need to make that happen, because I do think that absolutely holds a lot of promise, but you have to get it started in order to start seeing some benefits from that after a couple of years.
All right, Senator Hawk.
I think I heard this from Andy, or maybe he hinted at it, when we talked about the difference in salaries between people, particularly on our border communities, of maybe $10,000 difference. And we talked about potentially using the ARPA funds or the SPARK funds, and that would not cause us potentially a budget neutrality problem, but it could raise the wages that we have, and then that in turn would raise our Medicaid funds, our federal funds. We'd still have to do a state match, but at a smaller percent. what is it, 66 versus 34%. And there's even some things you can do that give you 85%. So my question is, I think the group ought to look at the budget numbers, and that could be a short-term thing we could do that could address the crisis we're in right now. Because if people can make $10,000 more by jumping either into private practice, as the previous speaker said, or going across the border, that becomes an intractable problem if we don't compete. And the other thing I'd like the group to look at is, why is there a 10,000? What are they doing differently? Because I suspect, I heard, if I'm right, 75% of our community mental health revenue is still Medicaid dollars. And I would guess that's not different in Missouri or Oklahoma. So if that's the case, what is it they're doing differently so that there's that big a differential? And we have to address that economic reality, I think.
The big difference right now is that Missouri jumped on board early on when the CCBHC was opened to states. Kansas did not. Oklahoma jumped on. So that's why I say when you look, if you look at a map, and we can have staff get that map for our members, you'll see that eastern border of Kansas is loaded with CCBHCs on the Missouri side, because they receive cost, just like what our FQHCs do. They receive cost. They don't receive a regular Medicaid rate. That's what will enhance the revenue with our CCBHCs and allow them to have money to actually pay for more salaries.
And that's true on the border thing, but maybe not true for the people going into private practice. So when we have, was it Southwest Kansas speaker that we had, and who was just on, who mentioned that they're losing people and they're not leaving the community. My guess is they're going into the same line of work or something else. And maybe it's burnout, but maybe it's a salary differential. So.
Well, some of it will have to do with, because you've got, obviously let's use Sedgwick County as an example with ComCare. And that's our CMHC right now that will work towards our CCBHC. Obviously, that border issue is not there for us, but because they can't pay enough, then we have the school districts hiring them, and then we have those that are going into private practice or going to work for other facilities because they can pay more or even give better hours. And, people forget that our CMHCs have to function like an ER. They have to have certain services available 24/7, and they serve everyone regardless of the ability to pay, and they can't turn you away. So we're hoping that the CCBHC designation helps to improve a lot of that. Is it going to solve all of it? We don't know until we get there.
How long is it going to take us to see a significant difference in the money that's available to provide to providers?
It takes 2 years, and I think Andy can jump in on this, so stop me if I speak out of turn. It takes 2 years for them to get that designation, and Fort County is the only one that by this time next year will be a full CCBHC. Is that correct?
So, not exactly.
Okay, see, that's why I need it, because that look on your face was like, yeah, you're not headed where I need you to go. Okay.
So right now we have 12 CMHCs that have indicated that they are interested in becoming CCBHCs by the end of this year, meaning state fiscal year. And KDHE and KDADS are working very quickly in order to try to make sure that we're able to start certifying them beginning in May. When they go through that certification process, they will be able to submit a cost report that's based on their projected expenses for the following year. So there will be a almost immediate financial benefit for those that are able to meet certification requirements because they'll be able to build those projected costs into their PPS rate for the first year. It will take us approximately 3 years to get all of the CCBHCs or all the CMHCs to CCBHC status. But I think we'll see an immediate benefit next year.
And the reason for that is we're phasing them in because to bring them all online, the fiscal note was not manageable at the time we were working that budget, so.
This is Senator McGinn. Can you hear me?
Yes, go ahead,
I'm
Senator.
sorry. This is former Vice Chair McGinn.
No, I'm not letting her take your title.
Okay, all right. Sorry, I've been driving. I'm parked right now, but I couldn't find my chat button or raise the hand. I kind of want to go back to a little bit about what Carrie talked about, and then listening to this whole conversation about how some of these individuals are leaving to pursue other careers. And so I think about clinician pay. The privates certainly, pay what they can and how and through all the different means. But we also have state clinicians. And I'd be curious, looking at surrounding states, and we could have that in our paperwork, but I can't go through it right now. But I'd like to kind of know before our next meeting how we compare, and maybe you already know, if we are lower at paying some of our clinicians, whether they're state or private. I think about last year how, we some of us tried to increase the state employee pay, and it's only 2% generally, and that didn't happen. And about 15 years ago, we did a parity study about the different positions our state employees have. So my question is, Madam Chair, is more of what do we look like to surrounding states? And I know we've had the conversation about some of them have Medicaid and that makes it different, but I'm clearly looking at clinician pay as to their licensing position that they hold.
I think that's an excellent question.
Is my microphone working by chance?
Yes?
Thank you. This is Greg Hennon with Four County Mental Health Center. Sorry, I was having technical difficulty earlier, but I might be able to just share a little bit. We're one of those centers that borders on Oklahoma, and Oklahoma, as a CCBHC state, has been actively recruiting our therapists and our case managers over the last year and a half. And what we found is that, say an example, one of our master's level therapists that had been with us for 17 years, worked as a middle manager in our organization, was making just a little bit over $50,000. And she went to Grand Lake Mental Health as a line level therapist, no administrative responsibilities whatsoever, and was making just over $70,000 for that same credential 30 miles south of us. So I lost a mid-level manager over a $20,000 difference. And you think percentage-wise, that's a pretty steep difference on a $50,000 salary. Making things worse is this individual, as a supervisor in our organization, knew who all the best case managers were, and guess who she recruited to be on her team down in Oklahoma. So I lost 3 case managers with a differential of $15,000 a year in their salaries. And last week lost another case manager. So I probably lost half a dozen or 8 professionals over the state line in the last year and a half. And that's the gap that we're seeing right now.
Representative Ballard.
Thank you. And I'm going to add something else a little bit when we were talking about it. We tried, because we were on the same working committee last year, we reduced the supervision hours. Remember, we went from 4,000 to 3,000, and that was to keep them there longer, and they wouldn't have to put in all those additional hours. So there were things we were working on, trying to keep people here. And that's a recommendation I would make, that we look at those discrepancies again, like we changed from 4,000 to 3,000. What other kind of things would you recommend that we continue to look at that would make it easier for us to hire people, on top of we need more money so you can keep your staff?
Well, and sometimes it's not always in the credentialing so much. It's like, do we need a new entry level position that could get there, say, with a 2-year program and, internship, involved somewhere along the line. Then they decide that, hey, I kind of like this. Then they go on to, and then perhaps the organization they went to work for might be inclined to kind of help them a little bit to gain that next upper level to go above the entry level as well. So
Well, I have to ask him, I mean, did you have any leeway at all that you could get more money to try and entice any of those people to stay with you?
Greg, we can't hear you again. Nope. Okay, keep working on it, Greg, and we'll come back to you, okay? Let us know when you're back in. All right, next, I've got a couple people online here, and then I'll come back to the room. I've got Rennie Schuler-McKinney, and then I'll have Will Warrens, and then I'll go back to Representative Neighbor. So, Rennie, are you available?
Yes. Thank you, Madam Chair. I probably have 50 comments. I'll try to keep it very limited. I love that we passed the reduction from 4,000 hours down to 3,000. I had 2 individual staff members. Oh, I should have said I'm with Advent Health, Shawnee Mission, inpatient psychiatric program here in Kansas City. And I had 2 folks in that 3,000 and 4,000 hours. So they were excited. They got their advanced license and then they quickly exited to go to private practice. So although a great thing, it ended up kind of having a reverse effect on my team. I have about 50 licensed therapists. One thing that I have worked on is that clinical ladder that we've heard mentioned many times today. We have it at the very entry level, at the entry bachelor's level, but we also have reduced down tech positions where you don't have to have a bachelor's, you can have a 2-year degree. That has helped. We are seeing some exit with their bachelor's degree to go work at these companies, warehouses that surround Kansas City that deliver packages to homes where they're making equal amount of money or more. And we're just not able to compete with that. And the folks that are getting their bachelor's degree, I don't know if any of you guys have a kid in college, but I know Kyle and I do, it's not cheap. And they're getting out of school and can't pay back these loans. And so they're motivated to go elsewhere and get these jobs. The other thing that I think has helped our workforce, even though I have a lot of openings right now, is I'm not just thinking masters in social work. I'm expanding that, thinking about the other, I believe, 4 degrees through the BSRB or licenses through the BSRB. And then each of those 4 have an advanced license for LCPs, LCPCs, LCMFTs, et cetera. And so I'm hiring those folks in at a higher level than I ever have in the past. I continue to struggle with losing, as everyone has spoken about today, back to the school systems. And we sure know the schools need a lot of help for the behavioral health needs within the districts, but I can't compete against no holidays, no weekends, et cetera. I also am challenged with the competition with telehealth, being able to sit in your own home office and doing telehealth. I do sit on the work group for telehealth, and I'm very much an advocate for it, but it's a strong competitor. And then my final comment would just be around, and I don't know the answer to this, is the higher education universities here in Kansas, could they possibly expand the number of individuals they take into their master's program? Have a niece of mine, 4.0 high school student, 4.0 college student, graduated and could not get into a master's program or a doctoral program in the state of Kansas. And she was the president of her sorority. We're telling, obviously I love her, but a go-getter. And so she's in Oklahoma now. And I'm afraid she's going to like it there and stay there once she graduates with her master's. So is there an opportunity to expand how many we're admitting into our programs here in Kansas? Thank you very much.
All right, then Dr. Warrens, and then we'll go to Representative Neighbor.
Yeah, thank you, Madam Chair. This is following up on Representative Shu's question about, is there something specific to Kansas in this workforce shortage? And one of the reasons when I went to work at the Guidance Center up in Northeast Kansas, CMHC, I had Keith Rickard come and talk to the committee in 2020. And so he gave some testimony about how some of the underfunding of the entire system of the CMHC system, you know, you think to yourself, well, you know, if someone has a bad financial manager or can run a single CMHC into the ground, I mean, I guess that's possible, but why would 26, all of us, you know, through the course of a decade start having increasing financial problems? And so he was trying to point out to us just the fact that, you know, between in 2007 to 2013, we made the shift away from state grant funding for the CMHCs. That made a pretty delicate balance on Medicaid dollars. But then, of course, what happened right after 2013 is more aggressive management of Medicaid dollars. So decreased state grant funding, then increased management of Medicaid dollars, and in the course of all of this, a rising uninsured population. Those macroeconomic factors are pretty powerful for the CMHC system, and I think has left them in a situation right now where they're kind of gasping for air. I don't mean to bring this up to be pessimistic, because right now at this exact time in 2021, we've got CCBHCs coming, and so we have a new funding system, and so I think this is why everyone's so excited about it. But not all the struggles in Kansas have to do with COVID and have to do with the national struggles that are going on, you know, in all the different states. Some are unique to Kansas.
Right, Representative Neighbor.
Thank you, Madam Chair. I guess a couple of things to think about too is when a doctor goes into private practice, they have the startup costs, they have to have an office, they have staff, and if you're doing it on your own, your accountant, everybody else is in there too. So it's a much, much larger expense, and we have a lot of people, doctors that are entering groups that can absorb this kind of cost, or are working with a group associated with a hospital that brings them in and puts them on staff. So sometimes I think it has to do with the ability to have that kind of funding, and it is not cheap. The reason I know that is my daughter is a doctor. She did her preceptorship in Oakley. They have a country club and they had a Pizza Hut. That's all they have there. So I don't know if these students and the community could come together and have a group that helps them find a location, offers them a building that may be empty, or can work with a group to reduce some of those costs as an encouragement. So it's a partnership between the community and the physician going in. So that was one thought. And then I've talked with several businesses and people at home too, and they are not leaving. Since COVID has come, they can get paid more somewhere else. And they'll stay in our communities. They're not leaving, but they're finding higher paying jobs. And this is just the opportunity of the day. They can look for something that they like better or doesn't have the exhaustion level of a nurse. And I praise nurses and doctors, it's not an issue. But they can find something that equates to more family time, or they can work from home, and it's the convenience. So I think there's a lot of things that we're competing against that we weren't competing against before, but we are now, just because it's the time. And I think it may change back, but I don't know if some of those things would work with the public-private finding buildings that would be available so that small towns could recruit. And we also have to make sure that we have the tools that are necessary there for them to function, such as broadband. So I think there's a lot of things to consider when we want to bring people to rural areas. And it takes all of us, it takes a village to bring that on board. Just food for thought.
I've definitely eaten at that Pizza Hut. Being from Western Kansas.
Representative Arnberger.
Thank you, Madam Chair. Another thing Oakley has is the Armberger families from there. So I have been to Oakley numerous times.
So you know they have great things.
Yes, they have, and their golf course is a easy 9-hole golf course. Country club, sorry, country club. Something I'm curious on is, you know, the number one thing a lot of us are talking about right now outside of this is inflation. So how much is inflation gonna play a part in the salaries? So I don't know if it's too soon to even start looking into that, or if there's some articles or data or previous situations, but.
Did you have something, Andy, you wanted to add to this?
You know what, I was just gonna say that I think you're kind of onto something there, right? So like, earlier you were talking about like, what can we do around the kind of the lower level licensure or maybe a certification or something like that. And I think there's a connection between that and the Promise Act that was passed last session. And I think the Board of Regents has been looking at how we might be able to do a different level of credit hours on transfer into universities that are four-year universities. And I think when you start to pull all of that together, it does kind of address that. But I think it's one of those things where it's a big puzzle, and it's going to take a lot of pieces being put together to make it all work.
Further questions or comments on this discussion time here, folks? Representing Lynn.
Thank you, Madam Chair. One of the other things that she mentioned from Nebraska was about the recruitment in high school. And I think we've got such a huge groundswell of support when you're talking about Zero Reasons Why and all the other things that are happening in those high schools. I think that is a pool of people that we can go to and encourage them to find careers in helping people. Those high school students, those middle school students are so passionate about taking care of each other, and I think we can use that. So thank you, Madam.
You know, Andy, something I was thinking about as I was listening, you know, through this process today is several years ago, and Representative Ballard was my partner in crime, where kids that age out of foster care can get a free ride. Mm-hmm. And at the time, for 2 or 3 years, we had some of them come back and talk to us and how it was going. And so many of them were going into social work. Do we know what's happening with that today? What's going on with that? I'm not sure I like that look on your face.
Yeah, I don't know the answer to the question.
Oh, okay. That's the only reason you gave me that. Okay,
yeah.
That's okay.
Yeah.
Well, I think that's something that we need to look into, because what I recall in those discussions with those young people was they understood the system. They understood what a lot of these kids were dealing with because they lived it. And I remember many a times, because I was chairing the committee, but Representative Ballard would go down there because they would struggle telling their stories. So, you know, maybe that's another piece that we're missing, because we don't necessarily give them the encouragement. I think we see that somewhat with
Peer sport.
KJAG or JAG-K. There we go.
Huh? Representative Landwehr?
It's our JAG program, K.
Yeah.
JAG-K.
Representative Landwehr?
Yes.
I'd like to add something to that. Case for Networking, my organization, we work closely with Gear Up out of Wichita State. And they, Gear Up sponsors, foster kids to go to high school, has the only grant just focused on foster kids. Gear Up would have data, I could get that for you, on the number of kids, and Gear Up follows kids from high school through college. Gear Up would have probably a lot of that information that you're talking about how many kids really do go into social work or what they do go into.
Well, if you could help facilitate that, Jane, that would be very much appreciated.
Okay,
And
I
then
can
just
do
go
that.
back to Arida and make sure that she gets the information. So thank you.
Okay, I know the director, Corey Nielsen, would be love to talk to this group about
Okay.
that.
All right.
I wanted to bring up something maybe a little bit different, is that I think it was Lynn that said, you know, we could teach high school kids. I think if we could, I only know the side about where consumers and parents live in this system. But so many times, parents especially, and youth, they don't necessarily, parents need often training, a lot of training, intensive training to deal with very difficult children who have emotional behavior problems. That training, and it would be the same training that they could need to then become employees to provide that training to other parents. And I don't think it seems like we don't focus enough on growing up within ourselves and using our own, not using them, but accessing our own customers who we're training and teaching to manage and cope and have, you know, self-help skills, both for adult consumers and the parent kind of, and youth kids. And so I'd like to see us do a lot more work, because I agree with whoever said, you know, training people who already live in the community increases the likelihood they'll stay there. And so I just wanted to call that out, that I think we're missing an opportunity to grow within our client base, to become providers.
No, I think that makes perfect sense, because many, many times we leave out the consumer side of this, of the things that we discuss in the healthcare or behavioral health field. So good point. Further comments, questions, committee, for her to take back? Is anyone on? We don't see anyone else online, so Carrie, if you'd like to wrap us up.
Well, thank you very much. This is very helpful, thought-provoking as well. I had written down a few things. I thought, well, just in case sometimes you come up at the end of a meeting in the afternoon and ask the question, everybody sort of stares at you. So I'd written down a few themes that we might be able to help. You guys burned through that in like the first 2 comments that everybody covered. So you really went deep, and so we really appreciate that. So the next meeting again of the various working groups is December 2nd. Those of you who are on working groups, and all your legislators as well as folks on the roundtable are, you are all getting various versions of surveys, and we know there can be sort of survey fatigue. We're trying as much as possible to use like radio buttons where you can just say yes, no, or just click one or the other. But a few things like this, when we're starting to talk about workforce, we do probably need us to have some language to be thinking about so that we are ready for a really tight, concise conversation on December 2nd, then to prepare for the meetings of the special committee just the next week. So look forward to that. I appreciate all these comments. If anybody has other follow-up questions or ideas, feel free to reach out. You can email me. I think everybody has our email address, or if you want to go through Arida, and she can send it to us as well. And then we'll make sure we'll be meeting with the co-chairs and figuring out the best way to get this information out to folks. Thanks for everybody who is on the working groups, that was on the round table. Hope you all took really good notes too, so we can have a great conversation in a few weeks.
All right, and I think also that probably another source we could use for the college and foster care would be DCF may have some of that data as well. So, Carrie, thank you very much. We appreciate your help here today.
Thank you.
Rita, well, I'll just go to Dave on this. He hasn't done anything today. Yeah, he signed his resignation letter.
Now you know how to get her attention.
No, you can't hire him, Barbara, forget it. The dates that this committee meets next is December 10th, is that right? December 10th, 15th, and 16th. Okay. So committee, what I'd like to see us do is, our goal is the 16 and 17? Is that right? 15, 16. In December is if we can get the bulk of everything that we need to get compiled into this report done, get a lot of it done on the 10th. The goal would be to make the 15, 16 to only be one day, to be the 15th, to try to get things done. So just kind of keep in mind as you're working with some of these working groups and anything that you want to see brought into the report, because what we'll do is we'll start on the morning of the 15th of just narrowing down what do we want in our committee report that we send forward to the full legislature. Any questions on that? Okay, great. One thing I think staff, if I got my notes correct, is we probably need to forward to Senator Hildebrand, Chair of CanCare Oversight, the potential language that's coming that way for the post-audit, which was the 1.2 on the presentation that I believe that was Dr. Warren's. Was that right? Yes. And then, because all of these things impact Medicaid. Then the methadone clinics, which was the 1.3 item. And discussion on the Medicaid postpartum, which was 4.4. Those were the numbers that were in his report. Was there anything that you recall that I may have missed that we talked about should be looked at maybe by CanCare? Nope, okay. Is there anything that the committee members recall that we talked about on Medicaid stuff that needed to be looked at by CanCare? Okay. So, you also have in your packet committee is and we just didn't go over this sheet, but it's a status report on the 988 suicide prevention hotlines from the different states, so that may be something you'd be interested to take a look at. And then, Rita, I believe you handed me, was it two reports from the revisers and KLRD, that one was from the revisers on the Healthcare Stabilization Fund Oversight Committee, and that goes through some of the bills and different things that they've got. And then we have the Telehealth Work Group of the Special Committee on Kansas Mental Health Modernization that came to us out of October. So those two things are also in your packet. Is that correct? Do they have those? Okay. That you may want to look at. We didn't figure we had to read everything to you. Also, in answer to Representative Lynn's comment earlier on Marley Doyle's testimony, it will be posted online later because it's coming to us. But it's always good for us to be reminded of those things because it's important for this stuff, being that we do work virtually for the bulk of our committee member. We forget that we have 30-plus ad hoc members out there assisting us with this at the same time, and many of them do monitor what we do on this committee. Doesn't mean they're always participating, but they're here. So we're adjourned until the 10th. You have a safe drive home because this is deer eating time.
Yes, it is.